Good morning, everyone. On Department of Pharmacology, I want to welcome all the online and offline participants. Today's workshop is on good clinical laboratory practice. Today's session is in association with Department of Biochemistry, Department of Pathology, and Department of Microbiology, MIdnapore Medical College and Hospital. You need to submit 3 links of Google form, one for the pre-test, one for the post-test, and feedback. After submitting these 3 links, we will send you the certificate after 25th of June for the online participants. We are celebrating the 5th year of GCP and GCLP workshop. And from 2025, we have added good clinical laboratory practice along with the good clinical research practice. So keyword link is provided in the group in offline and online groups. You need to submit it within 2 hours. As this session is a hybrid workshop, the session will be recorded. All the online participants' video will be switched off. If you want to ask any question, you can use the Q&A section of the Zoom. And we will be happy to answer your queries after end of each session. If anyone misses the lectures, these sessions will be uploaded in YouTube. The link is provided in the group. You can watch it later. We have total 10 topics, which is AI-based or AI integrated. Some slides and illustration or picture of the presentation may be AI generated. Content which are AI generated already checked by our esteemed faculty. So we are sharing the pre-test link also in the group and in the QR code. You need to submit it within 2 hours. Before 10:30, you need to submit the pre-test link.
Hello, check. Hello, hello, check. Hello, hello, check. Hello, check. Hello, hello, check. Hello, check. Hello, hello. ঠিক আছে?
Good morning, everybody. Welcome to you in our GCP and GCLP workshop series. Today is the second day for the GCLP. Welcome all the participants in offline and online platform. So this is our institutions, MIdnapore Medical College, a government medical college in West Bengal. But this program, GCLP and GCP, is very much popular. We have done so many footprint in various medical colleges. We are doing from the 2021, but successfully from the 2022 to this year. This is our fifth GCP and GCLP workshop. And the second, nearly 22 states was participate, and the third 21, again 422 this year. That is 15 states are participate in online and also in offline platform. If we go to the regional anchor points, then the maximum is in West Bengal. There are also Karnataka, Uttar Pradesh, Maharashtra, and Kerala, and also various other states. So Pan India overseas is showing the almost from Kashmir to Tamil Nadu, from Ahmedabad to Tripura. Every state there are some sort of participants involved in this online successful program. In the fifth workshop, this year we have success that some participants from the Ranchi, that is the Central Institute of Psychiatry, Himachal Pradesh, the AIIMS Bilaspur, GMC, Alwani are involved in this workshop. Welcome, all of you. The core pillar of this workshop is to safeguard the rights, data integrity, and global standard. Though everything is discussed in GCP platform, but the GCLP is always neglected. But the thing is that GCP and GCLP both are internally linked, because the most of the part of the laboratory works are done by our GCLP. So unless the quality of report is come to our setup for our patient, how can we do how the safety, how can we preserve the rights, and how we want the welcome of our participants. So the need is the safeguard to rights, data integrity, and the global standard. In the fourth workshop program evaluations, we have integrated this GCLP and our safety protocols focused on the mainly handling and diagnostic integrity and explained our essential document guidelines. We have some international connection also in the last years. There are from one participant from Malaysia also involved in our platform. The curriculum innovations has been done day by day. The ecosystems of the GCP ICH is evolving. The revision is going on almost in every year. So many amendment is coming day by day. So in this highly expanding and also mainly for our purpose is the safety. So GCLP and GCP is day by day more complicated. So unless we go with our evolutions, we can't give the right decision to our patients. So the vision of this GCP and GCLP 2026 is the AI in the clinical use. We are using the AI, but you don't think that this is actually is the AI. When we are typing in our message sections in our mobile, smart mobile, automatically what is in your mind is coming suddenly. We think this is a default. That is not default. It is AI. So many AI you are using in our clinical trial today also. So, but we are only focused on this AI part only. In focus with the global harmonizations and the advanced GCLP we will discuss today. Our learned faculty persons are coming and they will give the justice to the AI related GCLP today. So almost 350 medical institutions are attached in our program for last 2 to 3 years. So at the end, the excellence in clinical research is not a destination, but a continuous pursuit of truth, safety, and scientific integrity is our vision. If there is any questions, always welcome. And welcome to all of you in our today's AI-based GCLP. Thank you.
A very good morning to our delegates and PG students and other participants. So to begin the session, it is my privilege to introduce our first speaker, Professor Dr. Soma Gupta, HOD of Department of Biochemistry, MIdnapore Medical College and Hospital, a respected academician, clinician, and laboratory medicine expert. A respected academician, clinician, and laboratory medicine expert, Dr. Gupta has significantly contributed to medical education, quality laboratory practices. Today, she will discuss the evolving landscape of GCLP and the future of AI-enabled clinical laboratories. Please join me in welcoming Dr. Shoma Gupta, ma'am.
Good morning, respected delegates and dear organizers. At the outset, I'd like to thank the organizers for their tremendous effort to organize such a beautiful workshop. My topic is Principles, Ethics and Future of AI-enabled Clinical Laboratories, which I have organized in 5 sections. In the first section, I'd like to talk about introduction to GCLP, what and why. And then I'll give the introduction to principles of GCP in traditional laboratory and AI-enabled laboratory. Then some ethical consideration and ethical challenges. So, how many of you have attended yesterday's workshop, GCP? So, many of you have already attended GCP. So, you know what is GCP. It is an international ethical and scientific quality standard for designing, conducting, recording, and reporting trials that involve the participation of human subjects. And good laboratory practice is another nomenclature, which is a quality system concerned with the organizational process and the conditions under which non-clinical health and environmental safety studies were planned, performed, monitored, recorded, archived, and reported. Now, GCP and GLP, there is a gap because GLP is associated with non-clinical health. So there was a need to prepare a bridge between GCP and GLP. So good clinical laboratory practice came in this part, and it applies those principles established under GLP for data generation used in regulatory submission relevant to the analysis of samples from a clinical trial. That this is a international standard which is applied for clinical practice. So it is, we can say that behind every successful clinician, there is a successful laboratory practitioner. Now, once upon a time, laboratory was allotted the most dark and dingy places of the institute. If anybody has visited NRS Medical College, there is a room where Dr. UN Brahmachari worked for the UDS department, and you will be surprised to see the position of the lab. However, nowadays, the lab is allotted the most spacious place, and there are air-conditioned rooms. So this evolution has been possible because now laboratory has become complex. Initially, only some this microscope, some beakers, some pipettes. These were the laboratory instrument, but now it is quite machine sensitive, and there is rapidly changing technology. Huge variety of tests have been done in a time-bound manner. The labs have to comply some legal procedures and other statutory requirements. And for this, constant upgradation of skill and accreditation is necessary. The whole process made the laboratory a complex place. Moreover, all laboratories are not same. In India, the laboratory services are integrated with three-tier public health system like primary, secondary, and tertiary level. Besides this, there are some reference laboratory, some research laboratories, some specific disease reference laboratory to provide services for complex and special tests like molecular or genetic tests. All levels of laboratories follow biomedical and waste management guidelines, which is concerned with safe disposal of contaminated waste and safety of health workers and the community. As per NABL, the accreditation of laboratory system, the laboratory can be classified into 4 groups, like small size laboratory, which receives samples up to 100 patients per participants per day. Medium sized when the patient number is up to 400. Large sized when the patient number is up to 1,000 per day. And very large sized when the number of participants is more than 1,000. So with this diversity, this ICMR thought that some guidelines should be there, which will be used to standardize all these laboratories. So in 2008, it released the first GCLP guidelines, and then ICMR released the National Ethical Guidelines for Biomedical and Health Research involving human participants in 2017. Ministry of Health and Family Welfare, Government of India had notified new drugs and clinical trials in 2019, and revised guideline for good clinical laboratory practice came in 2021 to establish minimum criteria which should be followed by clinical and research laboratories involved in examining human samples in routine healthcare delivery and clinical research. So the question, why GCLP? What are the purposes? Number 1, to ensure quality, reliability, and integrity of study data. To ensure comparability of study data. Suppose we have seen that MBBS students are under stress and they have cortisol level more than if compared with the students of general college. Now these data must be comparable with Dr. Ram et al. Conducted the study in Delhi. If Lakshman et al. Conducted the study in Odisha, if Bharat et al. Conducts the study in Kerala, and if Shatrugna et al. Conducts the study in Gujarat. That is the comparability of the study data. To allow for reconstruction of the study, if I say that my device is will require only 1 drop of blood and not you need not to draw the blood from vein, then you have to reconstruct the thing so that the results are comparable. And 4th is to achieve uniformity of the performance of specific function across all laboratories worldwide. If I am diagnosed as hypothyroid here, I must be diagnosed hypothyroid elsewhere also if I remain untreated. Thus, GCLP compliance empowers clinical laboratories and clinical researchers to provide data or reports which are reliable and reproducible. In India, this supervision is done by NABL, which is National Accreditation Board for Testing and Calibration Laboratories, which is based on international standard ISO 15189 in 2022. This specifies requirements for competence and quality that are particular to medical laboratories. And laboratories should adhere to requisite national and state regulations as applicable. Now, yesterday, Dr. Hajra told us that GCP should be, why GCP is not renamed as GCRP because it is mostly related to research. But here, GCLP, here it is clearly said that these should follow wherein human samples are processed for diagnosis, patient care, disease control, and clinical research. So it is not only for research purpose, but also for patient care purpose in day-to-day practice. And departments are not these the departments which are involved under this, and it is not limited to microbiology and infectious disease, hematology and blood banking, molecular biology, molecular pathology, clinical biochemistry, histopathology, genetics, everything is under the scope of GCLP. So next come principles of GCLP. Management principle and ethical principle. We can divide into two heads. Now, management principle is, these 5 management principle is common for all. That is planning, organizing, staffing, directing, and coordinating. We have to plan where the instruments, which instruments to be purchased, where the instruments will be set up, and where the sink will be placed, where the waste material will be deposited, and we have to organize accordingly. Then we have to recruit the proper staff, direct them, and coordinate among them so the work is done properly. Now the elements of GCLP, we cannot do it as per our own choice. There is guideline by ICMR, and you can see I have given the contents in the right side. So all the elements of GCLP are given in proper way, elaborately by in this book. And these elements of GCLP are organization and personnel, facilities, equipment, material, reagents, standard operating procedures, planning, conduct, and reporting, quality control and quality audits, and retention of study records and reports. Now, everything will be discussed subsequently in today's workshop. Now, what happened? In 2024, FDA approved more than 500 AI or machine learning based medical devices. So, there was evolution of what happened. The basic framework needs to be evolved also because everything has been, the whole landscape was changing. So there was this GCLP2, which is a rigorous ethics first paradigm for governing AI-enabled clinical laboratories, where algorithm validation carries the same weight as chemical reagent calibration, and transparency, explainability, and patient safety remain non-negotiable. Thus, there is evolution of GCLP2 and there is evolution of AI-enabled laboratory. So to discuss further, let us have some basic definition for AI spectrum. First is artificial intelligence, where the machine can think or mimic the cognitive function, the same reasoning, problem solving, perception, and language comprehension. Then the machine learning, which is a subset of artificial intelligence, you can see the figure, which is a specific subset of AI, where algorithms learn statistical patterns directly from the data to make predictions or decisions without being explicitly programmed for every scenario. Then the next subset is deep learning, where the machine learning utilizes multi-layer artificial neural networks. And ultimately, there is generative AI, which refers to advanced models, which we are using like GPT, Claude, or Gemini. And this can create net new content, including text, images, diagnostic reports based on learned data patterns. So this is a slide which shows the comparability between traditional laboratory and AI-enabled laboratory workflow. So what is how to compare them? If we compare the pre-analytical aspect, the traditional laboratory uses manual sample sorting, visual inspection, where AI-enabled laboratory uses automated sorting and AI quality flagging. Then, so for analytical is concerned, it is operator-dependent interpretation, where AI is algorithm-assisted pattern recognition. For post-analytical, it is the manual result entry and verification, where in AI, it is auto-validation and predictive flagging. For QC, it is rule-based, it was rule-based Westgard rules, and now it is adaptive machine learning-based QC prediction. Reporting is template-based manual reports, where in AI-enabled laboratory, it is AI-generated narrative reports. Then turnaround time is 2 to 8 hours average for traditional laboratory, where it is 30 to 60 minutes with automation. And error rate, where there is 1 to 3% in human error in traditional laboratory, in AI-enabled laboratory, it has less than 0.5% with AI augmentation. So everybody is thinking that AI-enabled laboratory is definitely better when we are getting result in shorter time without much effort and it is more or less error-free, then why shouldn't we go for AI-enabled laboratory? But no, AI also has some limitation. And what is the limitation? There is bias. What are the sources of bias? There are training data bias. That is the training data of the AI, যেটা দিয়ে AI কে ট্রেন করা হচ্ছে সেই ডেটাতেই যদি bias থাকে, that is under representation of ethnic minorities, females or elderly. Level bias, 160 by 100 millimeter of mercury in a 60-year person. Now somebody is saying it is mild risk problem, and somebody is saying no, it is moderate risk. So this type of level bias is there. Then measurement bias. Different analyzer platforms produce non-harmonized reference values. Feedback loop bias, when this is a peculiar thing, when AI generates some wrong data and that wrong data is again applied, and thus the error rate increases and multiplies. And there are temporal bias, where models trained on historical data which is not reflecting current pathogen or disease patterns. So with these sources, AI also needs some regulatory network, and this is given by FDA, WHO, ISO, CAP and NABL, and GDPR and HIPAA. So these are some regulatory bodies which regulates the AI-enabled laboratories. However, the GCLP2 differs from traditional laboratory in two main aspects. The main thing is shift from the static quality control checkpoint to dynamic real-time model governance, which is given by regulatory scope expansion. Initially, the regulation was only for equipment, reagent, all these things, but GCLP2 extends this regulatory umbrella to encompass entire computational stack. And it governed animals now include data ingestion pipelines, that is machine learning model architecture, how the machine learning is done, software version control system, and automated decision support outputs. A laboratory software pipeline is subject to the same scrutiny as its physical infrastructure. And documentation, validation, auditory requirement apply equally to computer code as they do in chemical process. So everything with the expansion of the regulatory scope has been expanded. And second difference is active model oversight and drift monitoring. There is data drift due to change in statistical part, and there may be concept drift. That is, if some guideline is changed or if some unit has been changed, then that should be given as input so the model performance better good. Otherwise, the model performance degrades and the laboratory must detect, document and remediate the deviation before patient care is effective. Every software update retaining cycle and parameter change requires documented validation, mirroring the rigorous QC of chemical reagent. So this is the comparison of evolution of lab standards, legacy of GCLP2, legacy versus GCLP2, the control domain being data integrity, system validation, ethical safeguard, and personal training. Now come the ethical principles. Personnel working in clinical and or research laboratories should be aware of their ethical responsibilities, follow the basic and general ethical principles, and responsible for protecting the dignity, rights, safety, and well-being of the participants enrolled in the study. So these are the 12 ethical principles which yesterday Dr. Shuman Chattopadhyay, our NU coordinator, was telling about. That is principles of voluntariness, non-exploitation, social responsibility, ensuring privacy and confidentiality. It is very important. Principle of risk minimization, principle of professional competence, maximization of benefit, institutional arrangements, transparency and accountability, totality of responsibility, and principle of environmental protection. So suppose I have become very much excited because Julia Roberts has come to my laboratory to give blood. So I am telling everybody, so you know Julia Roberts today who came? Julia Roberts came. And I drew her blood. I was sitting beside her. And you know she is suffering from diabetes. So what I am doing? I am violating the privacy. I am violating the confidentiality because I am hyper excited. So this is definitely violation of ethical principles which we very commonly do. But AI has not decreased this. Rather, artificial intelligence has created some more bioethical challenges. What is that? AI is used for diagnostic part and predictive part. The diagnostic AI for underserved regions uses some geographic and demographic bias in training data set. Whereas predictive model, sometimes there is ethical issue is around data privacy and taking the consent. So the concern is, will we see robots or algorithms for medical malpractice? So there must be some clear guidelines. So let us see some cases. One case where AI autonomously reports a normal CBC differential. The attending physician relies on this without review, and a rare blast cell is missed. Patient is diagnosed 6 weeks later with acute myeloid leukemia. So the lesson from this is AI auto-validation must have human sign-off for morphological interpretation. Then the second case. An AI sepsis prediction model flags a resource-limited hospital patient as low risk. যেটা বলছিলাম 160-100 millimeter of mercury 60 বছর বয়স একটা টারশিয়ারি কেয়ার হসপিটালে এটা লো রিস্ক কিন্তু এটা একটা রিসোর্স লিমিটেড হসপিটালে এটা কিন্তু মডারেট রিস্ক. The model was trained on data from tertiary centers with different patient demographics and comorbidity pattern. So lesson is local validation and site-specific calibration are mandatory before deployment. Okay. And case 3, an AI company uses de-identified laboratory data to train a commercial algorithm without explicit patient consent, citing IRB waiver. The resulting product generates significant profit. So again, there is concern of commercialization ethics, and here the lesson is transparent data governance framework and benefit sharing models are needed. So we see that this introduction of AI has also created some bioethical challenges. So ethical framework for AI in clinical laboratory is monitored by WHO. In 2021, they have given some ethics principle which is applied to lab medicine to protect autonomy, to promote well-being, to ensure transparency, to promote accountability, equity and inclusion. This is very important, and responsive and which should be responsive and sustainable. So, compliance to GCLP, the data reported must be consistent, auditable, reproducible, and produced in an environment conducive to study reconstruction. Clinical laboratories in this way can enhance operational efficiency, better meet the needs of healthcare providers, better meet the needs of law enforcing agencies, and ultimately improve the patient care and outcome. Thus, out of difficulties, we can grow miracles. Thank you.
Thank you, ma'am. Thank you for your well-crafted and enlightening session. Now, I would like to call Dr. Durvashri Das, SR in Biochemistry in Purulia Devenmata Medical College, to facilitate Dr. Soma Gupta's felicitation. Thank you, ma'am. Now moving on to next session, our next speaker is Dr. Khia Mukherjee, HOD Microbiology of MMCH, with extensive expertise in laboratory system and microbiological diagnostic. She will share insights into modern sample management and digital laboratory workflows. Let us warmly welcome Dr. Khia Mukherjee.
A very good morning to all the delegates, faculty members, and the organizing committee. I'm very delighted to be here as a speaker for this session, and I'm very thankful to the organizing committee for giving me this opportunity. So today's my topic of discussion is smart sample journey, which consists of digital front desk, barcode tracking, and cold chain automation. So in this era of diagnosis mainly depends upon the laboratory system. So every result of our laboratory is very, very important for patient care service. So for this, we should get accurate result, laboratory result, as well as timely result is also required. So for this, that conventional, traditional method of sample journey has to be changed. So there is a little bit change of the sample journey from the traditional way to the faster and smarter way. So that's the thing I am going to discuss today. So already madam had discussed about the principles of GCLP, but in one sentence, if I want to describe GCLP, that means implementation of the good laboratory practice for the clinical samples. That is good clinical laboratory practice. So that is the GCLP. Implementation of GLP for clinical sample, that is GCLP. In short or in one sentence, if we want to describe it. And this is very essential in the medical field No, not only for the research purpose, but also for the diagnostic laboratories also, because we want reliable and reproducible data, and the safety and integrity of the test results are very much important, and also it ensures that quality of the data, quality of the test result, and the ethical conduct, regulatory compliances, all will be followed up by this sample or laboratory data, mainly laboratory result. Everything depends upon the laboratory result. And this will ensure the timely and accurate data, which is very important for our patient care service. So this is the journey of a sample. So whenever we are collecting the sample, it goes through 3 stages. We all of us, we think we know there is pre-analytical phase, analytical phase, and post-analytical phase. Pre-analytical phase starts with the patient registration or requisition of the sample. Whenever any doctor, any clinician advise the test, from that only it starts. So pre-analytical phase, we have to think from that part only, from the advice of the test. Okay, so in this test phase, main important thing is the sample collection. Sample collection, so before sample collection, few things we have to consider. That is, patient preparation as per prescription and requirement is very much required. Correct identification of the patient is very much required. Appropriate counseling with written consent should be there. And SOP, standard operating procedure for sample collection, should be there in each and everywhere where the sample is collected, and sample should be collected by well-trained personnel, by proper technique, and all the clinical samples should be considered infectious. So before collecting the sample, this all we should have in our head, that this we have to follow. These are the things. Next important point is labeling and accessory. So after collection of the sample, this is the main part where we can mix up the sample. We may make error. There may be some delay. There may be some manual error. Everything may be there in this phase. So each sample should be labeled with unique identifier and logged into the system. And that means it becomes traceable and reduces the chance of mix-up. And the identifying points may be many things: age, name, gender, patient ID, test requested time and date of specimen collection. Everything should be written on the sample container. Next important thing is requisition form or TRF, that is test request form. That also should be completed properly by the clinician or healthcare worker, and that should also contain all the points, that is age, sex, location, data, time of collection, what are the investigation required, everything. And also should contain the provisional diagnosis, clinical treatment history, everything. So, and another important step of this pre-analytical phase is transportation. So in this phase also, the sample may be mixed up, there may be the cold chain may not be maintained, there may be mishandling of the sample, integrity, stability, everything may be compromised in this portion or in this phase of the sample. So these are the main important points we have to consider in the pre-analytical phase of the sample journey. These are some sample rejection criteria. I am not going to discuss all this here. Just some unlabeled sample, broken, leaked sample, Okay, not proper hemolyzed sample, not fasting sample, we have to reject. And we have to inform the authorized person. And we can keep the data of the rejected sample also. Then after pre-analytical phase, we will move to the analytical phase. In this analytical phase, proper processing and testing and quality control are maintained. So this is the main phase where sample is tested and quality control is also done. Next, post-analytical phase. In post-analytical phase, we are delivering the report mainly. So result, we are getting the report, delivering the report, data analysis is done, record storage is done, everything is done here. So this is the journey from the pre-analytical via analytical, and this is the post-analytical. This is the journey of the sample. So during this journey, the sample may be lost, the temperature may not be maintained, preservative may not be the proper preservative, the sample may be leakage may be there. So everything, transportation, there may be compromised transportation. So everything, anything may happen in this pre-analytical, analytical and post-analytical phase. So we are changing the sample journey from the traditional to the smarter way, faster way. We are changing it. So that is smart sample journey. We are making the journey of the sample from traditional to the smarter way by transforming diagnostic operation through digital innovation. We are using digital innovation for this sample journey. So in the pre-analytical phase, analytical phase and post-analytical phase, every phase we are using this digital innovation. So making the sample journey smarter, faster for getting accurate, reliable and reproducible result. Why we need this smart sample journey? Because maximum 70% of the clinical decision depends on the laboratory result. And this sample quality directly impact diagnostic accuracy. And this manual workflow, there may be chance of error, delays, and day-to-day laboratory. Madam already told that laboratory previously it was only some test tube, few microscope, and a dark room. Now it is not like that. It has become very big. Corporate sector is also there, and in our government sector also it has big room, big air conditioned room, smart laboratory has come. So, and sample value has increased. So that's why there is requirement of a smart sample journey or smart laboratory is required. Traditional management system, we faced many problems. Patient identification error were there. Many illegible handwriting, we face this problem, mislabeling of the specimen, lost sample during the transportation. We know every time we face this problem that we have sent the clinicians tells that we have sent the sample, we are not getting the sample. So where is the sample? It may be lost anywhere. Temperature deviation may be there. If we don't keep the sample in the proper temperature, there may be error in the report, so and delay reporting. So these are the challenges we can overcome by the smart sample journey. So this is the vision of smart sample journey. Starts from the patient registration and ends with the digital reporting. Patient registration, after that sample collection, barcode assignment will be there. Transportation will be there with cold chain monitoring, automated cold chain monitoring will be there, and after laboratory testing, the report will be directly linked to the laboratory information system digitally, and it will be digital reporting will be provided so that patient will also get, consult clinician will also get the report directly. And what are the benefits of this journey? Faster turnaround time, higher accuracy, better patient experience, and regulatory compliances. Some regulatory bodies are there, ISO, then NABL, all these compliances can be maintained or regulated by this journey. So in this journey, first thing comes that is the digital front desk. So journey comes with a digital front desk. Digital front desk replaces the manual registration desk and paper-based workflow with integrated software solutions. So we are using a computer mainly in the, as a desktop, whatever it is in the that is the front desk. And what are the key components? What are the work done in this desk? Mainly online appointment or patient registration, digital patient registration, e-consent form, insurance verification, queue management, and automated notification. So all these can be done by a front desk. So this is the flow of registration desk. Patient books an appointment, identity verified, test ordered electronically, and sample collection request generated. Unique ID created, barcode printed automatically, and label attached at the collection center. So after the registration done, the barcode, the patient ID is generated, barcode printed, and that barcode we put it into the sample container. So from that point, we can now trace that sample. Whenever the barcode is generated with that unique ID, from that point, we can trace the sample, where it is, how is it maintained, what is the temperature of the sample. We can track the sample actually. Benefit to the patient. What is the benefit to the patient for digital front desk? Reduce waiting time, online everything happening, the digital registration, online consent from identity verification, everything is happening. Faster service, transparent communication, mobile notification, patient may get mobile notification, and easy access to report. So patient will get the report in his or her mobile or maybe by chat, by WhatsApp, by mail, anything. And what are the benefits to the healthcare providers? Reduced administrative workload. So only one digital front desk can do so many things that the administrative workload will be reduced. Better resource utilization. So mainly the human resource, which only one person in the front desk do so many things. So other human resources can be utilized in the other places of the laboratory. Improved data quality and enhanced operational efficiency. So these are the advantages not only for the patient but also for the healthcare providers. Next point is barcode tracking. So after digital front desk, in that desk only it will be started, that is barcode tracking. So each specimen receives a unique identifier linked to the patient and test information. So barcode is generated. Many technology, barcode-based technologies are available, linear barcode, QR code, 2D data matrix, many are there. So these type of barcodes are used to track the patient sample. So why this barcode tracking matters? Manual labeling and sample tracking leads to many errors. Sample mix-up, identifying mislabeling, data entry errors, sample loss, many are there. So delay, difficult traceability, time-consuming post-process to match the test result with the sample. So to overcome all these, we are using barcode, and that barcode only we scan this barcode so that automated lab operation will be started, reduce manual error, and improve pre-analytical turnaround time. So this is barcode generation, and we are scanning the barcode of the sample by the barcode scanner, and also this can be scanned by our mobile. If we introduce the app in our mobile, so without any scanner also we can scan this by through our mobile app. And this is, once it is barcode is generated, it is linked to the laboratory information system. So from that point to up to patient gets the report, everything is linked in this system. So we can track the sample. By barcoding, we can track the sample, whether it is in the collection department, dispatch, in the transit or transportation department system, or it has reached the laboratory, testing it is done or not, storage, disposal, wherever it is, sample is there, we can track that sample. And it is real time visible. Means we can track the location, status of this. If patient inquires about this, we can tell that here's the sample is running. You will get a report in few minutes or few hours. Okay, chain of custody of records, where it is. We can track the location, track the sample, and audit trail generation. So for any audit, this is the sample, where it is, how it is maintained, everything, every data is preserved. So we can record this audit data. Next point is cold chain automation. Cold chain automation, so after sample collection, maintenance of cold chain is very, very important. Many biological sample, we have to keep it in the fixed temperature. That is important. Blood, plasma, tissue, whatever, mainly molecular diagnostic sample, we have to keep it in fixed temperature. Otherwise, that will deteriorate. Cell damage may be there. We may get invalid test result. Repeat collection may be required, and that will increase the cost. So, to overcome all these problems, we have to maintain cold chain, and that is also by automated way. So we need to maintain the cold chain by looking at it, by whether temperature is maintained or not. It is not like that. It is automated maintenance of temperature throughout the process, from collection up to the storage in the lab and up to report delivery. We full process the cold chain, whether it is maintained or not, it will be an automated procedure, and if there is any change in the integrity of the sample, temperature of the sample, then there will be an alert. That alert will come to the laboratory personnel, and that can be monitored immediately. Necessary action can be taken immediately. So transport monitoring is very much important. Whenever we are collecting the sample at the collection center, or if it is transported through a courier, distribution hub, laboratory, everywhere, the temperature and location monitored continuously by this cold chain automation. And this is done by some important components of cold chain automation. Smart refrigerator are there. IoT sensor, Internet of Things. IoT means Internet of Things. These are some physical sensors which are kept in the sample container so that it can tell about the location and temperature of the sample by tracking. GPS tracker, by GPS tracker, it can send the location, and everything will be monitored in cloud. Everything will be linked, and automated alert will be sent to the concerned authority or concerned laboratory personnel. So this is the role of IoT in biological sample tracking. That is the compact connected device that provide real-time monitoring of the location and environmental condition of the sample. So a wireless device like tracker or sensor is placed inside the sample container. and it continuously record the location, temperature, movement, and light exposure, everything of the sample. What is the environmental condition and what is the location of the sample, and by using cellular device, by Wi-Fi, cellular data, everything, this device, they transmit the information to the cloud-based platform where lab staff can monitor in the real time. So at that point, the alert will be given to the laboratory staff, and if any issue arises, they may intervene immediately. That is the main thing. That is the role of the IoT in the biological sample tracking. So this in everywhere, the temperature and location and the environmental condition all are monitored automatically, and it is in real time procedure. So every time healthcare personnel or laboratory personnel authority gets the alert. So this is a continuous 24/7 monitoring of the environmental condition, and it not only monitor the sample condition but also monitor the laboratory condition, equipment health, reagent storage, sample storage, everything. It can alert whether there is any breach in the breach or gap in the system. Any problem in this system, whole system, anything happens, it will give real-time alert, and automatic data logging will be there. Generate compliance log, significantly increasing overall operational efficiency. And remote visibility. So even if sample is transported outside, it is in the truck, we can see whether temperature is maintained or not, anything happened to the sample or not, we can see it, and gives the alert. Then automated alert system when you are there. So temperature exceeds, refrigerator malfunction, power interruption, transit delay, anything it happens, they send us alert. So what are the advantages of this IoT platform-based monitoring than the manual monitoring? Because it is a continuous monitoring, not periodical monitoring like manual. Accuracy is more, response time, instant response time, and secured encrypted cloud storage is there. And one-click audit report is available with this system. So everything after collection of the sample, whenever we are generating the barcode, and it is linked to a system that is known as LIS, Laboratory Information System. So whenever the patient test request form is generated, barcode is generated, sample is collected, everything is linked to the LIS system. And this is nothing but a software system that record, manage, store data for clinical laboratory. And this is highly configurable system that can manage patient data, also data of the instrument, workflows, and enforce rules for verifying and releasing test results. So everything after the test done also, if this system thinks there may be, or if we are verifying that we have to verify the result, so we can verify it before releasing the result. So this is the important system which has come to our laboratory, so that everything is integrated from sample collection to the report discharge. So this is the end-to-end smart sample journey. It starts with this thing that customer, when it comes to the laboratory, sample received, you can see this sample is received, then barcode is generated, and the sample goes to the link to the laboratory information system, and there will be diagnostic test, check the result. If there is problem in the result, it will redo the test. Again, this result will be generated and the report will be discharged to the patient or the doctor. So this is the end-to-end smart sample journey. And This is one example. If we give one booking for patient blood test, what will happen? Online booking, digital registration will be there, barcode generation, sample collection, temperature control transport, automated analysis, and report delivery. So this is the end-to-end system. And from that dashboard, we can generate many data. So what is the turnaround time for different samples, sample rejection rate of that laboratory, transport efficiency? We can monitor real-time temperature, environmental condition during the transport. So that also can be monitored, or efficiency of that can also be considered. Temperature compliance is there or not. And main important point is the patient satisfaction. So by analysis of the dashboard, we can get all this data from this smart sample journey. And what are the business benefit? Reduced operational cost, better utilization of the staff, increased productivity, improve quality assurance of the laboratory. Patient benefit, faster diagnosis, fewer repeat collection, because everything is maintained, everything is in the smart sample journey. So repeat collections are very few, better communication to the patient, and higher confidence in result. So what are the future innovations? So this is the smart journey we are using in many corporate lab, and many government lab also using this type of smart sample journey. But in future, we will be using this innovation like AI. Madam already told that artificial intelligence or many digital twins, smart laboratories will be coming in future. AI-driven progress of smart laboratory can be applied in all the stages of the laboratory procedure, pre-analytical, analytical, and post-analytical, but it has to be validated, standardized, and regulated in ethical and legal aspect. So what are the key takeaways from this session? That digital front desk improves patient experience, barcode tracking ensures traceability of the sample, and cold chain automation preserve the sample integrity. So together they can create a fully connected diagnostic ecosystem. So this is what we want from a smart sample journey. These are the advantages of the smart sample journey. Thank you.
Thank you so much, ma'am. Thank you so much, ma'am, for the very informative session.
So actually, data storage, how many days to keep the data? So there are different time period for different data. So for our infectious disease data, it is different. For biochemistry, it is different. So instruction is there. So you have to know that for which sample you are doing, how many days we have to keep the data. So this is different for different specimen. Okay.
I would like to request Professor Dr. Ramnaran Maiti sir to kindly felicitate Dr. Khea Mukherjee ma'am. It's my pleasure to introduce Dr. Shayantan Jana, Assistant Professor, Department of Pathology, MIdnapore Medical College and Hospital. He is actively involved in pathology diagnostic and medical education. He will discuss the ethical challenges faced by modern pathology laboratories and their implications for GCLP compliance.
I'll change. So good morning, everyone. I will give a very brief talk on ethics. So, what is the importance of ethics? As you can see, I usually wish a better audience participation in my lectures. So I will ask the audience to participate. So what is the importance of ethics in GCLP? As I see, most of you are my students and PETs. So I've given started with the MCQ. So GCLP, ethics is required for as an unofficial tea break, for WBMC credit points, for legality, and because NMC has requested that ethics should be included as at home. Anybody can. Why do you think ethics is important? I'll take that. Most probably the WCMC credit points is the most important criteria for ethics, especially in GCLP. But according to me, ethics is partly legality and part it is in the excellence. So is ethics a legal thing? It's like that all illegal things are unethical, but all unethical things are not illegal. So there is a wide gap in between the legality and doing something correct. And most of the labs use that thing to do unethical things which are not illegal as such. So I have been asked to highlight those challenges in this modern era. So why is ethics required? As you all know that there is something called quality control in a lab. Now quality control is ensured to give the best accurate report to the patient. But within this quality control, if you see the skeleton of the quality control is based on ethics. If you are not ethical, you will compromise on the quality of the report, and it will be the patient will not get a correct report. So the basics of ethics is to give a correct, accurate report to the patient. Now, ethics is not an abstract thing. It is based on 4 pillars, which are autonomy, beneficence, non-maleficence, and justice. So what is autonomy? Autonomy means that the patient has every right to decide whether he or she should do a particular test or not, or a particular procedure or not. Beneficence. The test must be prescribed for the patient, keeping the betterment of the patient, not the betterment of the lab or the betterment of the pharmaceutical companies. Non-maleficence. The test must not do harm. Especially, I see a lot of requisition for bone marrows, which are unnecessarily advised. So that is a non-maleficence. Justice. That test must do something good for the patient. And it should be equitable. You are prescribing high-end test for a patient who can afford, and you are not prescribing them to someone because he cannot afford. That is not justice. So ethics is integrated with the quality control. So anything that helps in the quality control, that is special zoning, biosafety infrastructure, chemical and electrical hazard separation, is integrated into ethics. Now the ethics starts with consent. So there is informed consent. You all know what this consent is in this era. It can be a routine or low risk consent. For example, any blood, when you take a blood sample, it is implied that the patient has given the consent. It can be high risk or invasive consent, like doing a bone marrow aspiration or tubal biopsy, or it can be a vulnerable population. So what is consent? We all know that consent is something we have to ask the patient, but there are some points that define a consent. Consent should have the patient should have capacity. Capacity means the patient should understand, should retain, should analyze what you are telling and communicate to you. It should be voluntary. It should be informed. Informed means it's not a consent if you make me afraid to say no. You are making the patient afraid. If you do not do this test, this will not be diagnosed and you will die. So that is not a consent. You must properly explain what are the benefits of the test, what are the drawbacks of the test. Is there any alternative available to that test? Then it's consent. Then it's informed consent. It should be continued. An example of continued is that suppose the patient has come to you for HPV testing, for pap smear. So you do the pap smear and you find there is LCL, low grade squamous intraepithelial lesion, and you wish the patient does a HPV, and you do the HPV testing automatically without asking the patient, because I've already taken consent for pap smear. But no, you have taken consent for pap smear, not for HPV testing. So the consent should be continued and confidential. We all know confidentiality is a very much touching topic in this era of where there is AI and where there is so much social media. So confidentiality should always be maintained at all cost. So again, that accuracy and its integration with ethical challenges. So what are the ethical challenges in laboratory? I will go the laboratory report. Now you are an ethical laboratory, you are doing everything ethically, but you have to sell that ethics. Everything is sellable in today's world. So you have to sell that ethics. So how can you tell the patient or the clinician that you are an ethical lab? That is to the report. In the report, you have to say at what time you have received the sample, at what time you are testing it, what is the method of testing, which machine are you using, are your tests validated, what reference interval are you using, are the person who are signing off the report, are they competent enough, their degree, their registration number. Also, just giving merely a value is not a report. You are giving a sugar value or a value of lipid. You have to give the interpretation. What is the interpretation of a report? And what are the limitations of the interpretation, or what are the limitations of the test? Is there any fallacy that can happen in your test? Is there any element of uncertainty that can happen in your test? All those things should be communicated clearly in your report, because you are not interacting with the patient, you are not interacting with the clinician. So the only legal thing that you can communicate with your patient or with your clinician is your report. So the report must be ethically valid. We'll go through this later. So now the audience participation part. So I have been asked for some challenges. So some real life challenges, but ethically I cannot discuss real life challenges because I have not taken consent from those particular persons regarding those real life scenarios. So just like in the movies, they say based on true events. So the following slides are based on true events, but any coincidence is purely fictional. So the first one, the collected report. Histology report of a lung biopsy was initially diagnosed as a lipidic pattern of adenocarcinoma. And later in a internal review or in a teaching session, it was pointed out that this is not a malignancy, it is an inflammatory condition, benign condition. So as any good NML laboratory does, they redacted the report, they issued a corrected report, they wrote it in their register that the report has been redacted and corrected, but they did not inform the clinician or the patient because there is challenge of litigation. So I'll ask the audience, what should be done? Anybody please respond? Anything, this is not a class and you will not be penalized. You will get the 8 credit points you will get, even if you get the answer wrong. Anyone? Okay. I have a very mute audience. So there is something called duty of candor. And in developed countries, there is this concept is there that if you do something wrong, you have to apologize to the patient as soon as possible and tell that I have done something wrong and this is the corrected report. But in India, unfortunately, we do not have this duty of candor. But believe me, it is better to apologize to the patient than to meet the patient in the court with lots of litigation and lots of lawyers. So the best thing that you can do is follow up the patient, explain him, or follow up the clinician, explain him that this was a very tricky case, you have misdiagnosed it, and follow up the patient, issue him the corrected report, and see if the patient has already started receiving treatment, stop the treatment. Because if you do not give that report, the patient will most probably not die of lung cancer, but will die of chemotherapy. Good doctor. I think all of us are good doctors, and somebody has seen this sitcom. So we always think about the patient. So as a pathologist, I have seen a case of sarcoma. I think this is a synovial sarcoma, but I do not advise ISC because I think the patient is too poor to do ISC. Or there is a mastectomy operation has been done, it has been referred to the surgeon, and the surgeon has told the patient cannot afford, please give only 2 slides. And I have given report only 2 slides without staging and grading. Now, do you think the patient can sue me or make a case against me? I have thought about the patient. Now, the recent Supreme Court judgment says that you have to inform the patient of everything. It's up to the patient to decide whether he or she can afford or not. It is not your prerogative to judge a patient whether he is poor or he rich or whether he can pay or not. So the ideal case scenario would have been I should have given a complete report. It is up to the patient to decide whether he can do the further tests or not. I'll skip this. The bullying. This is a scenario that we encounter in our daily day-to-day practice or in our daily hospitals. I'll go to the second one. A pathology resident notices that a lymph node biopsy is reported as reactive, but it contains a metastatic deposit. But he is afraid to tell the consultant or his professor or his associate professor who has reported it because he or she always shouts at him and always humiliates the junior in front of the staff. So ultimately, who is the affected person? The patient. A wrong report has been issued to the patient. So the learning point is that, learning objective here is that the environment that should be conducive. It should be an open environment where the juniors can point out the mistake of seniors and the seniors can learn something from the juniors, which is unfortunately not present in many places, but some places encourages this thing. Telephone reporting. Lots of time we get a call from the patient relatives. What is the report? No confidentiality. The report should only be communicated to the patient, not to his relatives, and to the doctor or any person who is authorized by the doctor, and that should be documented. So if a relative asks what is the report, you cannot tell the relative. It's the patient's prerogative to know. I will skip this. Clinicians pathologies, the pathologies which all clinicians love. So a known cancer patient has an NGS report. The NGS report was a bit if some, but the pathologist reported it as an aggressive variant because the clinician wanted that the aggressive report should be given so that the molecular test therapies, immunotherapies can be given. So this is clearly illegal. But it is very difficult to prove because these are all again interpretive reports. So this is an ethical challenge to the budding pathologist or the budding clinicians not to pressurize the pathologist and for the pathologist or the biochemist or the molecular pathologist not to give in to the pressure of the clinicians or to pharmaceutical companies. Also, unnecessary ICs keeping unnecessary ICs in benign conditions or in suspicious conditions where you can clearly diagnose that this is a benign condition. These are also challenges or ethical challenges. Those you cannot stand in a court of law and prove that they have kept unnecessary ICs. But these are ethical challenges. A manipulator we have in all labs. Usually the junior most persons are the most susceptible to this. Whenever they do not understand something or they do not understand the report or a particular parameter, they manipulate it to their to fit the overall picture, or they manipulate the QC data. We get in annual inspections, we get in 100 number of times this manipulation. So this is again unethical. The all-knowing pathology. This is again a very dangerous thing, especially also the all-knowing clinicians. Blood group. Some labs perform blood group only in forward routing, and they think that reverse routing is a wastage of time, resource, and money. The O blood group. Many labs do not perform anti-H antibodies and do only O blood group because they think Bombay blood group is very rare. But I have got 2 Bombay blood groups in last 2 years. So they do not do anti-H lectin because it will be costly to do anti-H lectin and it will take time. So these all-knowing pathologists or all-knowing things are not good. I know this. That is not good. Do as per the protocol, as per that is in the textbooks, follow it blindly. Molecular mayhem. I will want opinion of especially the second case. A colorectal carcinoma was undergoes a molecular testing and Lean syndrome is diagnosed. Now, as you all know, Lean syndrome has a prognostic significance, especially for the patient relatives, because they should be screened for underlying endometrial carcinoma and colon carcinoma. But the patient doesn't want the report to be divulged to her relatives or his relatives. So what as a pathologist or as a clinician should you do? Should you tell the relatives? Or should you just, as per because the patient's confidentiality is the most important point of ethics. So what should be done? Ma'am? Sir?
Now, the reason is that everything you should say to the patient. So it may be not in a laugh way, but in a lucid way, and give the best prognosis to the patient. Whatever may be, it may be.
But this is concerning the relatives of the patient. They should be screened for colorectal carcinoma.
And very much close relative, you can say everything.
But that will break the confidentiality to the patient. Confidentiality clause.
But as per our
Medical ethics.
medical
Our ethics.
ethics,
Okay. So I asked one of my molecular genesis friend. She is in Mumbai, and she told you cannot break the patient confidentiality, but you can call the relatives and tell them to do screening. So you you do not tell that her relative is suffering from Lean syndrome, but you advise the relatives that you undergo colorectal screening. Hydra. This is a mythical character. So increasingly, we are having more and more laboratory tests, and the sad part is that the laboratory are not driven nowadays by the pathologist or the biochemist, but by the marketing people. So say they devise what tests should be advertised, what tests should be done, and not the clinician, not the pathologist, mostly the marketing and the pharma people. So one example is the executive cancer panel. They are doing a NGS of all the molecular things in normal people, or something a full NGS panel. These are very costly tests. Sometimes I get requests from normal persons. As recently I got a request from a person who was going to marry, and he had a very old history. His grandfather was died of some unknown cancer. So he requested I want to do a full NGS panel to see if I will be having any cancer or not. So these tests are not validated; they are just sold. So these unethical things should be explained to the patient that this test doesn't have any importance or any prognostic value. Phone a friend. Whenever we go into a difficulty, we usually phone a friend. But again, there are some people who does not want to acknowledge the limitations and issue a report. So there are some things in labs or pathologies or biochemistry or any of diagnostic field where 2 plus 2 is not equal to 4. So if you are in doubt, better to write that I am in doubt, I cannot explain this. Please refer this slide or this sample to a better lab or to a colleague or to a better facility. So acknowledging your limitations is a very much important part of ethics. VIP syndrome, madam has already given an example of Julia Roberts, so I will not go through this. WhatsApp doctor. Most of us use WhatsApp to consultation, to show off our achievements, but always remember to mask the patient identity. The problem arises when this is a rare diagnosis. Suppose Amitabh Bachchan is admitted in your hospital and he has a rare diagnosis of neuroendocrine tumor of the pancreas. Very rare. So you send a slide of neuroendocrine tumor of the pancreas to your group for opinion, and later in the paper it comes out that Amitabh Bachchan is suffering from well differentiated neuroendocrine tumor of the pancreas. So everybody can do a 2+2. That slide was the slide of the patient. So problem arises there. So confidentiality should be maintained at all times. Motivated technician, this is very much important for the interns and the house staffs and junior doctors also. So I have taken my name only. Shantanu is a hardworking technician who wishes to work 12 to 14 hours a day in a lab because he wishes to be in the good books of the management and get a raise. And the management encourages everyone to be like Dr. Shantanu. So is this a correct thing? Because I am getting paid for doing more work. Is this okay? Why not, sir? It will be stressful, and stress means errors, and errors will be sufferer the patient. So there is a reason that 8 hours work has been done for everyone, and that should be followed because increased stress, increased patient errors, and wrong reports. Drunk pathologist, I don't think it is relevant to Indian scenario more or less. But if you report, if it is there a drunk pathologist or one of your colleagues is doing job under the influence of any drugs, it should be reported. We do not report such things because out of compassion for the colleagues or kya sochenge log, but ultimately thing is the patient safety. So it should be reported to your immediate senior, to the lab director, or to the hospital authority. If you are the boss, then junior can report against you. Einstein, your question that you are the boss. A highly respected hematopathologist occasionally reports cases after drinking, but colleagues say he is experienced enough to never make mistakes. Does expertise justify impairment? Should past performance affect previous judgment? No. Any one incident is reportable. Even if the patient has the doctor is 99 days keeping cover and he has been a good fellow, but in one incident it should be reported because any one report to the patient and abnormal report to the patient, wrong report to the patient, that patient will be affected. So you cannot say that okay, I have given 99 good reports and one bad report. That doesn't justify or make you a good doctor. The pool party. I will ask any biochemist or any microbiologist regarding this. Lab pulls HIV sample and runs them in batches to save cost. Lab pulls HIV serum samples and runs them in batches to save cost. Is this ethical?
But it's cost effective, sir.
Has the lab communicated this thing to the patient? The patient knows that my sample has been run in a single batch. If you communicate that to the patient, that okay, I will be taking your sample, I will be running at a lower cost because I am pulling your sample, then it's okay because medically this is okay. There are some guidelines of pulling in as far as I know. But have you communicated it to the patient? That is the most important thing. If you do not communicate and you do a cost saving procedure, then it is unethical. Yeah, but the patient should be communicated how we are testing.
We cannot score the analysis of HIV analysis just because it is going to be cost effective by doing the batch. I did.
Yes. We do. I am telling these are real life scenarios, not real life scenarios. That was government regulation. That will override. Yes, in COVID we did, but that was government regulation. The government directed you cannot. That they need a legal thing. This is sir. This is done not only for HIV. This is done, I think, many other places. This is done for thyroids also, and lots of tests they do. And this is highly unethical practice. But unfortunately, the clinicians don't ask. The perfect patient. This is also a real life scenario. A patient, a lady did a general pre-employment checkup and her pregnancy test is positive. But if you, in Indian scenario, if you tell a positive pregnancy test, you will lose the job. You will not get the job. Many jobs require a negative pregnancy test, unfortunately. So she requests you to make the report negative. What should you do? This is what the patient has requested. Patient request. Okay. Yes. Scientific rigor must always override patient's request or patient's confidentiality. Blue-eyed boy, you are the best loved pathologist of your organization because you always think about the organization. So you order IC even in benign morphological conditions like endometriosis, even if it is not required. So this is clearly unethical, but you cannot prove it in the court because I think endometriosis needs IC. Some other pathologists will say, no, I do not think endometriosis needs IC. And also the add-on test. Many labs does this, that patient came for one test and went out with a battery of investigations done because we are getting one test for ₹100, we are getting 7 tests for ₹500, so I win. And the tests are paid by the insurance company, so what is the matter? But doing unnecessary test again is a very unethical thing to do. Control C, this is enable thing. I'll ask those people who are enable assessors. So the lab outsources the ISC to a third-party lab with whom they have a member of MOU and prints the ISC report on its own report pad signed by the in-house pathologist who is not in the slides. But enable allows it. Enable allows it with an but enable allows it if you give a disclaimer that this test has been done outside. So this is again an ethical issue that needs a broader consultation, especially among the but usually that is said in a very small, tiny print, and that you have to search with a like a not with a magnet. You have to know that it has there is something like that. You have to search like that. This is something that we know what is that is. And nowadays, all the labs are advertising we have the smartest or the smallest stat, and all these automation, AI, all these are driven. One of the important engines of this AI is to decrease stat. So the serial sections or regrowths are not given because we have to keep the stat. Lab has promised a serology report in 1 hour, and instead of doing it in ELISA, which is for better, they are doing in a POCD kit. So is it acceptable to decrease, in the name of decreasing TAT, we are decreasing quality? No, TAT is only a quality indicator. It is not quality per se. So the goal of a lab is to issue the most accurate report within a clinically acceptable time. A biopsy report, if you get within 2 days, okay. If you get it within 7 days, okay. Not in 1 month. But to get in 1 day, and for that you are unnecessarily pressuring the pathologist or the biochemist or someone to release the report as soon as possible without any clinical implication is not acceptable. It's unethical because ultimately, if you give pressure, there will be some errors. This is again a controversial thing. I will want opinion of random. 2 validated, approved black box AI system. Black box AI system means you do not know how the AI acts. Have given 2 opposite results regarding a biomarker study which is predictive of targeted therapy. Human review is unequivocal. What should the pathologist do? Though both AIs are validated, both have given, one has given as positive, one has given as negative. Suppose it is a EGFR. And based on that, you have to give a therapy. If it is EGFR positive, you will give therapy. If it is negative, you don't give therapy. You ask the pathologist for your opinion. Reproducibility is same. Validation is same. Systems are same. What happens most of the times, labs go on with the clinician's thought. What do you think? If they think that, okay, it should be positive, they give positive. Or if the clinicians think negative, there is a bias. But But I think that it should be acknowledged in the report that we have run into separate AI systems and both have given controversial results, opposite results, and we do not know. So the thing that we do not know, that is a very much important aspect both for the lab personnel and for the clinicians, because you will never know everything. So we do not know, do further testing. See, as the patient becomes more educated, he will understand. We had a case from practical experience. We had a case. We thought it was a Hodgkin's. We initially signed out it as a Hodgkin's on an FNC, and then again we did FNC. We corrected ourselves and we thought this was a thing, nothing but a reactive lymph node. We called the patient. We explained the patient. See, we have erred. That is the duty of candor. And the patient understood. There was no litigation, nothing. The patient was relieved that I had nothing. That will happen, sir. That will happen. You cannot prevent it. That is dry lab. You cannot prevent. How can I give? Because we can give this inconclusive. Inconclusive, we have to do a further confirmatory test if there is available or not. Or you can do the same test after a period of time. Time when it will become a yes. So you should not be a god. Everyone knows this person, Hila cell. So this is also a real life scenario. Our molecular genetic labs has accumulated a large genomic database from Indian newborns with congenital disorders, and a pharma company offers to purchase it. Patients had signed the consent before giving blood. Data may be used for further research. Do you think the lab can sell the data to the pharma company? There is a lab which is performing molecular genomics in young patients for congenital disorders. And they have a huge database of all the molecular genomic problems that can occur. So a pharma company has approached that lab. You sell the data, we will develop drugs against those diseases. Most of these are incurable. And the patients, those who have given blood, have signed a disclaimer that their data can be used for future research. So can the lab sell the data? No. The patient research is not equivalent to profit. The lab is selling something for a profit. In HeLa cell, the HeLa cell is used in such, it has been commercialized in such a way, but the person didn't get a dime initially after the court case. So there should be some profit sharing. The concept should be again retaken. Yes, sir. Yes. Ideally, they should have an in-house ethical committee, and they should deliberate on this. And patient consent should be taken. This is a real life scenario, but they didn't sell the data. But that CEO told that they have got offers from multinational companies to sell the Indian data to them, because at that time there was no ICMR guidelines also. Everybody knows this. You are the product. If there is a free checkup, free health checkup, everybody has a free health checkup or free thyroid tests. All those data are used for drugs and drug deliveries and for targeting marketing. So that brings us to the last important, the most contentious, fee splitting. Everybody knows what is fee splitting. Dry labbing is what we call that issuing report without testing. Lab shopping, that I was telling. If I am not satisfied to this lab, I go to another lab. And one particular thing we have, especially in MIdnapore, is that splitting sample. I send the sample, half of the biopsy specimen to one lab, half the biopsy specimen to two labs, without understanding that the whole of the specimen to be seen in integrity. Or half of the blood sample to one lab to see the platelet, and half of the sample to my colleague in another lab to see the platelet, and we both discuss over the phone, and then we issue the report, and the clinician doesn't know that we are friends. Even we are in opposite competing labs, we are friends at the end of the day. So he calls me, I call him. Okay, you are 30,000. Okay, I will also give 35,000. So that doesn't do any benefit to the patient. Window dressing, this is very much rampant for NVL. We hire a consultant and he or she, that organization makes all the reports and all the things before NVL. Health checkup I already discussed. So how to decide whether a thing is ethical or not? We have all those 4 pillars, but if you are in a very short time scenario, I call this the mean phenomenon. Imagine yourself or your very close, near or dear ones in that situation. What would you do or what would you expect if you were in the situation? That is the most ethical thing to do. But do not have an egocentric bias. That means do not think, okay, I will not do that thing. No. Judge in a third-person perspective as if your patient or your someone close dear one is suffering from the disease, and what should be the most ethical thing that we expect from the lab or the doctor. A few unethical disclosures. I have no copyright for the images or the slides. Special thanks to the GCLP team for giving me this opportunity for wasting their time. And no effort was made to seek permission from any of the persons for the images, which case scenarios were presented here. And special thanks to Dr. Priyanka Datta. She made the slides. And thank you for your audience for participating. And this is a famous film, Newton. So, अपने ही ड्यूटी करने के लिए तुम चाहते हो लोग तुम्हें थैंक्स करो. So ethics, we should be ethical. Nobody will thank us for being ethical, but it will save us from litigation and it will help us to have a good night's sleep at the end of the day. Thank you.
Thank you so much, sir, for your interactive and thought-provoking lecture. I would like to request Dr. Kaushali Mukherjee to kindly felicitate Dr. Shankun, sir. Our next speaker is Dr. Poroma Banerjee ma'am, Assistant Professor, Department of Biochemistry, Dr. B.C. Roy Multi-Speciality Medical Research Center, IIT Kharagpur. She is known for her work in clinical biochemistry and laboratory quality system. Today, she will highlight advanced quality control, validation, and AI-assisted error detection in laboratories. Welcome, Dr. Banerjee.
Good morning, everybody. And I'm grateful to MIdnapore Medical College and the Pharmacology Department for having me here today. After a wonderful session, after my previous speaker, I'm here to speak about something which is not really that funny and something that we do on a regular basis. Now, I had a similar session last year. Difference is everything is advanced this year. As the title says, precision beyond accuracy, advanced QC, validation, and AI-assisted error detection. Right. So, what will be the learning objectives for today? First and foremost, we have analytical quality. What we are already doing, like QCs, which we are already running. Next, we have another new thing, not very new, but new to our country only in the last 10 years maybe, that is sigma metrics and performance specification for the modern clinical labs. Things we are already doing, but we shall see what is new, what can be done further. Next, we have the total testing process. It initially started with the laboratory or only the QC, but now it has been applied to the entire analytical process. That is quality management for the entire process or total testing. Now we shall see how quality management will be applied to the pre-analytical, analytical, and post-analytical phases. Important is risk-based thinking. Now, if we know the new NABL 15189/2022 mandates risk assessment at every stage. We have all practiced CAPA, that is corrective action, preventive action. However, nowadays it is more of CARA, that is corrective action and risk assessment. Now, a very important next step is validation and verification. We shall look at it in details according to the CLSI guidelines and of course ISO. And next is AI integration. In this age, we have found a new tool, which is AI, artificial intelligence. Of course, we are the brain behind the matter, but yes, if we have technology which can make things simpler for us, why not use it? Especially so for us, because we generate a huge amount of data. It's not possible humanly to go through all that. So we'll be using the predictive analytic capabilities of AI to give us better results and of course, advanced technology. Next, coming to the evolution of laboratory quality, very briefly, a history. I'll just walk you down how the entire process of quality evolved and what we need to do more. So, initially, if we see 1950s and 1970s, when the initial phase was starting out, we were doing everything manually. There were the Shuhat charts, which we manually used to calculate using some basic statistics to find out what was the QC performance. Next, moving on to the next decade, 1980 and 1990, we were more aware. Next, we started to have actually quality control programs. That is when the Westcast multi-rules were introduced. We are still using it today. Despite that, there will be changes. So Westcast multi-rules came in somewhere around the 1980s and 90s. Moving on, coming to 2000, this is when the idea of quality using sigma matrix came into being. So lean principles, which is also a characteristic of the sigma matrix, is what was introduced. Now, what will happen next? 2020, we will have integrated laboratories and quality practices where AI will play a major role. And we have some advanced matters which we shall see very soon. So, before I go on to advanced QC, some metrology measurements which we are constantly using, and so the foundations of analytical quality. Let's see what these are. Before I go on to this, I had talked about quality last year. So today, as a part of quality, I'll be emphasizing on precision. What is precision? And most importantly, why does it matter? Precision matters why? Because number one, from the clinician's point of view, precise means every time, no matter how many times we repeat it, we should be correct or as close to the correct value as possible. Why is it needed? Say, for example, we are treating a patient, we have a baseline value, we want to see on serial evaluation whether the disease is progressing or the patient is responding to treatment. So for all that, we need precise values. Values are being repeated, but we must know whether it is reliable, dependable, and if it is near the clinical decision limit, it has to be correct and acceptable. So that is the load on the clinician. That is a clinical perspective of precision. Let's see, coming to us, the analytical perspective. Number one, we cannot go on repeating the value over and over again and wasting our resources. Number two, for our own reliability, for our acceptability of our values also, we need to be precise so that every single reported value is as close to the true value as possible. Why am I saying as close? because there is also something called uncertainty. We like it or not, some amount of uncertainty does creep in. So we should have acceptable level of uncertainty. With that, we will try to be as precise as possible. Now, again, these are terms which we very commonly use: accuracy, precision, trueness, and bias. These are day-to-day terms. So let's see what each of these mean. Very simply put, accuracy means accurate, means being correct. If you see the diagram, the first one, that's a bullseye. Now, what does it mean? Bullseye means we are hitting the target. Accurate means correct, as close to the true value as possible. Next, how about precise? Precision essentially deals with the characteristics of repeatability, reproducibility. If you see the target diagram, it is not accurate, but on repeated analysis, the values are very close to each other. So the assay performance, that is definitely precise. Next, coming to what is trueness. This is slightly different from accuracy, because here, if you have a series of values, similar values, the mean of that will also be as close to the true value as possible. And finally, bias. Like I was talking about uncertainty. Why does uncertainty creep in? Because there is always a bias. Bias is basically a deviation. This is the property of the system which we are being using, and this deviation does cause a fractional change. That is the uncertainty brought about by the bias. So that is the imprecision. Now, what are the sources of laboratory errors? The word error somehow is not visible, it was there. Okay, so if we see the percentage, let's see the pie diagram. If we can see closely, pre-analytical phase is where maximum amount of the problems will occur, or sources of laboratory variations will occur. So pre-analytical phase, that is 62%. Next, we have the analytical phase, about 15%, followed by the post-analytical, which is about 23%. Also to keep in mind, there is something called biological variation, which we shall see, disease dynamics, and definitely unavoidable within patient noise means intra-patient variation. There will be variations also, because these are biological samples, diurnal, seasonal, etc. Now, this is a fishbone diagram which shows you all the possible areas from where variability can rise. So, across the entire testing process, it can be from the running of the test, it can be sample collection, integrity of the sample, it can also be calibration, it can be the patient itself. There are multiple ways. That's why I've tried to collate the whole thing inside one diagram so that it gives us a basic idea where all we should be looking for. If we don't know where the problem can rise from, we will definitely miss it. So it's a huge list, trying to collate it in one diagram. Next, coming to measurement uncertainty. I was speaking about measurement uncertainty. Before I go to that, I want you all to focus on the diagram. See, if you can see there, it's a very simple diagram. Basically, we have two rulers or scale. If you see, no matter how precise we claim that the system is, there still remains a difference, slight difference from the true or the accurate value. And that imprecision is given by the measurement of uncertainty. So, what is measurement of uncertainty? Okay. So, if we see here, we have two rulers. Still, this is graduated even further. This is graduated slightly less. So, every measurement will have some degree of uncertainty. It can be fractional, it can be more. Our aim is to bring it down to as least possible, so that because we are trying to move towards precision. And what is uncertainty? The range around the reported result, which reflects the incomplete knowledge. And like I was saying, it combines
imprecision, bias, calibration uncertainty, and of course, other contributors. This is essential when the results are close to the clinical decision limit. And there's another term, uncertainty, and total allowable error. See, the two aspects is total allowable error is how much we can accept, how much deviation is acceptable. Whereas uncertainty is that level or that fraction which can be accepted confidently. Now, measurement uncertainty, why it's so important? Because the latest ISO mandates that all the stakeholders should be given the records by the laboratories in a well-documented fashion. That is why it is so important. Next, we were talking about biological variations and also clinical decision limits. Clinical decision limit is the ranges or cutoffs which we use to diagnose patients, manage patients, and also see their response to the treatment. Now, the important is why think of biological variations? We already have reference ranges, but they should be kept in mind. Human body itself has variations, even for a person, intra-person variation. We can have cortisol levels, which are measured twice. We have hormones, which are secreted in pulsatile manner. We can have fasting, postprandial glucose levels, which are different. Also, we can have seasonal variations, remember? So, that is only intra-person. Of course, there will be variation within two persons of the same population, and definitely genetic variation, racial variation, and even geographical variation. So whenever we are thinking about clinical decision limits, all this needs to be kept in mind. Not only the reference range, but also the population that we are dealing with. And over here, I have given a diagram. This basically integrates all the things that we are talking about and how to go about. This is a reference interval. Now we have the comparison to the interval, comparison to the treatment threshold, and the subject-wise changes. All this taken together will give us the final result. Right. Now, what are the clinical consequences? Why are we so bothered about precision, accuracy, etc.? What will be the consequence if there are laboratory errors? Let's see. Number one is a diagnostic misclassification. Like I said, today in the world of evidence-based medicine, we must give each and every report correct and acceptable, because the patient will be diagnosed based on that, the patient will be treated based on that, the response to treatment or progression of disease will depend on the results that we give. So diagnostic misclassification is absolutely unpardonable. We cannot have that huge mental harassment load on the patient. The stay will increase, cost will increase, so many complications can arise. Next, operational and financial costs, of course, for us also. If we have to go on repeating tests, we have to go on re-reporting tests, that is definitely a significant financial burden, operational cost, time waste, and of course, most important, we lose our reliability. Now, next coming to advanced quality control system. We are all aware of the internal QCs that we are doing every day to see or check our systems. We are also doing external QCs, that is proficiency testing. But what more can be done or what better can be done is what we will see in advanced quality control system. So, first, let's see what were the limitations of the traditional QC practices. Number one is definitely the blind spot. We are running QC before a batch, or maybe say in the morning, and we continue with our runs. What happens in between, we do not get to know. Even within a batch, random errors are highly possible. Next, talking about random error, next thing we can have is a systematic error. What happens? Inability to detect the rapid shift or the systemic failures, which if we identify, say after 2 batches, 80 samples, we have to rerun the whole thing. Now, high false rejection rates. Many labs, especially the high volume ones, they have something called auto verification and auto rejection. That is to reduce the burden on the specialists. Now, what happens is, if we are operating on very narrow limits, some prefer lab means, but for values or analytes, which are very narrow ranges, if we operate on such narrow limits, there will be false rejections, which are not at all required or desired. Next, matrix effect. What is that? We all use QCs, which are being supplied by international vendors, and we know that they are simulators. They are made of matrices, which lyophilized usually, which are manufactured in such a way so as to mimic the human body fluids, serum, blood, etc. But there do exist some difference, and that might cause a change in QC values. So this is what we are used to doing, internal QC control. Why I put it here is, if you see, when we integrate it with AI, the predictive analysis can help us in, the predictive analysis part of it can help us in identifying flaws which might be missed by the human. See over here, we have something called trends, we have shifts. So if AI is already integrated, we have already used common Westgard rules here. Giving the flag ourselves or identifying the flag ourselves is one thing, but getting flagged every time by virtue of AI is definitely helpful. That's why I have put this entire decision chart over here. This can act as a reference for AI to take decisions and to give us the flags. Now, this is what we actually advise, that for each and every laboratory, there should be an individualized quality control plan which suits the laboratory better according to its load or according to its requirement. Accordingly, we have something called a 3-box strategy. Risk assessment, like I said, the latest NABL mandates that you assess the risk at each and every step. Pre-think. We think what can go wrong. We take the preventive action, and that's how we mitigate any kind of unwanted, undesired effect. So that is risk assessment. Followed by that, of course, we'll have the strategy. Like we have SOPs, we will have a proper written documented plan which suits us the best. And finally, we'll have periodic review. Without monitoring, we'll never know where the system is going or what changes are required. Next, this is something new which can be done with the help of AI, and this is a part of advanced QC. This is called patient-based real-time QC. Advantage, number one, it is not based on artificial matrix material. It is done with patient's blood, so there's no matrix interference. Number two, done on a continuous basis. Hence, we will get to know whenever there is a deviation or a shift. Third, it also does reduce the cost of all this commercial, when we are buying such commercial material, it does give us a lot of cost on the lab. All that will be minimized. Also, another important thing is continuous monitoring, no matrix effect, like I said, immediate error detection, and yes, ideal for high volume test. Like I said in my previous slide, it's no use identifying a problem or a deviation after 2-3 batches, because the whole thing has to get repeated. Now, this is how the data flow diagram will be if we are using a PBR-RT QC. This is a rough layout how the lab can integrate this real-time QC in their workflow. Okay. Westgard multi-rule system we all know, and we all know how to take the decision. This chart I've put here, not just to revise, but also to know that these algorithms, if we are giving to machine, that is the machine learning, if the AI is trained on these particular algorithms, it will also know how to interpret the data like us. And like I said, it is essentially it's there to help us reduce the load on us and also on a very, I would say, proactive basis, because the predictive analysis of AI is something we are going to utilize. Now, Six Sigma metrics, last 10 to 15 years, this has been introduced into India. It has been there for much before, of course, which was started by Motorola, and gradually we have all picked it up in the various industries. Six Sigma is a Japanese, I would say, quality practice. And what it says is the main target is to minimize error. The best or the most desirable is, of course, Six Sigma and above. Six Sigma basically gives you errors per million, or if you translate it to Indian numerology, it will be errors in lakhs. Let's take errors in million. Now, 3 to 5 is what we can achieve better. 6, of course, if you can achieve, that's best. Otherwise, we say 3 and above is our target. The important thing about Six Sigma is if we can minimize error at each and every level, then finally the need for monitoring, QCs, external QCs, all this automatically reduces because our entire system has become far more foolproof. Okay, coming to a very important part, which is validation. Why is validation so more important nowadays? Is because we all go for accreditation. Accreditation requires certain standards, certain verified and validated use of not just parameters, QCs, but also processes. That's why validation has become so important. Now, we will take both of them up together. Why so? There's a slight difference between what is validation and what is verification. I'll come to the easier one first. What is verifying? Verifying means checking something we have already got from a vendor, from a commercial person. But before we employ, we must make sure that this particular product, it matches or it can meet up to whatever demands is there. When we are verifying, we are essentially just checking that all the manufacturer's claims are met with and it is working fine in the environmental condition that we have in our labs. So this is actually easier. Coming to validation. Validation essentially applies to newer assays, especially if it is in vitro, developed in vitro medical devices. In that case, this is more exhaustive and we must make sure that it serves the purpose and we have to subject it to stringent testing to ensure that all the performance characteristics which we require from it are being met. So validation is essentially for entirely new assays, especially if they are in vitro developed. Verification, on the other hand, will be essentially unmodified commercial diagnostic system which have been provided to us. And the goal, as I said, is slightly different. Now, in order to validate, there are about 11 points which we must see, but few important ones I'll touch on right now. Okay, this is when we are verifying a certain product from a vendor, how to go about that. The vendor has claimed that it has these performance characteristics. Next, we'll have the local verification, which will be done by us. And finally, only when we are satisfied can we use it in our day-to-day practice and release the reports. Right. Few topics, like I said, when we validate an assay, there are about 11 points which we have to satisfy. Of course, sensitivity, specificity is very, very important, as the name suggests. Sensitive means even the littlest amount of it will be picked up. The assay is sensitive even for a very small amount. Whereas specificity means it will pick up or assay only that particular analyte that we want it to. It will not cross-react with anything else. Next is 3 things. These are the limits of detection, quantification, and blank. As the picture shows, there are very slight differences. Limit of blank is supposed to give us an optical density 0, 0. But what is the limit of blank? There is still that least amount is there, which gives us an acceptable value. Now, so what is limit of detection? The least amount which can be detected, not quantitated, mind you. It is only getting detected separately from blank. Whereas limit of quantitation is that level or that amount which can be acceptably estimated or quantitated. That is the basic differences. Now, low-level performance matters most for trace analytes and near threshold clinical decisions. Why we are bothered about these? Like I said, there can be analytes which are present in very minute quantities which needs to get detected, or there are threshold areas of clinical decision limits where we need to be very precise. Accuracy and bias, I've already spoken about before. This is another time I'm mentioning it because it's also very important characteristics when we are validating the test. And there are multiple statistical tools like bland Dalton plot and several others which are available to validate accuracy, validate an assay for accuracy or bias. Now, linearity and analytical measurement range. See, if we see the diagram, this essentially shows the progression of a reaction. If we see, it's not a straight line, right? It behaves differently at different parts of the reaction. The one in between, the linear part, when do we call it linear? When, with a change in the x-axis, there's a proportionate change in the y-axis. That is something which is linear. Proportionate change in concentration, proportionate change in the OD or the optical density. But there will be parts where this is not followed. That is when it becomes non-linear. Why is it important? Because the analytical measuring range is where the part of the reaction we will consider when the linearity is being maintained. Another important thing. Non-linearity will appear, is likely to appear. There is something called dilution, and protocols are there to avoid hook effect. Now, what is that? We know that if there's an overwhelming amount of a cross-reactant or an interfering substance, this linearity of the assay is getting hampered. So we need to dilute it. So these are the some basic characteristics of the assay which has to be validated. Now, the reference interval, like I was saying, very, very important because we have biological variation. The vendor, of course, will give us a reference interval which has been tried out on the population. If you can see the diagram on the right, this diagram is taken from the WHO website, which beautifully demonstrates what's a reference individual and a reference population. We have the entire population, the general population. A part of it becomes the reference population. From this reference population, we will choose a sample group. From there, we will take out the data, which are the reference values, and finally, we will calculate or construct the reference distribution, giving us the two extremes. Depending on what confidence interval we are applying, we will get the reference limits. And this becomes the reference interval. Reference interval is very important and it should be validated for each and every population in question because there do exist, like I said, biological variation, geographical and racial variations. So this has to be verified or validated before being put into use. Okay, this is in a nutshell how all the documents which are available, that is ISO, CLSI, and the local SOPs, how they all amalgamate to give us what we want to know. This is the interrelation between the various documents. Okay, so next going on to the more advanced, or rather I would say the more trending part of the topic, which is AI-assisted error detection. There's a huge hue and cry, AI will take our job and whatnot. It's not really that. Like I said, we will always be the brain behind the matter. But yes, AI is a tool. It's a technology. It helps us in processing huge amount of data, which no human can possibly do in that short amount of time. And usually, if it's a very refined, I would say, algorithm or model, in a very smart manner, that is without errors, and most importantly, predictive AI will give us trends, shifts, patterns, which we usually miss. So we are essentially augmenting our practice by using AI. Now, AI in laboratory medicine. If you see that we have already started using AI in multiple things for prediction, triage, pattern recognition, detection, and the best, like I said, the best thing to do is augment and not replace. Now, it can analyze structured data. Something we say is clean data, because there's this idiom in AI, which is called garbage in, garbage out. If you give it unsuitable data, it'll give you unsuitable results. But if you give it proper, streamlined, clean data, it will give you results which will help you. It can deal with all the LIS metadata that we are generating on a daily basis. Now, generalization, of course, like I said, will depend on the local workflow, similarly, and the training data quality. Now, what are the areas where AI might be helpful? Again, dividing the flow into pre-analytic, analytic, and post-analytic. These are just few examples. Say, for example, detecting contamination, something we get on a regular basis in our labs. Contamination between the different samples and the additives, the draw volumes, the vials, if they're correct or not, microclots, and incorrect collection container. Analytical, it can identify multi-analyte drift, subclinical lot-to-lot reagent shifts, calibrated deterioration, and pipetting and volume changes. Whereas post-analytical, if there are demographic mismatches, auto-verification errors, and patient result profiles which contradict historical clinical files. Now, since I'm talking about AI, we have to mention something called machine learning, the process by which AI learns. This can be supervised, unsupervised. Very simply put, supervised is we have trained the AI by giving definite set of data, definite instructions. We have trained the AI to interpret something like we want to, whereas unsupervised is something when the AI has learned on its own. It has, okay, I'll give you a very simple example for this. Say children who go to tuition classes, they get a guidance of how to go about things. That is something like supervised. Whereas a child who learns on his or her own is unsupervised. They will try to see the, I would say, the trend or the correlation, learn his or her own way. That is the difference. Both models are there, supervised and unsupervised, depending on the intention, what we are trying to do with it, we will be choosing the model. Now, predictive quality control. How can AI do that? Number one is, like I said, proactively, it can give you IQC predictions. It can give you shifts, trends, predict when something might go off rather than waiting for it. Because NMES says risk assessment even before something has happened. And second one is demonstrated clinical performance. This is actually an example where one particular study was done, and here they had used AI and seen that the percentage of accuracy that AI achieved was actually quite impressive. Okay, so this is something we can do, and actually, like I have personally used it already on some platform. Quiddle also, if I should name it, they already have on their newer machines. All this facility is available. They will flag it where the sample is not up to the mark or it has problems. It gets flagged when there is hemolysis, icterus, turbidity, etc. What else can it do? HIL interference mapping, which I just mentioned. Convolutional neural networks are actually the deep neural networks of AI, which help in thinking, learning, and interpreting. They can analyze digital images of the specimen to automatically assess the type of specimen, the quantity, whether it's a correct tube, whether the additive is correct, all these characteristics, volume and tube classification. And finally, early intervention is what we are aiming at, because that will reduce not only the wastage of time, the cost, and of course, it will help us in giving better patient care. Now, how do we integrate with the Laboratory Information System or LIS? It will help only if the entire thing gets integrated. This is again a diagrammatic or schematic representation. So from the analyzer, it will go to the middleware and finally through the LIS to a dashboard and finally for human review. Through this entire process, AI will be detecting at every level. I'll give you an example. Say, for example, starting with when the patient comes in, patient identification. We have, of course, progressed to using barcodes nowadays for patient identification, sample identification, even for blood draw. There is technology which is being used usually abroad. So AI can help us with all these things, all sorts of identifications, mismatches, the correct sampling, all of it. Next, when it moves on to the analysis part, like I said, any problem which is happening during the performance, during the analysis can also be readily picked up by AI then and there. And finally, in the post-analytic part, we can always have it review. Something called precision medicine or personal medicine, which uses multi-omics nowadays, that is based on the patient's genetic profiling. There also, AI can help us collate the data and give us a predictive analysis. Okay, so delta checks is already being done in several institutes. Now, what is the difference? AI enhanced delta checks. What is the difference? Because traditional limitations again, like I said, we are using statistical methods and that too is done at a later date. Contextual AI evaluation is, it evaluates the delta checks by incorporating clinical context also. That is also variations which might be affecting it. And finally, we have certain analytical models which will help in taking into consideration multi-analyte trajectories and the performance gains, integrating gradient boosting model. There are various models which can help in doing this. One of them has been mentioned here. Okay, so this is again a schematic diagram of how AI can help us. If we see, this is the usual results or the trend that we are having graphically plotted. Now, if we see current result is giving results out of limit, that is given. The distribution has been flagged. Total results is there. This is, of course, a statistical diagram or statistical data, I would say, but AI does it in seconds and it helps in predicting. If you see all this out of limits and there will be discontinuities, what happened and where the problem lies, even that can be detected much earlier. Be it the reagent lot, be it the calibration, be it the QC material, or a issue with the machine. This is a schematic diagram by which we can have AI-assisted reports which are faster and also far more detailed. So, predictive quality control systems, what I have been saying from the very beginning, this is something, this is a schematic diagram, how it will look. The current probability, the maximum forecasted probability of an error, expected breaches, next 7 days, all these probabilities we can have at our fingertips just by using AI. So, I would say the crux of the presentation today is that already what we are using, we want to streamline that, advance that further to give, of course, better services, precision medicine. But for that, we can integrate a tool as AI which of course will integrate intelligently so that it helps us. The control is with us, but only AI will augment the entire process, making it faster, more detailed, more informative, and eventually we can reach our goal of better patient care and healthcare. Thank you so much for patient listening.
Thank you. Thank you, ma'am, for your enlightening and well-crafted presentation. Now, I would like to call Dr. Durvashri Das to felicitate Dr. Parama, ma'am. So it is the time to inaugurate our this program. I would like to call our chief guest, Dr. Professor Moushami Nandi, to come on the dais and say something to this session.
So today is the second day of the fifth endeavor in MIdnapore Medical College. Yesterday was GCP and today good clinical practice. It is very important that the investigations are accurate and precision and correct, as our previous speaker, Dr. Paroma Banerjee from IIT Kharagpur mentioned. And actually, this is the time for evidence-based medicine. For each case, we have some provisional diagnosis and also a big list of differential diagnosis. For correct diagnosis, for correct treatment and management to save the patient, we also need good clinical laboratory practice. And today, in MIdnapore Medical College, our lectures given by head of the departments of microbiology, biochemistry, and also our guest lectures who have guest speakers who have come and taken the pain for this good clinical laboratory practice. I heartily congratulate the organizers and also the speakers. But it is very unfortunate that today we have less attendance offline. But I hear that there is a big amount in online. So I congratulate the whole pharmacology team for conducting this program. Thank you. And Dr. Bulbul, who is also a guest lecturer, who has come from Vishnavad Medical College, is the next speaker. No? Thank you.
Thank you, ma'am. Now I would like to felicitate our principal, ma'am, Dr. Munshi, ma'am, to felicitate by Dr. Paushali, ma'am. Dr. Paushali. Now I would like to call Dr. Ananya Ghosh, Senior Consultant in Clinical Chemistry and Special Immunology and Biochemical Genetics at Suraksha Diagnostic, Kolkata, to take the chair. Okay. Now, I would like to call Dr. Durvashri Das to felicitate Dr. Ananya Ghosh. I would like to call Dr. and Professor Shoma Gupta ma'am, HOD Biochemistry MMCH, to come on the dais. Our PGT, Dr. Poushali, has been felicitated. Felicitate Dr. Sushoma Ghosh ma'am. Now I would like to call Dr. Professor Dr. Kia Mukherjee, HOD Microbiology, to come on the dais. And Dr. Durvashri Das would felicitate Dr. Kia ma'am. Yeah. I would like to call Dr. Parma Banerjee ma'am to come on the dais. Dr. Poushali will felicitate Dr. Parma ma'am. Now I would like to call Professor Dr. Bulbul ma'am to come on the dais. Dr. Durvashri Das will felicitate Dr. Bulbul Purkait. Next. I would like to call Dr. Priyanka Banerjee, Assistant Professor. Priyanka Datta, Assistant Professor, Bankura Medical College, to come on the dais and being felicitated by Dr. Poushali Banerjee. Now I would like to call Dr. Arindam Ghosh, Assistant Professor, Department of Biochemistry, BCR, MRC, IIT Kharagpur, to come on the dais. Dr. Poushali will felicitate Dr. Arindam Ghosh. I would like to call Dr. Shantan Jana, Assistant Professor, Department of Pathology, MMCH, to come on the dais, and Dr. Durvashri Das will felicitate Dr. Shantan Jana. Madam? Okay, 43B. Now I would like to call Dr. Audrey Bede, Assistant Professor, BCAR, MRC, IIT KGP, to come on the dais, and Dr. Poushali will felicitate Dr. Audrey. So moving on to next topic, we are welcoming our next speaker, Dr. Ananya Ghosh, Senior Consultant in Clinical Chemistry and Biochemical Genetics at Suraksha Diagnostic, Kolkata. With vast experience in laboratory management and advanced diagnostic, she will discuss intelligent inventory system for modern laboratories. Please welcome Dr. Ananya Ghosh.
Thank you so much for, for inviting me in this occasion of Good Clinical Laboratory Practice 5th edition happening in Medical College, Midnapore Medical College. This is my first time here. I'm overwhelmed to be here, though I think I'm a part of the risk management here, right? Because this talk was supposed to be given by Dr. Amrita Ghosh, but due to unavoidable circumstances, she can't. And fortunately or unfortunately, I don't know how it's going to be. I'm here to be a part of this this program. Now, my topic is intelligent inventory systems from shelves to algorithms. So we will be talking a whole lot about stock, reagents, consumable management for the modern clinical laboratory. Before going into much details regarding this, I have purposefully kept this thing. I've purposefully kept this image of our mothers because they are who. Thank you. I've just kept the cartoon or rather the sticker of our mother. She's the first one to teach us about inventory. I think এখানে সবাই বাংলা বোঝে, right? So কিছু জিনিস বাংলায় না বললে আমার মনে হয় ভালো লাগে না। মায়ের ব্যাপারটা না নিজের মাতৃভাষায় না বললে I don't think it's justice. So inventory মা সবার আগে আমাদের বুঝিয়েছিলেন। How is it? সবার সবচেয়ে বেশি হিসেব উনি রাখতেন ডাল কোথায় চাল কোথায় কতটা চাল আছে কতটা কালকে লাগবে কৌটো চালের ভাত হবে we are all used to it এগুলো মারা সকালবেলা ঘুম থেকে উঠে নিজের পড়া মুখস্থর মতন বলে যায় তাই তো so like this is where this entire inventory thing came into being কতটা reagent আমার লাগবে where to keep it how to keep it even mothers taught us the thing of temperature maintenance কোন আমটা পচে যাচ্ছে এটাকে শিগগির ফ্রিজে ঢোকা তাই তো আর কোন আমটা এখনো পাকেনি it has to be kept out otherwise okay right so like there is a thing that we can't speak in Bengali anyways so that is what this inventory the entire thing of inventory actually means because our mothers have taught us all these things and this is actually intelligently used in labs had our mothers not even done this at our home we would have just seen this intelligent inventory management as Hebrews okay or hieroglyphics if you say so moving on to my next slide how it evolved how this inventory management actually evolved. Now, what is inventory management? This is basically the right item available at the right place in right quantity and at the right time. That's all. That is all about inventory in one word. Now, we will come to the traditional and not so traditional inventory. From traditional things, now if we come to the traditional thing, we know that in medical colleges, when we studied, when I had done my PGs, it was like manual stock keeping. Right, there were spreadsheets. Somebody was keeping the accounts that how many reagents came in, what were the expiry dates, what was the lot number, how many boxes of the lot number is actually present. They used to be maintaining a kind of ledger or kind of a spreadsheet. Excel, I think that time Excel was not so comfortable since then, but now it is being excelled, right? And so there was limited visibility across multiple laboratory locations. Like microbiology department was separate from biochemistry and from pathology. Nobody knows what was there. Right, for the respective departments. I knew my department, I didn't know the other departments. So that was very difficult and the entire lab didn't knew about the clinics. What medicine was there, was paracetamol at all available, how was it, what are the expiry dates? We were not aware of anything, even the vaccines.
So the entire thing needs to be documented, or it has to come under one umbrella, and this gave rise to the intelligent inventory. Now, now what happens is, I don't know, this font somehow changed, because in my presentation it was not like that. I'll just frame the problem. We have to frame the problem, then we have to prioritize the data, and then apply the foundation and evaluate with AI and machine learning augmentation. That's all we have to learn today. This is the detail, or this is what we will be discussing today. Now our problem is why inventory control is basically not a backstage story. Okay, it is not a back office thing. It has to be. It is very much integrated with the quality management system operating here. And for the CLIA, CAP, ISO, whatever accreditation we are going forward, for the traceability also, inventory has got a important role to play. We will come with the applications. Now, how to prioritize the data? We will come across Pareto or ABC principles, and with the KPIs and also the governance involving this inventory. We will apply the formulas, how to set the minimum or maximum stock, what should be my reorder points, what is the safety stock, what is FIFO, FEFO or SLFO, and we have to verify how do we verify new reagent lots before actual clinical release, and how this is integrated with the help of AI or machine learning, how it is augmented. And of course, there's a most important part is cyber security. Now, the shelf is the part of the analytical pathway. Just I've already said, it's not a back office logistics. It's a first quality control checkpoint of every assay performed in the lab. Like a missing tube, an expired calibrator, untraced lots. These are all logistic. These are not logistics problem, but they will give rise to my pre-analytical errors and later on analytical errors as well. And of course, it will be affecting the diagnosis, the timing, the TAT, which is very important in commercial labs or the chain diagnostic labs. And of course, the accreditation status, because everything needs to be documented while you apply for accreditation. Now, the context and the category of lab inventory. How do we actually categorize? Now, we actually categorize it into 4 parts. Let's see how. Reagent, calibrators and QC, equipment and critical spares, consumables and collections, and of course the reference materials and the NGS kits for the molecular genetics laboratories. Okay, so these are the things that we categorize. In our reagents, calibrators and QC, this is mostly involved with the clinical chemistry part or the biochemical genetics part. Equipment and critical spares involves all the departments, microbiology as well as chemistry, as well as all the other parts where high-end instruments are also there. So equipment and critical spares are important for all. And then is consumables and collections. Those are like tips, PPEs, those things, tubes or aliquots, those are like consumables and collections. And many of the instruments require certain specific or high-end consumables, which are also targets for this area, and certain reference materials like standards, controls, NGS, library and sequencing reagents. Okay, so these are high cost, short shelf life, low usage flexibility things, which contributes to the largest costing of the inventory management. Now, it's very unfortunate because the fonts have been changed. So now the inventory failure actually shows up somewhere, like in the hierarchy. It is somebody is answerable. Okay, every time we do something, there is something happening in the inventory, be it a good one, be it a bad one. Somebody is obviously accountable. So now inventory failures can be affecting the pre-analytical, analytical, and post-analytical that I have already said. Expired reagent and control use often, which is invisible at the bench. It's not corrected there. It's not caught there. And it will be affecting in the analytics like drift, bias, SD,
SD difficulties, QC failures, and of course out of control runs. In post analytical, after the result even released, we also have to recall once again. And of course, if the patient finds any difficulty or there is any clinical mismatch, they will definitely come back to us that we found that this is not relevant to our history, our medical history, and we have gone for some other lab test. I mean, this test has been done in another lab, and we are getting this kind of values over there. So we have to answer them, and we have to again go back and check if there is any failure. And of course, this will be a high cost thing for the management, because they have to, if you are actually failure there, then you have to give back the money to the patient, and often this is being taken to the medical legal cell. You have to pay and face the medical legal consequences also. So this is very serious. Now, also we have to find out the loss of reagent integrity before the use. Unexplained QC shifts, lot-to-lot inconsistencies. I have already talked about the recall thing, and now the vials also, because we often don't check the expiry for the vials. So this is also very important. Most of the places they do check and they reject the expired vials, but many of places in small labs you often find that the vials are expired. There you face a problem, and of course in long run when you document it, it has to be documented, and this will be affecting your accreditation status as well. It will be a difficulty for that. And of course, there are places of risk which will be discussed after this presentation, I suppose. Now, what are the 6 recurring frictions? Frictions are the pain points. Now, what are the pain points? One is spreadsheet sprawl. That is, multiple parallel Excel files are there. If we maintain it manually, if we go into AI, use AI, or we use algorithms, or we use machine learning, then these pain points are actually the places which can be decreased down. So, but we should know what are the pain points. The pain points are spreadsheet sprawl. That is, multiple parallel Excel files are there. No single source of information, and hence there is a lack of truth in everything. There is no transparency. Manual reconciliation against fridge counts. Now, silent expiry. Certain things have already expired, we don't know. These things often happen. Next is reactive reordering. We haven't seen that what are there in my stores, and what we have done is we have just reordered. Now the reordered quantity has already arrived. Now we have to think about where to store them. So it is an added cost. Storing is also an added cost. So we have to think that even if we reorder, is it okay to reorder? What should be my reorder point? So these things, this reactive reordering actually affects us in this way. Now there is a lot traceability gaps, hidden waste, like ordering. If we have over ordered the things that have come, we have kept them in the shelf. Only the newer things are visible. The older things goes to the back, and now we couldn't just get them back. So they get expired. Now who are answerable? Who will be answerable? So this is a hidden waste. After some days, when we go for the annual audits or maybe quarterly audits, we get to know, okay, this much of reagent was there or consumables were there, but those got expired. So this actually imposes a huge costs on the lab. And of course, the most important thing is tribal knowledge. Tribal knowledge is something we always used to have a storekeeper. Like our mothers, they knew everything. Like we also have a storekeeper. Storekeeper is a senior person who knows everything. Which is the lot now you being used? How many of this lot number reagent is there? How much to actually give to the departments? How long will they require to exhaust that? And when will they ask for requisition? I mean, they will send the requisition. That person has all the information. But if he is on leave, then we are in a soup because we know nothing. And that person also has got very good, rapport with the vendors. Now, what happens? They know which vendor, when asked, they will be supplying the right amount of thing at the right time. So that is the tribal knowledge, because he is a tribe and he knows the thing. Nobody else knows the thing in the department. And we are only running, we are taking that consumable from that person and we are running the rest. We only know this part, but the rest of the story is with him. So that will actually affect the organization, and it will be very much vulnerable to stockouts, inefficiencies, and disruption in patient care. We don't want the patient to suffer. We want to maintain a TAT such that the patient gets the report. That is our main target. Patient gets the report at the right time, right report, and of course he has paid for it. If he has paid for it, so he should be getting the report at the right time, and of course that right report, accurate report. Now, that is what about tribal knowledge dependency. And that person, he doesn't maintain any Excel, any perfect Excel, or he has got his own way of maintaining things. Now, that is basically giving rise to memory-based ordering. He remembers, but we don't know. And there is nothing transparent there such that he can actually be anybody, if he is on leave or if he retires, suppose. No, he has to give handover, but often at times we find that there is no person coming out to take the handover. So then whom will he be giving the handover? So is his memory, he won't leave his memory with us, right? So there we have a problem, and thus multiple parallel Excels files, no single source of truth that I have already said, manual reconciliation. This affects us truly. Now this is individual experience that I've already said. Manual tracking, he is actually the person for the single, he is the single point of failure. Anything happens, he is the person, but if he is not there, actually, kake dosh debo, whom to ask? We have nobody. So from there we move to the foundations. Now the classic inventory theory still rules the laboratory safe. The classic inventory theory is basically what our mothers taught. We have to know what, when, how, where to keep it, when to keep it, what should be the temperature, when to bring it out, how to use it, and what to throw away even. She knows it, and with the cost-effective manner. She won't waste a single amount of pulse. She won't waste. She would make a bharta out of it and make you, just have it with your dinner, right? So she won't waste even the khosha or the skin of the fruit or even the vegetables. So remember her, she won't waste. So she is the person who knows how to maintain the inventory, and that is the foundation of the inventory which is being followed in the lab. If you see it in a very clear manner. Now, we'll come to the thing like governance. What is governance? I'll be discussing FIFO and a few stubborn KPIs which do most of the work. Now, governance at PAR levels in clinical laboratory inventory management. Now, what is PAR levels? This is periodic automatic replenishment level. That is automatic. We want it to be automatic. How to replenish our stocks? That should be automatic. Our mother goes to the market. She knows whom to ask for the rohu fish, whom to ask for the ilish fish. So she knows everything. So that automatic replenishment is also with her. So we want that entire thing to be integrated. Machine needs to be learned, to be taught, and that will be helping us in our inventory. Now, what are the four things or the four pillars? Risk-based classification, data-driven determination, governance formula, and governance responsibilities. We'll look into this one by one. Now, this is risk-based classification. What is it? We actually categorize all things or all consumables or whatever inventory needs to be, or reagents, calibrators, QCs into categories. What are these? These are essential. This is a critical category, essential and non-critical. What are the critical things? Which requires to maintain a higher safety stock, because we can't say a patient no, that we don't have the supply, please look for somewhere else. We can't say, because these tests, this is a question of life and death, like troponin. Okay, so these tests are critical. Next is essential things. These are the routine biochemistry reagents which needs to be maintained at a moderate stock levels, and the non-critical things like aliquots or like sample cups. These are non-critical things because they are actually asked for in bulk. So there is no question of run out. In large, huge quantities are available. So that's a lean inventory. So they don't really run out. We don't run out of stocks for that. Now the data-driven determination. Now we need certain datas like average daily or monthly consumption. We require the monthly consumption such that we can ask for when we order how much we require. So the daily and the monthly consumption is very much essential. Now there are certain tests like dengue. Dengue, we have it in the rainy season or after the rainy season. Like June to September, you have the dengue. So in those cases, you need the dengue kits the NS1, the IgM, those are on the rise. So there are seasonal demands also, and these variations needs to be kept in mind, because when you are in during summer season, you don't have much dengue. So in that season, your dengue kits, it can be maintained at a low stock. But when the rainy season comes, most of course, you require a huge stock, like the COVID, IL-6, D-dimers. We had to have a huge stock then when the COVID period was there. But now we don't maintain so much stocks. Even some of the labs have stopped running them because they are outsourcing, because there is no point in running 2-3 tests. They are coming once a week, or suppose sample load has gone to less than 10 a month. So those tests are not run. So like that, they are outsourced mostly. So like seasonal demand variation. Now you have the vendor lead time. What is lead time? Lead time is you ask for a reagent. They will take suppose 2-3 days, or some takes 1 month to actually supply that quantity. So you need to know the lead time. Some vendors are there who can just at emergency situations they can supply you. Just they will be giving like 2-3 boxes now. Just keep asking them. We will be supplying the rest of the amount. So we need to know the lead time for the vendors. Now the instrument throughput is also very important. Reagent shelf life. Some reagents are like they have a shorter expiry. Some have a longer expiry. We need to know that. Test criticality. Just I have already said that some are life and death tests. So those tests you can't say no, I don't have it. So those test criticality, depending on that, we have to maintain a stock. Historical stock out data. Do we have data that we have run out of stocks and we have to close the test for that? Yes, these things do happen, even in big chain labs. So this stock out data we often faced, we have faced it, we had to outsource it, and outsourcing, believe me, it's a pain. Now we have the emergency buffer requirements also. We have to keep certain buffer. Like if we have some VIP samples and we have to run them, we can't say no. So we have to keep emergency buffer, or even if the MD managing director asks for the test, you have to run that test. So you can't say. So we have to keep certain buffer before it is actually said no. Okay, now the governance formula. What are the formulas we use? There are two formulas. One is minimum power level. What is the average daily consumption into lead time by plus safety stock? That's the minimum thing. And the maximum thing is minimum power level plus the replenishment quantity. There's no rocket science over there, so I'm not going into the maths right now. Now, what are the governance responsibilities? There are certain stakeholders. I've already told that somebody should be made accountable. Otherwise, you just ask and nobody pays heed to your thing. So somebody should be made accountable. Like we have a hierarchy, we have a principal, we have MSVP, we go and give our grievances to them. Similar thing happens in the lab also. We have the stakeholders like lab director or consultant, whose responsibility is the policy approval and oversight. Inventory management, he should be monitoring the stock levels and be compliant. Section heads who validate the consumption trends. Procurement team, they are with the supply chain, and they are basically associated with the supplier coordination and replenishment. The quality team, who takes care of the audit adherence and investigate the stockouts. And also the quality team has to take an important role here, because they have to check the lot-to-lot verification whenever there is a lot change. So they have to take into account all of these. And of course the IT and the LIS team, because they are maintaining the dashboard, alert management, when we are coming into the concept of intelligent inventory management. Now there is a frequency of review, or everything we have made somebody accountable. Now we have to do the audits. That accountable person should come and actually audit how it is going, and what is the difficulty the subordinates are facing, and how it needs to be taken care of. Now inventory, depending on the inventory type, the review frequency varies. Like if there is a critical reagent, it should be done weekly. For high value reagent or costly, it's monthly. For routine, it's monthly or maybe quarterly. Seasonal items before the anticipated demand surges. Now, what are the KPIs that we follow? That is like stock out rates, days of inventory on hand, inventory turnover ratio, expiry wastage rate, and I think all the names itself says what they are. emergency procurement frequency, vendor lead time adherence, and service continuity index. Only service continuity index is something which needs to be a bit highlighted. Now, this is the intelligent inventory governance. I have given this, the picture or the AI generated image, which says that the Kauravas had everything. All inventory was available, but they had a failure because they were not able to manage it, with intelligence. While Pandavas have a limited source, limited resource, every constraint was with them, but they were intelligent, with, of course, with the help of Krishna, and they managed it efficiently to just glide over. So that's what intelligent inventory is all about. Now we get real-time consumption data with the help of AI. Of course, with machine learning and AI together helps in demand forecasting. We have dynamic stock, safety stock calculation. It's automated. It's automated such that when the reorder point is reached, there is an automated PO generation. PO means purchase order. There's an automated purchase order generation, and that purchase order goes automatically. It's mailed to the concerned authority for if it is signature required, then for signature. If it is for to the vendor directly, then to the vendor. So that's automated reorder trigger, and this goes in on and on. Okay, and also there are automated alerts, because if there is a sudden rise in some tests, suppose in the dengue season we had predicted something, like during COVID we have predicted some that we will be running this much of tests, but suddenly due to COVID rise we had a huge number of IL-6 coming up. So then even the demand forecasting couldn't tell, but we had an alert system such that the alert actually told us, okay, now you have to reorder in this frequency. So that is continuously, it's like a moving average. Okay, that is continuously upgrading that this test, because the sample load is increasing day by day. Marketing people are going in and around. They are coming up with more and more test requests, as well as the number of people are increasing for any labs. Like when I joined my lab in 2022, the sample load was like 1500 per day. Now it is like 5000 samples per day, 5000 tubes I'm talking about. That was 1500 tubes, now it is 5000 tubes. So you can well understand that this has increased a whole lot. Now, of course, the demand forecasting then is not same as the demand forecasting now. So this has been changed, and it is continuously upgraded. So I think 6 months later it will be 6000 tubes. Then my automatically demand forecasting will go up. And also the alert thing will also be changed. And depending on that, our job is actually to see if AI is actually doing their work or if there is a fault somewhere. Just as Dr. Poroma said, AI can't replace us. That is what we require. Our intelligence requires. So they are helping us some work which if manually done, it will require much more time, there can be chances of manual error, but if AI is doing it, then the chances of manual error decreases. Of course, there can be AI generated errors. We can, we already know that even if we feed some data, they do make some mistakes. So AI generated errors can be there, but if we know the subject, then we can detect the error. Our work is to detect that error. So that's how there's an optimization thing. Now, I was talking about the Service Continuity Index, or SCI. What is it? In clinical laboratory, inventory success is not measured by how much stock is stored, but how consistently patient testing services continue without interruption. The service basically should continue. That is our aim. The management wants that my lab should run. That's it. I can't say no to anybody, and my lab would never stop. Whatever test I have started, I can't say no. Okay. So what happens, I'll just give an example, like SCI percentage, it's calculated in percentage. Like you just follow this, the box. A laboratory operates for 365 days a year, and 3 days with reagent related service interruption occurs. Now what happens? The SCI changes. It's like 365 minus 3 divided by 365 into 100. That is 99.18%. That is interpreted as laboratory maintained uninterrupted service for 99.18% of the year and not 100%. Now our aim is to reach that 100%. So that's what this service continuity index, that means my service should be continuous and it should never stop because of issues like inventory. That is the concept. Okay. So, and every decimal point gained in SCI translate into uninterrupted patient care. Like 99.18% becomes 99.20, 99.50. That means we are improving. So that's the improvement thing. Okay, now the 5 P's of inventory governance. There we have 5 foundation. It's like a L'Oreal ad. 5 problems, 1 solution. Like 5 foundation, 1 goal. And the goal is uninterrupted patient care through intelligent inventory governance. Now, what are the 5 P's? Product, that is what to stock. Planning, how much to stock. Procurement, when and from whom to buy. Placement, where to store. Performance, how well we are managing. So that's the 5 P's. Our L'Oreal. Now, 4 classic foundations. What are the classic foundation? How do we maintain that? Now, we have a term called stock keeping unit or SKU. SKU, stock keeping unit. What is it? It's one identity, one item, one identity, one source of truth. That means if I say glucose lot number 0002, it is glucose lot number 002 in the department as well as in the inventory. If this goes to the microbiology, it also it's the same glucose reagent 002 lot number. So that's one item, one identity, and one source of truth. And whenever this decreases, the quantity decreases, the same thing is reflected everywhere. And if the data is transparent and available to whosoever comes. Like if a consultant goes, if the lab director goes, if the inventory person goes, or even the managing director. So everything is standardized. So we maintain a catalog, like one catalog ID per item, which is used by LIMS. Purchasing stockroom, no synonym. That is what I mean. What is meant by SKU? No synonym. No same thing, different name between freezers. Even if you store, if I store it in freeze A and then in freeze B, that doesn't change. Now, minimum stock thresholds. Like each item has a documented minimum quantity. It is for all items. Okay. Crossing it must trigger an alert, just I have already said, and it should not depend on any technologies. Like my SIC is getting 4 boxes of glucose reagent on the day, and that is reflected. 2 boxes are being used up, so 2 boxes are remaining. That is reflected everywhere. That the department has received 4 boxes, 2 has been used up, 2 is still there. Now the department needs to be replenished, and automatically when the replenishment occurs for the department, the stock over in the inventory that gets down. And if it reaches suppose the minimum order quantity or the reorder point, then automatically trigger is generated, an email is generated, automated PO is generated, and this thing happens. Now, barcode based tracking. What is barcode based tracking? We have every lot and package. We have seen that they are having a barcode that can be scanned, and each box is scanned. They are being added automatically. Like I scan a glucose box with a lot number +1, second box +1, third box +1. So this is being added up. So if I have 10 boxes, it is automatically as I scan, it's reflected over there. So there is no kind of no blind points. Everything is transparent and clear. Now, there we should be having periodic audits, and audits from all points of view. Like we are going, just checking up the documents and not looking into the actual status. It's not like that. We have to check the shelf as well as we have to check the document. Everything should be audited. It's difficult, but it should be done. Now, this audit can be an annual full-time audit. Most of the places do an annual audit, but in big labs or big diagnostic chains, they do have a quarterly audit. I think in the departments here also, we have certain audit frequency. Now, who owns what? Once again, you have that thing, accountability. Who owns what? Lab director, quality manager, section supervisor, technologist, and storerooms. They have been given a significant activity or the significant responsibility that you have to do this, and you are accountable. Anything happens, anything goes wrong, I'll catch you. So everything, like the lab director owns the policy, what policy has been done, he is having the ultimate accountability. The budget, the supply quantification approvals. Quality manager is assigned with the traceability framework because he should be taking care of the lot verification process and the accreditation part. So that entire thing depends, that is on the quality manager. Now the section supervisor is with the minimum maximum level. Just I have already said, 4 boxes are issued to the department, 2 boxes are finished up, 2 boxes are there. That this responsibility with the section supervisor. And of course the technologist and the storeroom, he goes inside the storeroom and brings out. So he is also responsible, and a register should be maintained about who has taken out the reagent, and he should sign. What was the expiry date? Because we need to check out whether that thing was, whether the short expiry thing, that is used up, or somebody which just near expiry is used up, or something that that could have been stored for a few more months that has been used. So everything should be documented. Now match the stock to the workload. Now we have, yes. Now stock should be matched to the workload. That is what we have been talking about. Our mother knows everything. 250 grams of rice each day. And if we have 1 kg, so divide it, and such that we have 4 to 5 days dal. And if we are using musoor dal one day and moong dal another day, then of course the ratio would change. So basically that stock would match the workload. So we have the inventory, the test menu. The inventory has the test menu. What are the consumables that is required for the test? Not only the reagents, not only the aliquots or the sample counts, not only the tips, the probes, everything needs to be documented. So inventory itself has an entire menu for it. Now quantify the consumption, at least 12 months of usage by SQ, and of course we will be setting the levels, and that has to be documented by in an SOP and has to be reviewed annually, at least annually, if not more. Now don't let the box decide your inventory. That's something very important. Why it is dangerous? Now, what is actually being said over here? Don't let the box decide your inventory. Suppose I require 100 tests. I require 500 tests per month, and the company vendor comes and tells me I have a box that will be this box contains this will give to 1,000 tests. Shall I take that box? Of course not. Because this 500, I require only 500 tests. He will say you would never go out of stock anytime. But my requirement is variable. It is an approximate. I require 500 tests a month. But it is very much approximate. Some months I require 250, some months I require 750. So if I keep 1,000, there is always a possibility of wastage. So I should definitely decrease the wastage. To decrease the wastage, I should never let the box decide my inventory. I will decide, and of course, I'll decide my reordering point myself. And I won't be influenced by anybody. Now, why is it dangerous? Because, of course, it will lead to overstocking, higher carrying cost, increased expiry risk. I have already said storage constraint. That is the most important thing. I take up a box, it is having 1,000 tests. I think that my inventory would never run out, and I keep this, but I will require place for storage. But the 500 test box is a bit smaller, so it will require lesser space. It is okay if you are having an inventory space at your own place, but many labs, many smaller labs, they don't have an inventory place at that location. They have to find out some rented house for that. So you have to pay more rent. Why should you pay more rent? You have to carry that box. You have to pay what to say, chota hati যেগুলোকে আমরা বলি. So like you have to ask for that. So that will increase the carrying cost and the transportation cost. So why to increase cost? Our idea is to decrease the cost, and that is what your management wants, nothing else. Now the distorted forecasting. Consumption data no longer accurately reflects now the replenishment needs. So this is distorted forecasting. Now, of course, there is a clinical risk because too much stock can increase the likelihood of expired reagent and emergency replacements. Now, as I have already said, that the demand is not flat. The demand is, most of the demands for the routine test is like the first one. It's a little bit of wavy thing. The curves are the sigmoid shape curved are the trendy. Some tests which comes in during trends or the seasonal variation. Some are increasing trend, and some had certain erratic. I mean, these are event driven. So this kind of the demand can be of 4 types. Okay. So hence, one rule is not specific for each of them. It is not applied for all. It's very much customizable, and each test or each test menu requires a specific attention. Now the corridor of safety. What is it? The corridor of safety is basically what is it? The minimum order, the maximum order, and the reorder points. We should be maintaining a minimum stock, or what is the minimum quantity that needs to be ordered? What is my ROP or the reorder points, which is equal to average daily use into lead time plus the Thank you. The ROP and the maximum, that is how much maximum quantity can we actually store. So that is minimum, maximum, and the reorder points, and that is the corridor of safety. We should be between the minimum and maximum. We should not exceed the maximum, and we should never go down beyond the minimum. So that is our corridor of safety. Now the ROP, that is average daily use into lead time plus the safety stock. I have just given an example. Just check the purple box that side. Lavender box, I suppose, yes. Daily use is 40 tests. Tests per kit is 100. Now, daily kits, like if you calculate it in daily uses, that comes to 0.40. Now, lead time means when the vendor takes 7 days to deliver after you have ordered. Expected use during the lead time comes to 0.40 into 7, that is 2.8 kits. Now, delta daily kits. What is delta daily kits? This is basically the variability. Every time I don't use 0.4 daily kits. Okay. Every day it's not 0.4. Some days it's 0.2, some days it's 0.1, some days it's 0.6. So there is a variability. And what is that is the delta daily kits. That is 0.12. That is daily variation in the kits usage. And entire thing is kept in mind with the advanced formula like Z into delta D into root over L. That comes to the safety stock 0.74 kits, and ROP reordering points comes to 3.5 kits. What it means that if I'm having 3.5 kits, I should start reordering. Okay, and my safety stock, that is, I can't go beyond that. 3.5, when it is 3.5, I should reorder, or my reorder point, it should be triggered. All the POs alert should be triggered over there. But I can keep myself calm and cool till 0.74 kits. After that, I have to stop, or I have to think something else. Now, 2 physical tires of stock, working stock, and one is the reserve stock. What is working stock? Which has been issued to the department and this is being used. And the safety stock, the stock that is kept in the inventory for future use. Okay, so this is the thing, that is working stock and the safety stock.
Everything got changed by presentation. It's very sad. Yes. Now you should have told me, then I could have brought my laptop. It's very bad. Anyways, I'll just go through. This slide actually said what should be the temperature requirements. Now the temperature requirements is definitely that should be definitely specific for certain things, like for like +2 to +8 degrees Celsius. That's typical of our clinical chemistry. Okay, and we have to monitor it regularly, keep a log, and of course, this is very important when it is for the accreditation thing. Okay. I'll skip this. Now this is a checklist, like this slide named the doc checklist. The doc checklist means if I consider my inventory point to be the doc, what should be my checklist? Okay, I'll be sharing the presentation with you people, the actual presentation, because here I find there are a whole lot of things which is not supported. I'll definitely be sharing with the organizers. Please feel free to take the presentation. Okay, I don't have a problem with that. Now, what is it? What are the checklists? The checklist of visual integrity check, because I have to check the bottles. Personally, I have to check the expiry date. I have to check the lot number. I have to match that what was the order, what they promised, and what have actually reached us.
have to check everything. And of course, the COA, that is a certificate, or the we call it the SDS, right? The safety manual actually. Okay. I don't find much difference. See, this is the AI failure. The technical glitch, huh? Yes, this is an AI failure because they haven't checked the entire presentation whether it is supporting. Otherwise, I would have brought my laptop. Anyways, I think I'm very clear with my discussion. Yes. Now that is what I was telling. Working stock, reserve stock. I've already explained. Now this is where I stop before the technical thing. Every reagent has a temperature contract, right? The 15 plus 15 to plus 25 degree 2 to 8. Then we have the minus temperature 70 to 80. The same thing. Okay, and see one unbroken chain. Anywhere a glitch, like a technical glitch right now. So anywhere there is a problem, the entire system just falls apart. Okay. Now, like supplier COA, receiving log, storage lot verification, analytical run, patient result, everything. A point anywhere you face a difficulty, you have to go back, recall the entire thing, and come to zero. And of course, there are certain guidelines given in all the accreditation by all the accreditation bodies, CLIA, CAP, ISO, NABL, all the checklists, they have a very specific mention about the inventory. Now, I was talking about the doc checklist. Somehow it is actually visible right now. So, like, what are the things that within 30 minutes of arrival, we will be checking, like visual integrity, match order, packaging, slip and items that I've already said, and capture the documentation, that is certificate of analysis, safety data sheets or SDS. And if this any of this is not available or it is disrupted, then it goes into quarantine. Okay. Now, when I'm actually doing the checklist or going through the checklist and checking, we have the barcode and record in LIMS. But we use the barcode and then record it. We have to store it under the condition which has been mentioned. And of course, the lot verification data needs to be taken care by the department and the quality cell. Now, what is quarantine? Quarantine means any of this reagent thing, they don't come with the COA or the certificate of analysis. They are quarantined. That means like COVID, we have to keep them separate. What do? We cannot use them for patient testing. It is not released into the inventory. It's not kept in the shelf that the other reagents are kept for, or the before the reagents were kept at. Now, we cannot go for this routine consumption also. We have to wait. These are physically segregated, electronically blocked. See, it has to be electronically controlled, that nobody can actually come and issue that. Somebody with an evil motive comes and issue that, and the entire system falls apart. So even nobody can't issue because it is blocked, and whenever you are trying to issue it will be giving an alert, and it will go to the respective authority that somebody is just creating a foul play. Now, held pending receipt of documentation, and in the receipt of documentation that you give to the vendor that we have received this much, the payment will now be released, or the rest of the payment will be released, that is kept pending. So the vendors, they are very much into it, so they do take care of them, but these things also happen for the smaller size labs as well. Now, which kit leaves the shelf first? We all know about that. First in, first out. There is somebody which is coming right now. That will be first out. Then we have the first FEFO, and then we have the shortest shelf life and first out. Okay. So these are the things. That is the first expiry, first out. FEFO is first expiry, first out. Okay. Something which is having earlier expiry, that should be given out first. And then the shortest shelf life, that is given out first. So these are the things we take into, whenever we issue inventory things, we keep this in mind. Now, lot verification. I think most of the things has been already covered while the quality accreditation and the validation method validation part. The same thing is applicable here also. If we are giving a new lot to the department, before using the new lot, they are doing the lot verification. So lot verification, many of the labs are having their own protocol, but mostly they run the more than 2 levels of QCs are run with split sample testing, and more than 20 parameter, 20 patient samples are run, checked if the values are fine, with covering the whole range of values. So that is done, and then after that, if the consultant feels okay, the lot is okay, the lot is fine to be given for the patient results, then the director or the QM signature is there, and this lot is being used. And if there is a lot failure, then we have to stop there. Okay, we have to just give it back to the vendor. आपका खराब चीज है, लेके जाओ भाई, हमको अच्छे वाला दे दो. Now, from spreadsheet to system of record, we actually whatever these things were there, these things were the foundation right from in the traditional days also, and nowadays also, even if we are not so traditional. Yes, tradition continues and it's very golden. So we don't forget, and anywhere this not so traditional thing fails, our tradition comes into play with the rescue things. So we have a master catalog, barcoded transaction, software alerts I've already discussed. Now LIMS integration, vendor and order ledger, that is, of course, I have already said, and audit ready exports. Everything I told you that there are specific clauses in all the accreditation body checklist. So we have to keep the documents ready for the audit to face the audit. So this is basically from spreadsheet to system of records. Previously, we used to do manually. Nowadays, we use a whole number of softwares, apps are available. We can use them. Now, 6 numbers that tell the truth. We want, of course, 0 stockouts in month. The expiry rate should be less than 3%. It's basically some data that we want, but every time it's not like that. The inventory turnover should be 6 to 12 per year. Days of supply should be more than 14 days, and SCI or the continuous running should be more than 95 days with lesser lot verification fails. In fact, there should be no failure actually. But however, there are certain failures, but there should be. Now, the vital fuse, that is where the ABC and the Pareto chart comes into being. This Pareto chart, I am very sure this is a management thing. Okay, but you see, every time you have a skin of any vegetable, you make a bharta out of it. So Pareto is like that. Okay, you have something to make some sort of clinical, some sort of mathematics in it. You find the Pareto over there, put it there. So what is called Pareto? Pareto is ABC analysis. ABC analysis, how we do it? There are we categorize the consumables into three categories. One is A, one is B, and one is C. What is A? A is the most important things whose stockouts is not acceptable. Those are the critical most things, and they are very much costly as well. The high cost, the critical most things are basically comes into the A category. What are the B's? B category comprises of those things that should be, that is of the moderately essential level. Okay, that means their stocks we should be kept at moderate, like the routine chemistry ones. They are kept at moderate, and we usually want them in larger quantities, more than the A quantities, of course, and they are of optimum cost. And the last one are the C categories, who are basically of the least cost. It's like two paise per piece, suppose, like that. It's very least costly, and you order them in bulk. Okay, like 1,000 sample cups, like that. So these are the categories, and these are the vital fews that I'm going to tell. Okay, so the small minority of SQ accounts for the majority of the inventory value, expiry waste, and stock out risk. That is a critical thing. That is the A's. The A's basically, those are the small minority. That is the majority of the inventory value, the expiry waste, and the stock out risk. They have a high risk of stock out. Now that has been given, the Pareto thing. So the Pareto comes out with a cumulative thing. I am very much sure that everyone is through and through with Pareto because of whole number of this GCLP running around. So three categories, the vital few comes to the A categories, and the 5 categories are the useful many. We require in bulk, those are very useful, but they are not the risky group. Okay, so what we do is we add the we cumulate it. Marker, yes. So we this cumulative things comes to 100%, and we see the 80% of the cost is for the A people, for the A items. The remaining things comes with those. The 20% belongs to the B and C. Of the 20%, suppose a 15% comes with the B item and 5% of the cost comes to the C items. That is how the 80-20 principle is applied to the clinical laboratory. Now we don't want any stockouts, so we just run from machine learning, IoT, or Internet of Things sensing, automated reordering, where AI augments the foundation, and however we augment it, we don't replace. So we don't replace the quality system that surrounds them. Now there are certain toolkits. The toolkits, I'm just going through the names like Arima, Sarima. Those are the certain softwares. Airtable is another of them. You can just go through in Google. It is very much available. Of course, paid. Okay, so you have to spend some money if you want to use it. And everything, what to order, when to order, how to order, how much to order, how much to pay, reordered quantity, whatsoever, whatever your questions are, it is given by them. Just you have to pay a little bit, and you have to know your subject, and of course how much tests you are doing, what is your turnover. That data that I have already told about, the data driven thing, that data you have to be with you such that the data, when it is available, you can just go beyond and beyond whatever. Now recently AI come into being, we have also come up with dashboard alerts. Okay, the dashboards are like in my lab, there is a huge television kind of thing, a monitor is there. It's like a drawing room status. Okay, we have that in the lab where it is showing every time what is the test, how many samples are coming in, how many samples are being reported on time, what are the TAT failures, why the TAT failures are there, how much in hold, why are those are in hold, where the problem is, if there is no reagent or the reagent is pending from the inventory, that is also being showed. And if the reagent has been completely stocked out, that has also been shown. Everything comes under the dashboard, and if you just see at a glance, you can have all the data with you. And even it is now connected to all the satellite labs, because that is a diagnostic chain lab. So chain labs are having certain satellite labs also. Those satellite data is also available in the dashboard. So the somebody who is sitting there at the head office, he or she can actually find out what nonsense is happening inside the lab. I call it a nonsense because সামনে বসে ওটাই দেখতে হবে, আর কিছুই দেখি না আমরা। So something our TV is running and you have so much data, red, green, yellow, blue, and your entire attention goes over there. So this dashboards is being coming up. I mean, this is a very much kind of 5 problems, 1 solution kind of thing is coming up right now in my lab. Now, these are also giving the forecast models. Master catalogs are also being shown. Barcode scanners, how they scan the RFID things, everything is being shown. The temperature status, even the temperature log maintained, who is maintaining, his name is also being shown. Like that. It's like everything is transferred and management is coming, seeing that data and giving a whole lot of jhar and going away. Okay, so it's very painful for us also. Anyways, now this is a case-based application. I won't go into much details. Now, our idea is basically we should be looking into fewer stock out, less expiry waste, cleaner traceability. That's all we want. Okay. And of course, what goes wrong? Wrong is, of course, if you have a poor data quality, just as Dr. Paromash said, AI is basically if you give garbage, it will give out garbage. So if your data is poor, if you are having a whole lot of nonsense happening in your data, if somebody is manipulating in data, then you are in a soup and you have to answer. So the poor data quality is always questionable. And of course, the most important thing is cyber security. If the cloud thing, if the cloud computing, I am very sure that most of you are being acquainted with the term of cloud computing and all. This, if the cloud thing is disrupted somewhere, if the middleware is disrupted somewhere, if the firewall protection is disrupted somewhere, your data is misplaced or it is given to somewhere. That means the policy or the confidentiality of the company goes out. So that's a thing that's very important when you are using AI. So the cyber security part is also very important. Of course, the costing, the governance for IoT and 5G, it is also a huge cost. But yes, we will soon be acquainted with so much of it that the costing wouldn't affect us much. Now, what are the guardrails? Guardrails means that those which are guarding me from getting into bad things, like treat models as devices. Or whatever models or whatever AI table I was talking about, Arima, Sarima I was talking about, those are basically models. Okay, those are devices and they should be treated as device. Like you have your mobile phone, if somewhere goes wrong, you just go for another mobile phone. Or you go to the mechanic and just get it done. Right. So these are basically devices and you don't believe it. Like you don't believe your phone. What goes wrong? Your Facebook data gets hacked. So like that. And there should be clean data. Unless you give a clean, transparent data, of course, that should be a garbage in, garbage out concept. And of course, you should be connected as well as safe. That I have already discussed. Now, if I want my system to be integrated intelligently, then I can actually plan into 4 phases. The 12 months can be divided into 4 phases. Like I first get into the foundations. What are the foundations? Like master catalog generation, SKU, inventory, SOPs, the owners, the supply chain, everything. Those are the foundations which should be first jotted down. Then we have to digitalize. Everything should be Excel. The Excel or the that should be supported by LIS or whatever things or whatever system you have. It should be used for forecasting, and whenever if there is any problem anywhere, that forecasting will help me to get into the root cause also. And then if everything is done, we'll scale up to the next level. That is how we plan into 4 phases. Okay. Now my take-home message is very simple. That is, inventory is not a back office logistics that I have already said, and it's a basis of quality. Even before your sample enters into your lab, your inventory starts. Without inventory, you can't run a sample even. So inventory is the first thing, and of course, for inventory, you require money. That's it. Unless you have money, you have nothing. So inventory is most important. It's a quality driven process, and it's the basis of quality. The most overlooked part of the lab is inventory. They just get a small place somewhere in the attic kind of thing, but they play the most important role. Now, once again, our mothers are the founders. So for the inventory, as I said, so the classic foundation works for everything. Works for small, big, very big, whatever. Pareto ABC I have told you, you can apply it anywhere you like, you feel like. You can apply your Pareto in your household as well. Okay, 80% of my salary goes into sarees because I'm a sari lover, like that. Okay, so you can just put Pareto everywhere. Now AI augments the foundation, it doesn't replace them. And of course, start narrow, validate, and then scale. What is it? When you start, it's your start can be even today. You're not organized, but you can organize today. Right. So start it right now. If you start, you start narrow. With suppose 1, 2 parameters you start with, then you scale up. At one go, if you take everything, you run into a mess. So you start, you validate, you then scale up. And thank you so much. I'll definitely be sharing my PPT for all those Hebrews and hieroglyphics, what I was talking about. I hope I'm clear. If you have any questions, we can take it.
Thank you so much, ma'am, for enlightening on such a critical topic of laboratory management. I would like to request Dr. Indrani Dalal, ma'am, to kindly felicitate Dr. Ananya Ghosh. Our next speaker is Dr. Priyanka Datta, Assistant Professor, Department of Biochemistry, Bankura Sammanoni Medical College. She is a clinical biochemist, NABL assessor, educator, and organizer of several national workshops and conferences. She will discuss on ECAS and proficiency testing in NABL compliant laboratories.
Thank you for inviting me in this GCLP training. So my topic of So my topic of discussion today is external quality assurance or ECAS and proficiency testing in a NABL compliant laboratory. So working. So what is proficiency testing? Proficiency testing is needed for a laboratory assessment most of the time when we think how good or how bad my laboratory is working. If someone is coming from outside and getting a report from Bangalore and asking us, is that report is fine with your lab also, or I am going to get a different urea level if I am doing in your lab. So how can I be assured about my result? How can I say that yes, whatever you are going all over India or over world, what report I am generating, that will be the compatible to the all over world. So proficiency testing or ECAS help us giving that confidence. So by definition, it's a process of assessing laboratory performance by which multiple laboratories analyze the common sample and an outside entity will collect and evaluate that result. So as Dr. Paroma already said, internal QC is very, very much essential for our daily monitoring. every day we have to run that daily quality control. Whereas the external quality control, we run once in a month or maybe in a 2 months, once a time. So that's the difference. So a little bit of history. External quality control came back in 1940s and from India started in 1977 from CMC Vellore. Nowadays we have lot Biorad, recast from Randolph, then CAP surveys from UK, NEQAS. Then for the pathology, hematology, we have from AIMS and Gangaram also have for microbiology. Max Hospital have their ECAS, Metropolis have their ECAS. So a lot of ECAS companies are there and we can go for it. So basic principle for an ECAS scheme. So the outside or third party, they will prepare a common ECAS sample and they will send suppose to the 100 labs. The lab will receiving the sample, they will do the test, perform the test and they upload that result in website or they will send by post. What again that organizing laboratory or company will do? They will analyze the result and then they will prepare a report. Either they will send it by post or they will upload in a website. And then as a consultant of a laboratory, we have to check how good we are compared to the other. This is the basic principle of our whole ECAS scheme. So, common PD material, monthly tabulation will be there and a summary report. So, what is the basic and main purpose? That is the challenging participant of our quality system, how good we are, and the answering to the other lab that my creatinine level is 0.7, so it should be 0.8 or 0.9 to your lab, it can't be 6 or 7. So inter-laboratory comparability, it improves and encourages the lab that they are doing good. If our lab is doing a poor performance, that can be an address and it's a mandatory for NABL. So we have to go for ECAS scheme if we are planning to go for a NABL accreditation for our lab. So what is a good PT material? Whenever we are planning to start any PT material or procure a PT material for my lab, what should we check? First one should be internationally recognized. Means I can take another lab samples and just do the test and say. So it should be internationally recognized. And very, very important, how many participating labs are there? If we are getting a good PT product, which are using by the 100 labs, 500 labs, so I will be confident about my result. If I am choosing a PT material which is only used by 10 labs or 20 labs, I can't be that much assured. Then, how many samples they are sending? If they are sending every month one sample, I'll be more assured. If they are sending once in a 3 months or once in a 4 months, then I'll be little bit confused if my performance is really good in all those months. Then rapid turnaround report. I generate a report, I send them, but they are giving me the report after 2 months. So there is no point of that. Rapid reporting is very much needed. And preferably electronic results. Sometime in post, we may lose the report. So always we have to check this ISO ISC 17043 accredited provider. Whenever we are choosing, we can go to the ISO guideline and we can check that company is valid or not. So operational integrity, and this is the most important point, what we find the problem in the labs. Lots of lab, whenever they are receiving our ECA sample, they give an extra calibration, they give an extra maintenance, and will be run by a very specific senior technologist. It should not be done. ECA sample is just like a normal patient sample. So whenever we are receiving it and we are planning to run it, just do it in a normal way. Run with the patient sample. And lots of lab also do that. They run it for second time, third time, get a mean, and then upload that mean result. We should not ever do that. So it should be a normal, as like a patient sample. Any staff can run it. We don't need any experienced or senior technologists to run it, and should not compare with another lab. Whatever report I am getting, I should upload that one only. So this is for a biodata. It's look like this. For 12 months, they give us the date when to upload. There will be assigning lab number. There is also a laboratory name should be also coming, and this is for the clinical chemistry. So there is another term called true value, or we are going for group mean. Why we have to choose that group mean? With sufficient participation, whatever the collaborative mean is coming, that is mostly close to our true value. So always we are going to talk about the group mean. How much my lab value is different from that group mean. So interpreting PT result, different companies or different system uses different PT interpretation result. If most of the labs are using SDI, standard deviation index, few uses Z square, like AIMS use Z square. Then VIS is used by UK. Then EN number is not using by many because it's mostly for the uncertainty of measurement. And then RICAS target score. So if anyone is using random CICAS, they will get target score. So for different interpretations are there. So first one, I'll not bore with the formulas and all that, just the interpretation part. So standard deviation index, it has to be between -2 to +2. If we are between -2 to +2, we are in a very good position. If we are in -2 to -3, that means a warning. For suppose of glucose, I am getting SDI is 2.5. That means my glucose level is not that much proper. We have to little bit careful that next time onwards, we have to very sure about the glucose value. If it is more than 3, then it is unacceptable. We have to stop that and we have to check wherever we are going wrong. Z-score is very much similar to SDI, classical Z-score. About the robust Z-score, we use for the non-Gaussian distribution, where we take normalized lab result minus our group median with normalized interquartile ratio. And there is another term called running mean z-score. That means last 6-month average of our z-score, which also help us to check in which month our thing was gone wrong. So usually biorad look like this. A pointer কি কাজ করে না? Okay. So if suppose this one for AST, it is like yellow means the SDI is more than 2, but it's acceptable minus it's working, madam. No, it's working. Minus 2.21, that's why it's coming in a warning sign. And for the LDL cholesterol also, it 2.02, that's why it's coming in a warning sign. So this is our Z square, and this is our RMZ means from last 6 months, how the parameter is doing. Next one, various index score, BIS. Usually, most of the lab in India don't use it. In UK, they use BIS. Their interpretation is a little bit different. If it is less than 100, very good. If it is more than 200, that will be not acceptable. Within 150 to 200, called warning, or there will be a room for improvement. Then EN number, again, it's depending upon the measurement of uncertainty. We can very well check the measurement of uncertainty from our CV percentage. CV into 1.96 will be our NU, measurement of uncertainty. From that, we can check the EN number. So this is the specialized one. EN number, we can go for variance index score. And if someone is using Randolph's data, Randolph's target score, if it is less than 40, will be unacceptable. We have to reject that data. More than 50, acceptable. 41 to 50 will be warning sign. They don't say warning sign. They say there is a room for improvement. If we are getting 71 to 100, it's good. So why we have to thinking so much about the PT or ECAS? Because for the NABL, it's a mandatory. We have to go for NABL accreditation and have to go for ECAS. In which parameter we can't assess the ECAS? Any idea? বাইরে থেকে স্যাম্পল এলো সেটা আমরা রিপোর্ট যদি করি ভুল হবে কোন প্যারামিটার এনি বায়োকেমিক্যাল প্যারামিটার এনিওয়ান রিমেম্বার শুনতে পাইনি হ্যাঁ ইউরিন স্যাম্পল ওয়ান বাট মেট্রোপলিস হ্যাভ আ ইউরিন ECAS definitely thyroid lipid is fine sir like bicarb ammonia they can't send it no হয় না তো সেটাই বললাম কার পিটি হয় না জিজ্ঞাসা কোশ্চেন so ammonia we can't do the PT in that case we have to go for alternative methods like we can go for split test we can go for a blinding method other than that whatever ECAS is available NABL mandate that whatever it's a NABL lab or you are going for a NABH accreditation for a hospital you have to go for ECAS only those like our ammonia like our bicarb then G6PD, PTH, which is not stable for longer time, we can go for an alternative method. হচ্ছে না Someone stop. ঠিক আছে So this is the full Biorat PT result report, how it will come to you. We have a problem classification section, and the very important part is corrective action. So it's look like this for any of the parameter. My result is 325, and what we have to check is our peer. So what is the peer group? That is very important. Peer group means using same instrument, same method, and same reagent combination. So always we have to check for the peer group if we are having. Suppose my peer group is very less than a 9 lab is using the same. Then we can go for a check for a method. Means how many labs are using my method but maybe a different instrument. So this is like peer group, how many are there and how good we are with them. So this is N means how many labs are participating, their mean is the CV, and then our Z score is there, and then RMZ is there. So this is the RMZ last 6 months one, how good we are running. So all the levels are within -2 to +2, so acceptable. This is another one, Uden plot that shows if we are going for a positive bias or negative bias. Z score are absolutely fine within the -2SD to +2SD, but we can see here we have a tendency to have a positive bias. We have to check this Uden plot also. So this is different machine, how they are running, we can check. This is for a hematology one, for AIMS, how they are doing. Here they use that robust Z square, that is they use the normalized IQ word. So here we have to check twice and then we can check that Z square. This is for the CMC value. They also give like this. Monthly summary report like that. So we can very well check the number of lab 737 and then CV percentage, my value and Z square, and they always give the interpretation acceptable, not acceptable. This is for the microbiology, ECAS. So they have to run in a similar way. They usually send a question also with it, and the microbiologist or lab director has to answer that. For all the serologies, we have all the ECAS. We can run through it. After 12 months, usually Biorat and CMC Valor gives a whole year data together. So at a glance, we can see and check how good we are. So here, only one point of time, glucose went for a warning sign, and only one point of time, triglyceride went for an unacceptable result. After that, everything was fine. When an NABL audit happens to lab, we have to show this summary report, how good we have done. CMC will also give like this. They have ranked in a group how many labs are participated. They give the overall Z squared OMZ and which grade you are falling, like this is a grade A. So this is the summary report. We have to show the NABL auditor when the audit is happening. So all the good parties we talked about. In part, they will release the report and they say it's a warning sign, or they say it's unacceptable. So now come to me as a lab consultant, what I will do. That's the main thing we have to do. So we have to go for a নো আনসার। কি মোস্ট কমন ভুল? আমরা একটা ক্রিয়েটিনিন রিপোর্ট করেছি, আমরা দেখছি সেটা আনঅ্যাকসেপ্টেবল এসেছে, আমাদের জেড স্কোয়ার একদম হে ওভার, মেবি আমাদের জেড স্কোয়ার এসেছে 10। কোথায় ভুল হতে পারে সবচেয়ে কমন? একদম, এটা হচ্ছে সবচেয়ে কমনেস্ট পয়েন্ট, মিস এন্ট্রি। এটা মানে ক্রিয়েটিনিন বা পটাশিয়াম যেগুলোর জাস্ট সিঙ্গেল সিঙ্গেল ভ্যালু ভীষণ ভাবে ডেসিমালটা আমাদের এদিক ওদিক হয়ে যায়। তো সবার প্রথম যখনই আমাদের আনএক্সেপ্টেবল এলো, সো ফার্স্ট উই হ্যাভ টু চেক what our result was and what is their result. Means we have put it right or wrong. That's the first one we always have to check. কিভাবে চেঞ্জ করবো একটু বলুন, কাজ করছে না আবার। We have to check that Biodata gives a very good troubleshooting checklist. We don't have to make anything. Just go to the Biodata website and we can get a very good ECAS troubleshoot checklist. They start from the sample receipt. They start from the sample receipt to internal QC, reagent, wherever we have to check. All the points are very much written in that Biodata website. So from that we can download and we can check in which point we gone wrong. So we can go on filling this and check where we were wrong. So once we have done that, that means our corrective action part is done. Then we have to retrain our staff. If there is any staff makes something wrong, that I told that about the fish thaw, so we have to train them and we have to write in SOP how to run a ECAS sample. So wrong estimate, sample mix-up, any late result, data entry error, these are the mostly common causes. And another one is improper storage, the temperature. So what are the challenges mostly we face? যে কোনো রকম কর্পোরেট ল্যাবে একটাই কথা শোনা যেতে পারে, we have a less money. So money part is a big part. Cost burden for a small lab, then sometimes delay in delivery, and there is a lot of lack of PT awareness in some settings. We can go for an interlab for a rare test. We can simulate PT using blinding sample, as I already told, and there should be a digital support too. So as I always say, or a lot of people always say, quality is a journey. PT is also same. It's not a pass or fail for an exam. Once mine is unacceptable doesn't mean my lab can't do better. We can always go for a corrective action. So always plan for at least 2 years. NABLs always want to see that if we have a 2-year plan for a ECAS. So plan for that and then operate. Handle every sample in a normal way. Should not be in a very like, it's an ECAS sample, আমরা খুব যত্নে রাখবো, no, not needed. But obviously in a temperature checked, please. Then evaluate, always we have to evaluate where we are going wrong, and whatever we are doing, documentation part, which we always fail. In a lot of lab, they doing everything but no documentation part. Everything is in a verbal. NABL doesn't see that, so we have to document everything and we have to have a very strong SOP and CAPA rules. So it's take-home message, PT ensure accuracy and patient safety, mandatory for our NABL ISO 15189-2022. If the failures, we have to go for a root cause analysis and CAPA. Use PT for continual improvement and test PT as a tool, not a burden. Lot of things people say this is an unnecessary wastage for PT material, but make it sure we should run so we can answer people better that my lab is doing good. So little bit of challenges are there, so we can overcome. Thank you.
Thank you, ma'am, for your wonderful presentation. I will request Dr. Durvashi to felicitate Dr. Priyanka Datta, ma'am. So our next speaker is Dr. Horitri B. She is an assistant professor in the Department of Biochemistry in Dr. B.C. Roy Multispeciality Medical Research Center, IIT Kharagpur. A President's Gold Medalist in DNB Biochemistry, researcher and educator. Her work focuses on molecular diagnostics, neurodegeneration, and AI in laboratory medicine. Today she will discuss protecting laboratory data in the digital era. Let's welcome Dr. Horitri B.
Good afternoon, everyone. I'm going to talk about confidentiality regarding protecting of laboratory data. So I promise that I will not take much time. Still, I will request Bulbul madam. After 15 minutes, please give me a nod. Yeah. So. So from this picture, I want some discussion regarding this. So, what is the common thing between these two pictures? Yeah, it is messy. What is the common thing? Yeah, that's a DNA sequencing analysis. Okay, so messy sequencing, no, but yes, both carries the identity, unique identity. So when we talk about data, data is like a photograph, a fingerprint. So just because there is no face or there is no name, that does not mean that every data is just irrelevant. If you can analysis, it is the identity of somebody. Of course, this is not Macy's DNA analysis. Otherwise, I would have been sued for that. So this is privacy. What Macy has written, that he has not released his unique DNA analysis, so that is patient's right. Whereas if I have his DNA analysis, it is my responsibility to maintain the confidentiality of the data. So again, when we talk about privacy and confidentiality, privacy is patient's right. I am to maintain my privacy. But if I reveal my data to somebody, it is his responsibility to maintain the confidentiality and not to leak. The third component in this system is the system, security, maintaining the security by different protective measures. It can be technical, physical, or administrative safeguards. That is what we are going to discuss in this presentation. Now, it's again not visible. So this is one serology report on the right side where it shows a patient is having seropositivity, HIV-1 positive. Whereas this is the CBC report. Now, can anybody tell me if any of these two reports is exposed to a social media or to the community, which one is more breach of confidentiality? Anybody? Surprisingly, breach of confidentiality is equal for both. Even the CBC report, if you reveal that it is breach of confidentiality and they carry equal weightage. It's not like I cannot reveal the serology report, but I can reveal the CBC report. So all are equal. Because data in these days are the currency. Data is currency. And why this privacy matters? Because when our data come to our lab, patients trust. Pointer. Okay. Patient trust and confidence is associated with that. Our lab's reputation is associated with that. Our ethical responsibility is associated with that. Moreover, that is one under regulation. So there is legal and regulatory compliance. We have discussed the DPDP Act yesterday. So it comes under legal regulation as well. So we are going to discuss under these legal regulation what can be the sources of data breach, what are the different key protection steps by which we can stop the data breach. If there is a data breach, what to do? Then if you are having a pool of data, what should be the life cycle of the data? And finally, the different available tools to protect different data. Now, lab and hospital are the high risk zones where different data are there and in different sources the data can be breached. Why these are high risk zone? Pool of data which are having patients' information, their ID, their finances, their health records. Those data are processed very fast turnaround time. So there can be vulnerable areas. There are multiple access points starting from the registration desk to the release desk. In between, there are pathologists, there are clinicians, they are accessing the data. Multiple steps of integrations. These are the activity points. And the vulnerable points are there are physical vulnerabilities. We are doing hard handling of data. There are poor IT control. We are outsourcing data to outside. So these are the leak points where we need to focus. Now, most important breach of data center is not any software or any system. Human error is the most important one. When we handle data unwillingly or unintentionally, data can be breached. How data can be breached? Accidental disclosure. Any example of accidental disclosure? Huh? It's not cloud failure, it's system error. What about human error? WhatsApp's, yes. So WhatsApp sharing, whenever I am sharing a data to Shanton, please check the data. Instead of sharing Shanton Jana, I can share it to some other Shanton. So that is an accidental disclosure, careless conversation. What is careless conversation? We always do gossip. Not only gossip, your blood sample has come to your lab, which is serology positive. Now, my friend under whom the patient is admitted, I am saying in leave that yes, this patient, please handle his data with care because he is seropositive. Another person who is present in the lift to whom the data is leaked. Unsecured documents here and there we can see in a lab. There are 1,000 hard copies are scattered here and there from which data can be leaked. Improper disposal. Those documents or any type of soft data in the form of hard copy, pen drive, if they are not securely disposed from their data can be leaked. Then cyber attack, cloud failure, ransomware, phishing, data exfiltration, and denial of services. What are these things? What is ransomware? Any idea? Ransomware? Yes. So what happens in many ways, suddenly one fine morning you will see that you cannot access the cloud. The cloud is blocked and is asking for $20. So that is your ransomware. You are not able to access the data. What is phishing? No. What is phishing? So basically, you are getting these days it is very common. You have some drug, drug trafficking. You got a case. So click in this site for further, non-availability of the cases, etc. So if you click that, that is a malware. Data exfiltration is data stealing. So from your data bank, data is getting, siphoned to some other site. And denial of services is one fine morning, you see, your total system is down. To extract that system, you have to click another link which will give a secure pathway to extract your data, but that pathway is not secure. Similarly, denial of services sometimes come in the form of multiple requests, multiple mailing requests. A random patient is asking for sending him his data by clicking in his email ID. Once you click that email ID, once you click one unknown link to that site, data can be leaked. After that comes our poor control, when you do not have the proper surveillance of what you are having in your system in the form of weak access control. In a lab where 10 pathologists are working, they all are accessing the system with a common ID. That is weak access control. Everyone is sharing the common ID, common password. Lack of encryption, data is not encrypted. The personal data, when I am sending even to the patient, that should be password protected. Proper encryption is required for each and every data. Outdated software. Now, what is the problem with outdated software? In our phone, every day there is a system upgrade, app upgrade. Why that is required? Any idea? If it is not upgraded, what is the problem? Or what is the requirement of this upgrade? Huh? That is the thing. When a new system comes within 2 years, of course, the system somewhere there is a leak point, somewhere there is a vulnerable point. So within these 2 years, probably the hacker has found out that leak point. So if you do not upgrade that, the data is vulnerable through those checkpoints. So constant upgradation is required. And finally, no audit trails. What is audit trail? Audit trail is when, who, where, why. Your data is accessed by whom? Starting from the lab director to the pathologist or lab technician, whoever is accessing data has to be tracked. When he has accessed the data, for what he has accessed the data. Typist has opened the laboratory portal to input some data that has to be checked. What data he has given in the site, what data he has changed. All these changes, activities, access from where he has accessed this data bank. All this has to be there in the audit trail. If not maintained, that is a point of leak. So there are 4 components of data security. We will start with a GPay. So in a GPay, when you are going for a Google payment or online payment, first you need a proper phone, hardware. Hardware is the first component. So your operating system has to be upgraded, needs a malware protection. What is a malware? The virus, trojans, these are the malware. So your system through which you are accessing your Google Pay app, your Phone Pay app has to be malware protected. Interface instrument. So by phone, when you are using the scanner system, that is your interface. You are linking your phone with that scanner. So even the interface has to be protected. Similarly, in a lab, the whole registration desk is connected via LIS to your different equipments. Your equipments are generating data and putting it in some computer. That computer is releasing data probably to some distant clinician or biochemist or pathologist. So all these hardwares, the instrument, the registration computer, the phones from which the data has been accessed, they must have some level of security. Secure authentication in mobile devices, definitely there should be an encryption. Network security. In a hospital, when you have established one LIS, majority of the hospital having one proper room or center where these cables, data, hardwares, the cords, the management is there. It's easy, very easy that you are having your own system in your hand. But again, that needs a security panel who is protecting that room, who is protecting the access to that room. The premises should be secured. External and cloud-based data system, when you are having your Google Drive, your Apple storage, all this storage you are not maintaining. They are getting maintained by a third party. So whenever you are outsourcing your cloud-based thing, the third party needs to be trustworthy, needs a constant monitoring, needs a system where they will constantly update you and upgrade you with the system they are handling, how they are maintaining the safety system. Application security, of course, password protection is required. There should be two-factor authentication. These days, it is very common. After entering the password, you will get a OTP in your phone that you need to again input. So that is two-factor authentication. Role-based access control. What is role-based access control? Any idea? Role-based access control. Okay, so in the lab, a typist who is typing a data needs not to access the patient history. He is just putting the value in the system. Similarly, a registration desk or the data releasing desk from where the data is, the reports are getting delivered, they don't need at all to open the reports, they just need to deliver. Or a finance department, they are just going to check whether the aligned tests are getting paid properly or the insurances are attached. They don't need to open the reports as well. So based on the roles, different roles in the hospital, the access should be limited. Fine. Personal security, if there is any error, as I told, the highest error is human error. So again, employee needs constant training regarding I have set a new password, I have put a new system, the system is upgraded. So all this upgradation needs a proper training protocol. So the best practice again, access control. I have already discussed, I'm not going into detail. Audit trails, as I told, audit trails has to be there. Whoever is from where they are accessing the data, when they have accessed the data, why they have accessed the data, and if needed, a second check by discussion. Why? Encryption. There should be an end-to-end encryption. Now, end-to-end encryption is at rest, the data is password protected. When I am generating the data, it is having the password. When I am sharing the report to the patient can open the data by giving a password. So in between, the transit is also password protected. So at rest as well as at the time of transport, the data needs to be password protected or end-to-end transcription. Now, homomorphic transcription is a encryption which occurs in between analysis. Now, I have a pool of data. pool of genetic data which I need to analyze. The data is end-to-end encrypted, but for analysis, I need to open the data, right? Now, homomorphic encryption allows hiding the vulnerable part of the data, only giving the values which is minimally required for analysis. So that is homomorphic encryption means without even opening the detailed identity or unique identity of the data, you can analyze. Confidential computing, for this type of analysis, what we need is trusted execution. How this trusted execution is done? It's a sort of a vault in a bank, which itself is an encrypted space. Even inside there is a vault. Means our data enters the vault in encrypted condition. In the vault, there is analysis of the data. The report is generated. From the vault, you can only access the report. So whatever analysis is happening is within the vault. That is the trusted execution environment. Huh? Like a black box. In the black box, what happens we don't know, but the TE system, we have to design that this part of analysis, even it happens, the data identification, because it has to be revealed, it should be in my domain to see, but not to others. Anonymization, pseudo-anonymization. Now, anonymization and pseudo-anonymization is just taking the, the university copies. Fine. Anonymization is when I am just giving you 10 values and I'm asking you do the mean or average or come out with the standard deviation with no name attached. Pseudo-anonymization is just like checking the university copies. I am replacing the name with some code. So the data is having one identity, which is a pseudo-identity, and only the specific person, investigator, lab director is having the master mapping for this data. Tokenization and masking. Tokenization is sensitive data with non-sensitive equivalence, like credit card information. Now, credit card information, see, the numbers, it is hidden. It comes in a proper PCI format where you can do the payment. You cannot see the value. You just put the OTP. Masking is just like in the credit card, please enter the phone number which is having the last 3 digits, 241. The initial part is masked. So these are the 4 ways by which data can be hidden or encrypted. Now, even after all these measures, if there is a data breach, what you will do? What is the first thing in a lab if you know that there is a data breach? You should do? Try to find out the source, not to find out the person. First activity is your source. Where is the data source? Detection of the breach. Fine. So find out where the data breach has happened. In these 10 computers, from which computer the data is leaked? From which ID the data is leaked? Then block the ID. So contain that specific source from which the data is leaked. Then notify. Whom to notify? Of course, the lab director, who are the associated personnel who are handling the lab, like if there is a quality control manager, if there is a all the pathologists, microbiologists, or biochemists in the lab, all typists do not access this system, everyone. Then who needs to be informed? This is the lab personnel, internal human. Externally, sometimes we need to inform the patients even. For a genetic bank, gene bank, when there is a data leak, you have to inform the party who is actually put their data in the system. And if the breach is legally of one legal one, in that case, you have the DPDP mandate is you have to inform the legal system as well. And finally, you are coming to rescue how it has happened, why it has happened. If there is a human error, train. If there is a system error, check. If there is a SOP breach, redesign the SOP. So after all these 3 steps, then comes the rescue procedure. Okay. Okay. So now we are having data cycle. So in data cycle, remember a data, how long a lab report you need to maintain in your cloud. The hard copies, how long you need to maintain or preserve. So definitely there is a data cycle which has been, the instructions are given by the authority only. So NABL or ICMR, they have mentioned the specific parameter-wise maintenance. So regularly there is a minimum 3 years of data maintenance. But in case it is a medical legal, even the regular data, if it is of medical legal importance, if the data is some related to some genetic test, that may require longer preservation. Whatever the time period is, that has to be mentioned in your SOP, and that SOP has to be aligned with the system existing and needs a modification based on the policy changes. These are the details of different type, I mean the histopathology report, cytopathology report, spectroscopic report that have their specific cycle for preservation. Where are these data stored? That can be digital data, that can be hard copy data. Means when you are having hard copy data, they have their separate disposal system. At the end of 5 years, you need to follow specific techniques for disposal. That can be shredding, that can be incineration. When that's a digital data, drive, hard drive, how to dispose that. There are degaussing system, crushing system, there are multiple systems. Means you need to follow relevant disposal system. If it is a hard copy, you need a proper disposal. You need, if you are having an USB, you just cannot delete, empty your USB drive and can throw. That needs a proper degaussing method to delete the trails of that data which has been stored in your hard drive or your USB drive. So these are the recent tools by which we can protect different data. Number one is currently very much in the system, that is AI diagnostics. Now, what we do, this is a very common practice in our system. Just share me the 10 images from which we are having the pattern diagnostic of what is the, is that is a stroke, is that is a CVA from CT scan. From histopathology, we are checking whether that is a cancer, malignancy, whether there is a metastasis. So that is by AI diagnostic, we are saving the time and increasing the efficiency. But what about, we discussed yesterday again, what about where this analysis is done? That is the black box. You don't know where this analysis is done. So that means what you don't know, what you can't see, you cannot believe. For which we need de-identification or encryption of data. Okay, thank you, madam. Cloud laboratories. So you are putting data to the cloud laboratories. I have Google Drive, somebody have Apple Cloud. Are those aligned with the DPDP Act? So currently, many of you are acquainted with Medical 365. You will see different data. Just like if you want to check some value, the Cleveland data is very common, whether they are aligned with the DPDP Act. Now, whenever you are storing some data for your lab, you are accessing a cloud, you need to ask whether that is DPDP compliant. Now, all these apps, they say yes. But then what again you need to verify? All these points we have discussed, you need to verify. Like, is there an audit trail in your cloud server? Is there a malware detection system? Are those malware can be blocked? Can we encrypt the data? If it is a genetic lab, is there a TEE system, trusted execution environment? Is it there? So individual questions you have to check instead of just checking whether that cloud server is DPDP compliant or not. Because this is a selling policy. Majority of the clouds will say yes. Zero trust security. Trust nobody, check everyone. Means even the lab director, even the senior pathologist, senior biochemist, they need to put the password, put the two-factor authentication when they are accessing the data. Their activity needs to be trained in the audit. So nobody can be trusted. Everyone's access should be monitored. That is, never trust, always verify. Finally, data loss prevention suits. Now, DLP suits are like monitoring specific things, like a technician who reports in your lab, the technician put 50 data per day. The technician access 50 data per day. Suddenly, one fine morning, he has accessed 5,000 data. He has downloaded 5,000 data. He has transferred 2,000 data. So this is a behavioral pattern which is actually monitored by DLP. Not only monitored, in majority of the system, what they do, they have a higher level monitoring. Means you can set in my lab, maximum 100 data can be transferred per day, per hour, in 12 hours, that you can maintain. Beyond that, if somebody wants to transfer some data, the system will shut down. The mail ID will be blocked. So these are the monitoring system that is in DLP suits. So these are the recent tools for data protection. Now, disaster recovery plan, even after all these things, all the scrutinization, all the monitoring, all the training, there can be data breach. So a lab needs to be well acquainted. They needs to be put in trial for any type of data breach. It's just like the fire alarm. So in a lab, there should be a proper SOP for a data breach and the followed activities. So you must have one off-site backup. Apart from your laboratory, apart from your hospital, there can be an off-site backup. So if there is a fire and there is a data loss, you can access your data. There can be cloud backup as well. Regular test drills. So yearly once or yearly twice, there should be a test drills. If there is a data breach, everyone needs to do their relevant activities. RTO and RPO, recovery time objective and recovery point objective. What are these two things? What is recovery time objective? If there is a data breach, within which time frame you can retain all your data or rescue all your data. That is your recovery time objective. And recovery point objective is how much data you can rescue. That is a percentage. How much data you can rescue, if you can rescue. Of course, then in data protection and privacy compliance, there is third-party sharing. Now, third party sharing, when you are putting your data in cloud system through some third party, you need to decide, and that has to be mentioned in your SOPs as well as with your vendor, how much data you are going to share, in which format, whether that is an encrypted data, whether that is a TE box data, whether that is a pseudo-anonymized data, how you are going to reveal your data. If the data is not anonymized, how they are anonymizing data in their system so that others cannot access through the third party. Physical security, that is the most important as of that is the most leak point occurs through the physical system. So inventory control, secure data disposal, hardware security, all these things is in your system. So all the computers, all the hard drives, mobile points from which the data has been accessed, that needs a monitoring. Personal security, human error once again. So whenever there is a test reel, specific person who is going to inform the lab director, who is going to shut down the system, who is going to identify the system, who is going to retain the emergency services by manual method, who is going to inform the legal authority. Those specific person need to be assigned in an audit, in a data breach trail. Everyone needs to perform their role when there is an emergency. Technology, of course, LIS needs to be monitored, real-time monitoring for all the activities, audit trails. This has to be practiced. This has to be put in the SOP, how this to be done. And finally, if there is a data breach, how the system can shut down and can be recovered. Regular review, of course, with the system changes, with the app upgradation, with the system upgradation, there is a regular changes of the SOP should be there. So this is all for data protection. I'm giving time. Okay. So thank you, everyone.
Thank you, Dr. Priyank, Dr. Auditri, for your nice presentation. So I would like to call Dr. Poushali to felicitate Dr. Auditri.
Now it is the time for lunch break. Take your coupon out and have the lunch.
We will be right to be here at 2:30 p.m. Post-session lunch will start from 2:30 p.m.
Good afternoon, everybody. So our post lunch will start soon. Actually, we have a plan to do weekly one evening webinar on some very small topic, like 2 to 3 hours in every week, particularly in the Sunday or Saturday. And the topic will be like the use of AI in publication and thesis, or the verification, validations, and accreditation of the or biomedical equipments. So please look for your mail. The mail will be given soon after doing the program schedule. So from the next week, in every week there will be one topic with some fully on the online platform, no offline, and which are mostly needed for our biomedical setup, particularly those who are related with human treatment or investigations. So please keep touch with us. I will inform regularly in every week, and that will be definitely in some nominal charge, and that information is not available easily. So on that topic, we'll choose and give it. So if there is any topic in your mind, please send us mail or the WhatsApp to encourage ourselves. So this will continue throughout the year from this platform, mainly in the weekdays. Thank you.
Starting the post-lunch session, I would like to call Dr. Arindam Ghosh, Assistant Professor and Laboratory in Charge, Department of Biochemistry, Dr. B.C. Roy, Multi-Speciality Medical Research Center, IIT Kharagpur. Please welcome Dr. Arindam Ghosh. And he is an accomplished researcher, educator, and principal investigator of several government and private funded projects. His interests include neuroscience, aging, bioinformatics, and precision medicine. Please welcome Dr. Arindam Ghosh.
Thank you so much, ma'am, for your kind introduction. I will just check the pointers, whether they're working or not. All right. So, thank you everyone for coming back. আমি ওরা লাঞ্চ করে কেটে পড়তে পারতাম যদি স্কোপ থাকতো। So, that being said, I took the liberty of sharing my presentation in the learners group. So Dr. Devjyoti has already shared it. So I address it to both the online and offline participants. So if anything is not legible here, you can please feel free to go through that particular slide. Otherwise, I mean, better look at me while I'm talking, fine? So once again, welcome everyone to this fifth GCLP, and I thank the organizers for providing me this opportunity. So again, good afternoon to my teachers, students, and dear colleagues. Today's topic is next generation molecular diagnostics, genomics, and AI in precision medicine. A lot to take, especially in the post-lunch session. So I'll be trying to provide only a very high level and surface level overview so that you can always reach out to me personally if you want an in-depth knowledge regarding any of this topics. So first, okay, first question. How many of you did attend GCP workshop yesterday? Just Hatolo. Right? Fine. Then for you all, my work is already half done. Right? For the rest, I am going ahead with today's presentation. So it will be for those who have already attended yesterday, it will be a quick top-up revision. Fine? So suppose there are two photos, right? One in which there is a photo of a biological cell and another same photo in which there are many lines. One line is showing nucleus, one line is showing cytoplasm, one line is showing Golgi apparatus, cell membrane. Which one of them do we refer to as a structured and which one of them we refer to as unstructured? There are two images. One is just an image, and in another image, everything is labeled. The characteristics are labeled. So, for example, in a picture of a cell, we have already labeled by too many arrows. This is a nucleus, this is cytoplasm, this is a Golgi apparatus. So, which one of you, which one is basically a structured data and which is unstructured data? Of course, the labeled one is a structured data. Why? If somebody who has no idea about that cell will be at least having some idea to train themselves. For example, if I show that same picture to a class 4 boy, maybe they have already watched an online video, but if they are seeing it for the first time, they will understand that, okay, this is a cell, okay, this is a cytoplasm, okay, this is the Golgi apparatus, why it is important. Next time when I show him that picture, it will be easier for him to at least have some idea. For those of us who already know what a cell is, even we can work on an unstructured image to find out or to easily guess. Agreed? That being said, the question of the day, if it is not visible, you can refer to the slide. The question says, what percentage of healthcare data generated in today's date is unstructured? Of course, so now you already know the answer because I have already shared the slide with you. So the answer is 80%. Means we need expertise to analyze that data. Expertise being the laboratory technician who may find out, oh, this is abnormal, let me have a delta check or let me take a repeat sample, oh, this might be hemolysis, so on and so forth. I'm just referring to my discipline. It may be any abnormal slide in pathology, it may be an abnormal looking colonies in microbiology. I'm talking about the whole laboratory discipline in whole. So, and we'll get back to this later. So when we come to the AI stuff. So why do we at all need to know about the next gen? Many of us have not been fortunate enough to work on today's generational methods, right? We have not even touched the surface. There are many methods that even exist today, many labs that we have not been able to do hands-on. But we are talking about next generation mainly because of the paradigm shifting, which is about precision medicine. Again, not visible, slide dakho. Precision medicine, what is precision medicine? By theory, it means I will be prescribed one single molecular tablet or a capsule which will be tailored so well to me. It will not have any side effect. It will exert only the desired effect. After exerting the desired effect, it will be eliminated seamlessly without causing any adverse drug reaction. Theoretically not possible because in today's date, whenever we are sitting in outdoor or whatever telemedicine, whatever we are doing, we are prescribing from our experience that this patient falls into this category of disease. We are giving a predetermined list of drugs from our own experience and we hope that this drug will work. It may so happen that cachicolonide does not have any efficacy and it leads to an adverse reaction. Why it can happen? I cannot guarantee that the drug and the dose that is working for me will work in a similar way for this gentleman. Why? Because two of us have got a completely different genetic makeup, metabolic profile, BMI, physical activity, lifestyle, health, food habit, everything is different. Therefore, in order to know and even attain such status in which we can prescribe a magic bullet, wonder type of medicine, the traditional analyte testing, that we call single analyte testing, means only checking the blood glucose or urea or checking any amplification of any single gene by PCR will not cut the mustard. So we need to know the entire genetic makeup, for which we need something called whole genome sequencing or whole exome sequencing, parallel metabolomic profiling. It is being done. They are not being widely applicated in a mass scale, but things are already in effect. However, when I have that much information, only then I will be able to make a drug which will exactly follow the pharmacokinetic and dynamic profile that is existing in my body. Otherwise, it is not possible. So that being said, if we are doing all those things, how will the good clinical laboratory practices paradigms or the baseline rules will apply? Will they need to be changed? No, the principles will remain same. But how we use them needs to be modified. The application of the process needs to be modified, and we will be discussing them very soon. The main reason of this paradigm shift is we are shifting our mode of practice from reactive to predictive. Means in today's date, in the periphery or whatever is happening, especially in our country, we will never visit a doctor. Of course, many of us, all of us are doctors ourselves. Still, the notion of the average citizen is we will never go to the doctor unless we are in so much pain that my lifestyle or daily routine is hampered. Like Dr. Hajar was saying, so much headache, even if NMC has come, that example, right? That is not only the will, but an obligation for many. There are many below poverty line socioeconomic class of people who cannot simply afford to visit a doctor because the cost of the daily wage earning will be hampered. Therefore, for them, today's practice, what do? We see the reports, we see the symptoms, and when something has already happened, we are prescribing a medicine or a treatment or a management that is called reactionary management or reactionary medicine. What we are aiming for is predictive. Means with your data, with existing symptom, should I be able to predict that you will have these diseases? Well, this is nothing new. So an endocrinologist seeing a diabetic patient in his outdoor will definitely be easily able to predict that fine, boy, you need to check your eye every 2 years, you need to check your DMGNC every 3 years. Because if not chronically well controlled, a highly diabetic will lead to retinopathy, nephropathy, neuropathy, so on and so forth. These are known, right? How am I able to predict? From my experience, right? So this is something very gross. This is already known, well documented. However, when it comes to the era of predictive medicine, we can find association among smaller and smaller genetic variation. And that is a rising topic of the funding agencies. Majority of the work that is being done in our institute and the institutes in which there is an engineering and health science collaboration is we are collecting data and then we are feeding the data into the machine learning pipeline, and the final objective is to develop an app that will predict the diseases, and that will be used for screening. And that is actually known as SAMD in ICMR funding head, software as medical device. Whenever you are trying to write an independent project, it is always better to include the final objective as developing a machine learning algorithm. Of course, you need to collaborate with somebody who knows, or you need to learn how it is done. Not that hard. And final objective is public dissemination of data. After watching these 2 points, the funding agency is very much tempted. Fine, this guy or this girl, they are trying to help the country and we will fund them. So let us understand what do you mean by next generation or next gen genomics. I will be briefly touching three important rising or emerging topic which most of us already know by today's date. One is next generation sequencing or NGS. What is NGS? We are sequencing the genes or genome with the help of high throughput methods, that is deviating away from traditional Sanger sequencing, in which a huge lot of data or information about my genetic makeup or whether I am having any problem are generated. What is new in that? Nothing new. Issue is the analysis or performing the next generation sequencing or NGS experiment or the technique. It's very easy. Even a class 7 or 8 boy, if he's being told you will press this button, you will pipette this thing, you will add this buffer, you will make this library and you will press this button and press enter. It's easy. Data collection, it's easy. Problem is the analysis. NGS, next generation sequencing, doing is very, very, very easy. The real challenge comes in analysis, and there we need a high computational power, not AI. Forget it, is simple mathematics. We need a high computational power, and that is important. Next, liquid biopsy. Liquid biopsy, you may be aware that it is. What is liquid biopsy? We are collecting or trying to detect circulating tumor DNA or tumor antigens from blood or tissue or fluids, right? Many of us will simply shrug off. What is this nonsense? It can never replace traditional biopsy. Yes, we are true in today's date. But believe me, every new process starts like this. In today's date, we are feeling this as negligible accuracy is not the gold standard. Yes, in every era, there are a few processes which are gold standard and something new will definitely replace them. Right? So, liquid biopsy again is another huge area of research in which I come from IIT Kharagpur, being a doctor, and I represent my institute, where this is another big vertical, because the agenda, what is the agenda? The notion is not everybody will go to the doctor for their biopsy. Not everybody will go to a doctor for a routine CT guided FNAC. What they can simply do, they can analyze their own body fluid. The body fluid being either urine or, you believe me, tears or sweat or minimally invasive. I mean by pinprick, blood. So if yes, ma'am, absolutely, saliva. Yes. So the notion is I have to find a marker using minimally invasive method, then it can be used for self-diagnosis. Will it replace gold standard? Never. It is a screening process, right? So for early detection, right? Primary prevention. And lastly, spatial omics. What is spatial omics? Mapping gene expression across tissue section, retaining their functional structure. So I will just go into the spatial omics a little bit. So spatial transcriptomics, again, if it is not visible, you can look into the slide. So the problem with traditional sequencing, just a moment back I was saying NGS is new. It is new. But if we only do NGS or next generation sequencing, what is happening? Whenever we are taking any tissue, how do we do it? So be it any oral mucosa, be it any punch biopsy, be it any lymph node biopsy, in order to find a genetic defect, we need to homogenize the tissue, right? Crush, make it powder, then obtain any sample, then take the supernatant and then do the analysis, in which the tissue architecture is simply lost. So to circumvent that problem, what is happening? We are trying to make sure that the RT-PCR or the amplification of the gene is happening in exactly the tissue itself, in situ, right? So the earlier approach or the traditional sequencing is often known as smoothie approach. I have many things and I am crushing everything. However, the new spatial transcriptomics is fruit tart. Means we already know pieces of things are available. So that is easier said than done. So what are this is next generation? What do we need to achieve for that? we need to do in situ hybridization, array sequencing, micro dissection, in situ sequencing. So all these things, again, there are dedicated equipments, right? We just need to have the proper antigen antibody, the proper technique, and the funding as well as the intention to do. Sample is always available. If it is done properly, it will lead to this type of picture. Mind it, in your slide it is much better visible which one is magenta color is which one, green one is which one. It may simply appear like an immunohistochemistry or IHC slide that, oh, this is simply a slide stain, right? It is much more than that because each of these sections represent amplified mRNA. Okay, no need to take photos. The slides are with you. You can simply take a screenshot and refer to them. So these are amplified mRNA, so that can actually test how the tissues are reacting in this environment with surrounding tissue. What does it help to understand? In this case, cancer mechanics or cancer metabolomics, right? And again, to briefly touch on liquid biopsies, the sensitivity is increasing. For example, in today's date, in non-small cell lung cancer, it is 85% sensitive, right? Nothing to scoff about. So finally, now we are coming to, so how, knowing all these things, AI is being integrated into all of these things. Fine. So as I told, 80% is unstructured data. So real challenge is to take that unstructured data and convert it into some meaningful clinical insight. So what are the probable things in which, not probable, existing things in which AI is being done? In pathology, digital pathology slide, digital slide, for example, advanced tumor cell counting, mitosis counting, border detection, patented softwares, FDA approved, are already available. Challenge is that those are not open source. Only the companies or the OEMs that are selling those microscopes have got that proprietary softwares with them. Reliability, of course, they're reliable. Can you take the responsibility? That question comes later. Even as a first year PGT, when I am diagnosing a slide, am I being entrusted to write the report independently? No. Of course, there will be a professor on head, there will be unit in charge, there will be a visiting physician from which I need to reassure this thing. However, when I am first seeing the thing, it becomes much more easier. The question, the problem statement is there is a dearth of doctors and expertise, and we need to help them, aid them in getting the initial diagnosis. For microbiology, again, simply by looking at the picture, automatic detection of colony pattern, from the genetic pattern, predicting the antibiotic resistance. We do not need to wait for 72 hours or even 2 weeks for in LJ media to understand the antibiotic sensitivity. It can be predicted earlier. And definitely in biochemistry, predicting the 3D models using protein-protein interaction, molecular docking, all those things are already being present. So at this point, the house needs to know something which I feel was not discussed yesterday. To achieve this, we need to at least have some idea about the differences in these two topics, ML and DL. Any idea? Okay, let me explain. Post-lunch, that is why I am fortunate about that. Machine learning is algorithms are highly trained to interact on structured data, as simple as that. So here is a machine, he is not that intelligent. So if I feed him something meaningful, then he will be able to learn, and then next time he will be easily able to give my answer or predict, right? So unstructured, any algorithm or any process in which the data needs to be we need feature engineering for the data is called machine learning. What is deep learning? Deep learning means the machine has already attained a state. They are not too different. What this is ML, this is DL, no. It is a state in which multiple such things have already been applied on this model. And now it can interpret from unstructured data. Very, very, very important. Right? So now we can feed it any unstructured image and now it will be able to do it. Fine. So again, what is feature engineering? It is given in your slide. It means labeling, cleaning, combining, transforming the raw data into meaningful structured data. Then only we can use machine learning pipeline. If your software says it's a deep learning model, it means they have already worked on it. It works how it works in a black box model. Of course, we are not sure exactly how it is achieving the diagnosis. However, deep learning model can give input on unstructured data. Basic difference between two things. So this is the rising graph in which represents the AI integration into diagnosis or diagnostic disciplines, and which is rising day by day. Now, another question that the example I gave in the very first thing. Suppose you come to me with this symptom, and I predict, okay, dear, with this disease, you will have this symptoms after so many days, unless you do these things, right? So nowadays, people are very knowledgeable. They comply and they follow the physician's orders. Nothing happens. আগেকার দিনে কি হতো in previous days, বাহ ডাক্তারবাবু বলেছে একদম ওরকম মিলে গেছে, right? That used to happen. So that was me being an expert physician. I am predicting your disease. If you want a machine to predict like what we are doing, what type of machine learning algorithm does a machine need? So the question is, it may come as an MCQ in any competitive exam you give. Which AI architecture is uniquely suited for predicting condition like sepsis 48 hours before clinical onset? Maybe it's the data, time series data. We are developing, the project has already been submitted, in which we are trying to detect sepsis by using smart bandage. It uses this thing, means a bandage has been attached on the wound. If any inflammatory markers are being generated, it will predict sepsis because it will have nano level of sensitivity. So remember, any predictive data based on time series means something has happened today, the machine predicts something will happen tomorrow. Unrelated to healthcare, I am just giving one example of healthcare as ICU sepsis. It is RNN. It will be discussed again by Dr. Priyanka, I believe. So recurrent neural network. Time series data prediction, RNN. Fine? So all that being said, we again need to return to our basics and find out how GCLP is acting in today's date, principles of GCLP, and how it needs to be modified later. So just you can see in today's date how validation is done. We are doing accuracy, precision, right? Limit of detection, accuracy. Next generation. Photo. Read the slide and please tell me what do you see in your slide, or what do you see here? How the next gen validation is being done. The slides have already been shared. Please, একজন কেউ বলো. Open your slide. দেখতে পাচ্ছ? Password লাগবে. You can just open it.
Validation, traditional laboratory will do assay. This assess the precision, accuracy, and LOD.
Right.
And next generation, we algorithm sensitivity, specificity, and rigorous bias checking against diverse data sets.
Right. Very good. Thank you. So it is algorithm sensitivity. We are not checking the sensitivity and specificity of the result, but we are moving into the algorithm. So when it comes to QC, quality control, we are running physical quality control with the help of any liquids or reconstituted lyophilized powders. When it comes to QC for next gen AI laboratory, sir, can you mention the keyword which AI needs to monitor?
Data drift.
Absolutely. It is data drifting. Thank you so much. And lastly, for traceability, we are measuring the reagent lot numbers and expiration. Here, quite obviously, we need to check for software versioning. As Dr. Arichi mentioned, we need timely security updates to check about the data security and privacy as well as the training performance. So finally, why we need all this thing? Because in order to have precision medicine, we need multi-omics, means entire genetic framework, entire transcriptomic framework, entire metabolic framework, and to need and compute all of this, it needs so much computational power that it extends the cognitive ability of a human being. That is where we need AI. Just because AI exists does not mean I can integrate into everything. There is a logical reason why AI is being implemented. Right? There is so much data we cannot process it. We need mathematical ways to provide a shortcut, which most of us might not understand, but there are mathematicians who are actually developing these algorithms, right? So the bottleneck is being sheer volume and data and our cognitive capacity, and the solution being deep learning, right? And finally, then only we can predict some new biomarkers. So, okay, that's I mean, presentation is actually over. So why do you think it is easier said than done? What is preventing us in adopting this thing into our own systems? Because everything seems so easy. Yes, there are regulatory challenges. There are reliability challenges. We will take accountability, everything, right? But the practical reason being paisa, right? Implementing the same platform across all the equipment and all serving into the same server so that it can be trained, all worldwide data trained into the same portal, and all are drawing the knowledge from the same portal, like matrix connection. It is not possible because technology is actually moving faster than infrastructure. It requires a massive systemic overhaul if we need to change any system to adopt all these things. But again, whatever is today's imagination is tomorrow's reality, right? So maybe I will see this thing. I will live out to see this thing happens, and I hope we are all benefited by these things, right? So now it is time for you to ask any questions. If there is not, these are the image references, and those have not been generated by AI. Those are real images, okay? And these are my. You can reach out to me if you want to know in-depth knowledge about anything. So thank you so much. That will be all.
Thank you so much, sir, for the exciting advances in the molecular diagnostic. And I would like to request Dr. Devjyoti Halder to kindly felicitate Dr. Arindam Ghosh, sir. We are pleased to welcome Dr. Priyanka Datta ma'am again. She will explore the transformative role of artificial intelligence in laboratory medicine while addressing its practical limitation and ethical considerations.
Thank you once again. And I like to thank you, Arindam, a lot. You make my work half. সব বলে দিয়েছিস প্রায়। হ্যাঁ, both Arindam and Orithri. Okay, so my topic of discussion after lunch, artificial intelligence in lab medicine. So a very, very basic question first. What is AI? What do you understand by AI? আমরা সারাক্ষণ এআই এআই বলে থাকছি, এআইটা কি? সকালবেলা বলবো, এখন কোশ্চেন করা যাবে না, কারণ ঘুমোচ্ছেন। Are we using anything related to AI in our daily life? Nobody is using. Is it so? কেউ ChatGPT ইউজ করে তো? হ্যাঁ না, সবাই একটু ঘুমোলে হবে না, আবার কি? You can't sleep like that. হ্যাঁ, Google Assistant, ChatGPT, Gemini, we are all using it. Which type of AI it is? Generative, non-generative, any idea? Generative. Good. Basic is clear. কি হবে না? No, it's a generative AI. So roadmap for my talk is what is AI? I discussed the concept of lab physician, how we are going to use it. Then laboratory testing workflow and where we can fit the AI. Then AI in pre-analytical phase, analytical phase, post-analytical phase, and which is coming up in a very big way, that is disease-specific AI application. It is coming. Limitation and challenges we'll talk about. Most of the things are covered by Dr. Oritri and obviously by Dr. Orindam. Then I'll talk very little bit about ethical concern and governance. From yesterday onwards, you are listening to it. And then the way forward. So about the machine learning, deep learning, already Dr. Orindam told, I'm not going into it. In general, machine learning detects the pattern. It doesn't give us any result, only it detects the pattern. খুব ভালো এক্সাম্পল হচ্ছে আমাদের যে কোনো রকম গুগল অ্যাসিস্ট্যান্সের গুলো and আমাদের গুগল টিচাবল মেশিন. Anyone used Google teachable machine? Anyone ever used that one, Google teachable machine? No. Okay, that's a very good example of machine learning. How from the pattern they can identify. Then the deep learning, and then our generative AI or our large language model. So for lab, where it's mostly used nowadays, that will be for pathology, the cell morphology. People are using it, how to identify leukocyte, platelet and everything. Then microbiology, plate reading, very easy to read. Then for our natural language processing, lab notes. Like ECG, we are doing ECG, the whole notes are coming, what is happening there and everything. So that also our natural language processing. And then electronic medical data records, that is also coming. Predictive analytics we are doing mainly for the sepsis alert and critical value prediction. It's like whenever the result from machine is coming, it's a critical alert. Directly from that, it will go to the ward or it will go to the consultant doctor phone as a WhatsApp or a message, that patient having bed number of this in this floor, having this critical alert. So these are coming in a bigger way. Then robotic process automation, lots of big medical colleges and lab having pneumatic suit. So we don't have to have a person to carry the sample. That is also AI. Then our result interpretation assistance that a lot of people are doing. We are just clicking a picture of a report. We are putting into ChatGPT, Perplexity AI and asking what is happening. It's a very common nowadays. So that's a large language model. So usually our main problem is in pre-analytical. 60 to 70% problem happens in lab due to pre-analytical error. Then something in analytical part and post-analytical. So pre-analytical part, one of the important is sample rejection. So if we are having a hemolytic sample, we are having a lipemic sample, we are having a icteric sample, that can be very easily identified by the machine itself. They can give a index like HI index, how much hemolysis is there, lipemic index, how much lipemia is there. So directly we can see that index and then should we process or not, decision will be by us. Then the transport monitoring sensor, this is also very important, in which temperature it is coming. If it is coming in a 27 degrees centigrade for a PTA sample, there is no point of processing that sample. So that temperature sensing sensor also can be by the AI. Then in an analytical, this is nowadays done by all of the big lab. Auto verification of normal result. They don't do it by themselves. All normal result goes for the auto verification. If I am talking about the Metropolis, talking about Dr. Lalbagh, everywhere, this is the process. Analyzing QC monitoring, lot of labs already taking this. Whenever we are running the QC sample, they can directly check if it is goes out of 2SD, having 10x rule violation, the machine already will show that there is a QC violation. Then cell efficient have a CBC differential, urine analysis image, that also two machines already in the market, UDCID and IQ200. Then pathogen, Malditoff, we can give it. For the post-analytical, I already talked about critical value prediction. This is very common, people are using. Then delta check, lot of us are doing the delta check with the AI algorithm, how much differ a patient parameter from yesterday or maybe 1 month before or maybe 6 months before. So that delta check one. Then reflex test suggestion. This is a very common nowadays coming. If you are doing or going for a test for a TSH, the AI will suggest for the FT4 and FT3. That's a reflex test suggestion are done. Then LLM assisted report drafting. We are seeing those kind of reports. Sometimes it's very good, but some point of time they can't do it properly. Sepsis and AKI marker, those are also very useful. This I already discussed, sample smart test ordering, hemolysis lipemia, sample volume and quantity test, patient identification everywhere, barcoded is there. So that is already done, and pneumatic tube. So disease specific AI. Usually hematological malignancy can be checked, and most of the bigger lab are using all those algorithms to check the AML, ALL, MDS. Then the sepsis and infectious disease. Malditaf can check within 2 hours if the pathogens start growing. Then for the thyroid and endocrine function, exactly what sequence we have to do the test, AI algorithm can help us knowing. Then diabetes and metabolic disorder, AI can predict how HbA1c is going, how our hyperglycemia risk is there. So usually our serial biochemistry data, if we are putting in an AI algorithm, they can very well predict. Similar with our AKI, with our chronic disease, kidney disease, we can find it out. And then there is a coagulation of thrombosis assessment can be done too. So nowadays we call it as a clean labomics. We call that clean labomics, which in lab and AI are together. So digital pathology or cytology came in a bigger way. From 2010, there are only was rule-based flagging to nowadays, with the help of our CNN neural network, we can directly identify if the disease is there or not. So there are a lot of, I'll tell Devjyoti to share the slide. So there are a lot of already FDA approved app are there where we can find it out. Like this one, Hello AI, they can tell you how the tumor cell to cell interaction is there. So we can identify the patient is going for a malignancy or not. Like this one, already approved in 2021, they done for the prostate cancer identification. Then Google LYNA, that's only for the lymph node metastasis is there or not, that can be identified. Television is also a very important one. And there are cervical AI are coming only to diagnose automated pap screening. So there are lot of POCT devices are coming up with our AI algorithm. Anyone knows the AIMS one recently came for diabetic neuropathy? Sorry, diabetic retinopathy. Ekdom recent একটা এসছে AIMS এর. Anyone knows the name? WhatsApp based পেপারে এসেছিল বেশ বড় করে, মধুনেত্রা এআই ডায়াবেটিক রেটিনোপ্যাথির জন্য একদম দিল্লি এইমস করেছে মধুনেত্রা এআই বলে। So that's a WhatsApp based AI algorithm to find out diabetic retinopathy is there or not. So lot of portable ECGs now we can see that can attach with our digital watch or Apple Watch. A lot of people are using digital watch, I guess. So from that we can check for our cardiac biomarker, how it is going. Then iStat is very much in for the ICU electrolyte and blood gas. There are enhanced glucometer is also are there to check. Why it is needed? Why India having so many of AI apps or AI coming in the lab? One is very important part, that is we have a limited specialist pathologists till now, and we have a very high patient load. So there are a lot of opportunities are there for the AI to come in. Large language model, clinical report drafting. Anyone ever tried writing a report with ChatGPT or Perplexity AI? Try করেছেন? বেশ ভুলভাল এখনো অবধি at least. I have tried once with protein electrophoresis. আমি একটা just severe report upload করে I have tried seeing how they are giving. So lot of time there will be a problem, but in a later days it will come that they can draft in a very good way. But if we are giving a normal clinical biochemistry report, they usually give a very good report. Then lab test consultation, lot of physician can check with the exactly appropriate test selection. Anyone ever checked Robin MD by Netflix? Just type in your Google Robin MD by Netflix. Otherwise, পরেও দেখতে পারো. So that website, that's a AI app made by our doctors. So there you can check drug interaction, drug doses, writing a protocol, making your slides. You can have a generator report of whatever you are giving. You can have a report summary. You can have put out a journal and they can summarize. So it's a very good thing. You can just check how they are giving. And as it is made by your doctor, they give a very good this kind of lab test consultation, drug doses, drug-to-drug interaction. So we can check all those. And then literature and guideline, we can get it from large language model. Patient communication, a lot of doctors are using this. Nowadays, we can see in our Facebook or Insta page, a lot of things coming in a podcast also, they are using for this communication. আমার মনে হয় নোটবুক এলএম তো বোধহয় সবাই ইউজ করেছে নাকি? কেউ আছে যে নোটবুক এলএম ইউজ করেনি? এই রে সবাই এরকম সাইলেন্ট কেন? Have you heard of this notebook LM? না গামা AI বলছি না, গামা AI তো পিপিটি বানানোর জন্য, একেবারেই বলছি না। ইন জেনারেল নোটবুক LM কেউ কি ইউজ করেছে না নামই শোনেনি? আমি কি নতুন নাম বলছি? নামই শোনেনি। আচ্ছা, usually people use ChatGPT a lot, Google Gemini, তাই তো? Claude কেউ ইউজ করেছে? Claude ইউজ করেছে। ওকে, Perplexity AI? Yes, no, একটা হাত, দুটো হাত। ওকে, Perplexity AI। আচ্ছা, তাহলে নোটবুক LM কেউ ইউজ করেনি। Please use notebook LM also. In notebook LM also, if you are putting a YouTube video, a whole movie, your journals, maybe you have a 10 articles and you want to summarize, you want to generate a very good mind map, you want to generate mind map is very good, you want to generate a infographics, you want to generate a data table, you can all can do with the notebook LM. So those patient communication for the report generation, these are a very good tools. Then We can use large language model for training and education, simulate lab case viva, we can generate MCQ, we can assist our data. So opportunities for our accuracy and precision. For the QCs, we can very well use this. Then throughput and speed. If we have a, suppose like Anurna was saying, they are having 5,000 tubes in a day. So if they don't put that auto verification option, it's very difficult to complete that process in one day. So the auto verification will reduce our TAT. Then early disease detection, a big data integration. How can we do that? Then workflow optimization and patient safety. And here comes our limitation. And we have to be very careful about those limitations also. AI is what we are putting. So whatever data we are feeding to AI, they will make that algorithm out of that only. So if we are putting a junk data, they will give a junk report. So we have to have a very good quality and very good quantity of data. We can't rely upon, we are putting 100 reports or 100 images and we want to diagnose a COVID city. With the help of Google Teachable Machine, we can't do that. At least we have to put 10,000 data, 50,000 data, then we can do it. Black box problem, I'll not talk about, it's already discussed. Then data set bias. That means we are sitting in India and we are getting or putting all the data set from the Europe background. Then there might be a data set bias, validation and generalizability. Same, we didn't validate the data for our setup. We can't take USA data and use it for India. So generalizability, we should check. Validation, we should check. And then integration is very much needed. And people are doing a problem of descaling risk. That lot of people are having problem with the chat GPT. আমার যদি একটা কোনো লিঙ্ক নেওয়া থাকে আমি সেই চিঠিটাকে চ্যাট জিপিটি থেকে যদি লেখানো শুরু করি I will forgot how to write a letter. So it's like that. Black box আমি explain করব না. So WHO have a governance for 6 things. Protect autonomy, protect human well-being, ensure transparency, foster responsibility, ensure inclusiveness and equity, and promote sustainability. All are coming for lab medicine part 2. ICMR have 10 principles, all of you know, it's already discussed. So what exactly for lab medicine ethical concern? Main part which Dr. Audrey discussed beautifully, privacy and data security. We have to be very particular about this part. Then algorithm bias and equity. Again, what we are putting that might create a bias. We have to be very careful. Then accountability and liability. If your AI model or your AI app done a wrong thing, who will be responsible for that? AI who made the model, or you who is doing, or the person whom you give the report or something, or from where you are working. So who will be the responsible? That is a very important part. And then autonomy versus human oversight. We need to be very transparent, and whatever report we are generating or giving to the patient from AI model, that should be explainable. That is very much important. And always use patient informed consent. If we are taking our data for an AI algorithm, that time also we need to take informed consent. It's not like that we are not taking serum from the patient or urine from the patient, we are just taking their report. Then also we need to take informed consent for that. We just can't take the data and use for us. There are a lot apps are nowadays are allowing by the FDA. 500 AI devices are cleared by FDA in 2025. Europe acts are there. They also classify high risk classification for diagnostic AI. WHO I already talked about. India also have medical device rule 2027. And we came with that DPDP Act, Dr. Oritra was talking about. That also came in 2023. CLSI EP29, please download it for only to check artificial intelligence in the lab. How, what to do, what not to do, everything is written in this CLSI guideline. Then for our risk management and ISO 13485, that is also for AI devices. How to manage that AI devices. All rules and regulation are there. So this is a stakeholder matrix which we should know. If is it in a development phase, researcher or developer should have data anonymization and they should avoid the black box design. It should be answerable why I am giving this. If suppose we are telling this patient are going for hepatic fibrosis, we are putting some liver function tests. They should explain why you are telling this is going for a liver fibrosis. That should be there. There should not be any black box. For clinician, they should define the clinical goal. Just not like that ki ja pawa jab ami niye lebo. No, they have to have a proper clinical goal and have a provide ethical access to the patient data. Ethical committees should check how they are going for a data privacy protocol. They should have, ethical committee should have nowadays both AI and medical law practices. Coming for the validation phase of any of our AI algorithm or app, should use independent data set. Clinicians should know how to use that data. Is it really collaborating with our real life scenario or not? They should test that. Ethical committee should monitoring unintended harm and need a spirit AI or concert AI framework for all the compliance. Deployment phase, researcher or development part is less, but they should always should be on feedback loop. When people have started using, how they are getting the reports and all, it should come on their feedback loops. And they should be maintained accountable for any algorithm flaws. For the doctors and clinicians, they can conduct a local pre-deployment testing for their own safety and should tell the patient we are using that AI app. AI limitation we have to communicate. Okay. So how we are going to be AI ready lab professional? That is also needed. We should have AI or ML literacy. It's just like that. I have one of my junior and one of my colleague who told we don't need to know all this. We can go without doing this, but no, it's coming up in a huge way. We have to know that. We have to check how this model biased or not. Then there are data governance, which already all discussed. We have to know about that regulatory awareness. We have to believe that AI will not replace laboratory doctors, but laboratory doctors who use AI will replace those who don't use. So we have to go and enroll any of our courses. How many have done a proper AI course? আপনার হাত উঠবে আমি জানি, ছেড়ে দিন। বাকি আর কেউ কি কোনো AI কোর্স করার চেষ্টা করেছে? ও একটা দুটো হাত, আর কেউ কখনো করেনি? 3-4, কম। সবার করা উচিত। কোর্সেরা ইজ ফ্রি। ওকে, কোর্সেরা ইজ ফ্রি। হ্যাঁ, কোনটার সাথে? না, আমি এখনই বলছি না, কিন্তু আগামী 20 বছরে হবে। হ্যাঁ, হ্যাঁ, don't, yes. আচ্ছা এআই রিপ্লেস করবে আচ্ছা আমার এখন অব্দি মনে হয়নি okay obvious this opinion will not be same yeah we can have a debate of this we already had it in our conference anyway so that's a request from my side please enroll any of the AI courses there are a lot of available for a healthcare and our association MB is also having only for laboratory medicine AI course. So we have to always, what Dr. Arindam and Audrey both told, always have to audit ourselves before using the AI tool because we are using, knowingly or unknowingly, we are using. Please read some journal, do a course for AI and engage yourself in AI thing. So this is the future of AI in lab medicine. Mostly in pathologies, foundation models are coming where we just can read the slides, they can diagnose the cases. LLA VMAD, it's for the CT scan, X-rays or the radiological one. AI guided personal reference range works is going on this because reference range can be changed for different person to person. Lab on chip. This is also a very good works are going on, lab on chip. Then multi-omics are coming. Then real-time AMR prediction from blood culture. This work are going on in various universities of USA. From culture only they can identify what will be the, we don't have to wait for 2 to 3 days. Then autonomous lab for routine tests. Exactly AI generated diagnostic hypothesis for rare disease. These are the upcoming ones. We always have to remember the human in the loop engine. Human can't be removed from any of the AI algorithm. So this is the last one. The power of technology is help in bridging delivery gap in healthcare. Empower complex rapid diagnostic where we have to remember eliminate encoded biases, protect human autonomy and consent, and then we have to check the digital part which is very essential. We have to know the data safety part very well. So concluding with our future is the race between the growing power of technology and the wisdom with which we use it by Stephen Hawking and quoted by Dr. Swaminathan. Thank you.
Thank you, ma'am, for your enlightening and so interactive session. Now moving on to next session. Now moving on to next session, I would like to invite Professor Dr. Bulbul Purkai, Professor and Professor in Department of Biochemistry, Murshidabad Medical College and Hospital. She is a distinguished academician, laboratory expert, and she has extensive experience in quality assurance and laboratory management. Today, she will address advanced laboratory risk assessment strategies. Please welcome Dr. Bulbul Purkai.
Thank you. Thank you so much. Thank you, Department of Pharmacology, MIdnapore Medical College. It is a happy homecoming for me, basically. So, my topic is basically advanced laboratory risk assessment in modern laboratories. In the morning, you had sessions where there was a session Dr. Paroma took on detection of errors. So, and then of course, Dr. Priyanka took a topic session on quality assessment, quality management. So from detection of error, I go off to my part, that is assessment of risk. Can anybody tell me what do you mean by risk? By definition, what is a risk? What would you call a risk? Anybody? Any of you? Yes? Anything that poses a possible hazard. Yes, of course. That is again, yes, anything that is posing a possible hazard. Yes, right. So today we'll talk about the basic terminologies encircling risk management, why risk assessment is essential in clinical laboratory, procedural workflow for risk assessment, various methods of risk assessment, and AI effects in risk assessment. So now I'd like to focus on the point that today my talk is on risk assessment, mind you. It is not risk management. So we need to learn the terminologies now. So what is risk? It is a combination of the probability of occurrence of harm and severity of harm. So it is this definition is as per ISO 14971. Who is the process owner? A person who has the ultimate responsibility for performance of a process and has the authority to make changes whenever it is essential. Then coming to risk analysis, as per ISO 14971, it is the systematic use of available information to identify hazards and to estimate the risk. Failure mode, the manner in which a process could potentially fail. Again, this is given by ISO Technical Specialties 22367. And FMEA, failure mode and effect analysis. All those who are just going to begin your life at laboratories, remember all these terminologies are extremely important because every day you will be faced with these terminologies, even if you are not going for audits, NABL audits, even before that, for root cause analysis and for every damn sorting, problem sorting algorithms in auto analysis or in automations. These terms are going to be thrown on your face. Again, risk assessment, that is overall, before that I'll talk about risk evaluation. That is the process of comparing the estimated risk against a given risk criteria to determine the acceptability of the risk. So 3 terms. First is assessing how much risk a particular process or deviation had. Secondly, comparing it with the how much can be acceptable in your setup, in your laboratory. That is risk evaluation. And both risk analysis and risk evaluation, risk analysis plus risk evaluation together make up risk assessment. So risk evaluation plus risk analysis make up risk assessment. And then comes finally the risk management, which is not in the domain of our presentation of our talk or this GCLP workshop as of today. Risk management is systematic application of management policies, procedures and practices to take to the tasks of analyzing, evaluating, controlling and monitoring the risk. Again, this is as per the ISO 14971 guideline. So for risk assessment, you remember this ISO 14971 guideline. It is very important. Okay, now what are the risks that we are faced with in our laboratory? There has been a paradigm shift. Before, maybe 5 years ago, the risks were what? The risks were exposure to HIV, exposure to aerosols, or spillage of acids, or electrical burnouts. These are the ones we were talking about. But now to this list, major, more risks or more deviations have added. First of all, handling of novel pathogens, that is, handling of GMOs and aerosol generating procedures. COVID has taught us what handling of novel pathogen means. Digital and cyber, which we were talking We have had 3 sessions with this, the threat of data corruption and hacking of LIMS. None of us here can remain untouched from LIMS anymore because it has come integrated into the laboratories of all government medical colleges as per recommendations of Government of India. Next is chemical and material. Chemicals, as I told you, in our times, chemical was acid and alkali spill. That is what we understood about chemicals, or max to max toxic chemicals, which had a glass bottle which had a skeleton on it. But now it has shifted to risks from nanomaterials, highly reactive compounds, and unexpected toxicological interactions. And again, next, which is a very important risk, which we all are seeing and which has become an epidemic now. You will hear every second person is complaining of cervical spondylitis, commonest. That is musculoskeletal strain from automated machinery and cognitive fatigue from high throughput. Like Dr. Ananya said in the morning, in her Surakha, the number of tubes that passes through the automated machine is 5,000. So fatigue, cognitive fatigue. So all these are posing a huge amount of risk toward the functioning of the laboratories. So now, how do we define risk? We have a few more definitions as per the ISO 73 and the ISO Guide 51 definition. Risk is defined as the effect of uncertainty on the achievements. When we are doing a particular job, we have a particular framework in our mind that this analysis will give rise to this result. And when it deviates from that, that is a risk. Secondly, risk is the combination of the probability of occurrence of harm and the severity of the harm. You must have all heard about Murphy's Law. Edward A. Murphy, he was an aerospace engineer. He gave this, which we all use in our laboratories. If anything that can go wrong, will definitely go wrong, right? And we have an extrapolation of that. We call it the Mrs. Murphy's Law. What is it? Anything that can go wrong will go wrong, while Mr. Murphy, in our case, Mr. Murphy is the lab manager, Mr. Murphy is out of town. So basically, risk management is a process that involves anticipating what could go wrong, assessing the frequency of occurrence of these errors, the consequences, severity of harm they cause, and finally, what can be done to reduce the risk of potential harm to an acceptable level. So you see, there are 3 points out here. That is, anticipating what can go wrong, anticipating the error, assessing the frequency of occurrence of that error, point number 2, and point 3, the impact of that error or severity of the harm. So these are the 3 points or the three main pillars on which risk assessment rests. Now there are standards which are set by the national and international regulatory bodies. Who are those bodies? One is ISO, which we have been talking since morning. Then CLSI. Second is ISQA, WHO, in India, NQAS, and NABL. So ISO, you see there's a huge long list of ISO documents which we would be requiring for assessment of risk and for establishing standard practices for risk assessment and risk mitigation. So the first one is ISO 9001, which emphasizes risk-based thinking as fundamental to quality management system. ISO 15189, we all know, quality management system in the laboratories. There is ISO 17205, this is for testing and calibration laboratories, that is PT providers. Then is ISO 15190, integrates risk management into medical laboratory safety. ISO 31000 provides globally recognized guidelines for systematic risk management. ISO 22367, it guides the direct application of risk management in medical laboratories
focusing on patient and worker safety. So till now, when I read out the list, one thing should be clear to you. The risk is not just the harm caused to the patient. The risk is also to the laboratory workers, starting from the doctors, entire hierarchy. Risk is also to the laboratory infrastructure, whatever is going wrong due to deviation from the normal workflow, and also to the reputation of the laboratory. Even that is a consequence of the risk that is incurred during the workflow. And last is ISO 35001, which is amended in 2024, which addresses bio-risk management in laboratories handling hazardous biological materials, including risks from biological agents. I know it is not possible for you to remember, but you should have it in your head that there are n number of ISO documents which are linked with standardization of the process of risk assessment in various parts of laboratory workflow. So we are going back to the talk of today, risk analysis. The purpose of risk analysis is early warning for potential non-conforming events or risks and quality indicators that detect the changes in the analytic process. Second, mitigation of the effect that the risk has caused. And secondly, developing risk response strategies. So today our focus is basically on this. Purpose, that is point 1, early warning for potential non-conforming events. So this is basically a roadmap for risk assessment. So you see, let's start from number 1. There are n number of abbreviations. Anybody, can you tell me any of these abbreviations? Any of these abbreviations, can anybody tell me? The full form? Yes? FMEA. FMEA is a very, very common term that is used in error management and risk assessment. Okay? FMEA is failure mode effect analysis. Failure mode effect analysis. As the name suggests, that means I take up the failure and I trace back what was the effect of that failure. Failure mode effect analysis. Then is FTA. FTA is fault tree analysis. Then there is FRSEAS, SRSS, QRA. We will talk about it in, sorry. So point 1, all these procedures which I have noted down here, they are the first step in assessment of risk. That is, with all these tools, I would first analyze what are the risks that can ever happen in the laboratory and what are the errors that can ever happen in the laboratory. Secondly, why those errors had taken place. And thirdly, root cause analysis, that is tracing back all the possible reasons that are the cause of this risk. If you remember Dr. Poroma's talk, she had drawn a fishbone. You remember that? She had drawn a fishbone in the morning in error management. That is called a fishbone analysis or a fishbone chart. And it's very interesting that it was first given in the automobile industry of Japan by Dr. Ishihara. Ishihara was a management guru of Japan, and he had made that fishbone analysis chart for automobile industry in the 1960s. And from there, it was imported in the medical laboratories and medical system management systems. So after we have analyzed what are the risks that can possibly happen in our laboratory, we have 2 ways to go. One is risk matrix. That is number 2, risk matrix, or number 3, RPN. RPN is risk priority number. So risk matrix and risk priority number. Number 2 and number 3 is quantification of the risk. So, for example, in my laboratory, in the central laboratory, say for example, of MIdnapore Medical College, from SNCU, every day they have been calling up the HOD ma'am that ma'am, the bilirubin report of the newborn, when we sent the blood sample, we are receiving the report 6 hours after we sent the blood sample. Do you call it an error? Do you call it a risk or a hazard? Bilirubin report coming 6 hours after the sample was sent in case of newborn. Is it a hazard? Yes or no? Yes or no? Hazard or not? If you think it's a hazard, why? Why do you think it's a hazard? Why it's a hazard in case of newborn? Yes, it is a defining our therapeutic modalities. If it is a term maybe, then bilirubin 10 or above 10, below 10, that we decide what treatment is to be given. If it's a preterm, 20 is the defining point. Whether to go for exchange transfusion or not, that cannot be delayed. So obviously here, the delayed report is a risk. And the effect is, it is life-threatening in case of a preterm newborn. Okay. So here, with the risk matrix or with the risk priority number, I can quantify the amount or the impact that a particular risk is going to have in my patient service, or in case of the laboratory personnel, or in case of the laboratory infrastructural deficits, or in case of the reputation of the laboratory. And after quantification, what do? We go for number 4 to assess and prioritize the risk and determine what level of risk is acceptable in the clinical laboratory. Very simple example, like I told you, bilirubin test of newborn. You agree with me? It is a risk, definitely. Vis-a-vis, again, from the indoor, Shoma madam gets calls, ma'am, we are sending blood for uric acid and it is coming the next day. Will you call it a risk? Uric acid. Yes or no? Not much, not really a risk. It is a risk, of course, but the impact of the risk is not really as deep as the impact of the risk that was there for the newborn blood. So based on these quantifications, we prioritize the risk and we determine what level of risk is acceptable. Uric acid report coming 6 hours or 12 hours late is an acceptable risk. I prioritize it. But newborn bilirubin report coming 6 hours late is a high priority risk. So this is how, based on case to case, based on my infrastructure or based on my personnel or the type of patients, every institution has to segregate or prioritize what is the acceptable amount of risk for any particular type of risk. So first is risk identification. As I told you, first one, FMEA, which is the most common risk identification protocol that is taken up all over the world, just not here. We are talking global. FMEA is one of the most common SOP. What is it? Failure mode and effect analysis. What do? We discover the possible sources of failure, evaluate where the process has gone wrong, then determine the probability that how many times such risks or such errors may happen because of failure of the system, then assess the consequences of each failure, that is severity of the harm. Then we outline the control measures to detect and eliminate such failures. We call it the bottom-up approach. That is, we pick up the risk, we see what are the errors that have happened in a particular day in the laboratory, and then we backtrace. We call it the bottom-up approach. Next, the fault tree analysis. That is a top-down approach.
We begin by assuming a high level hazard and then try determining the root cause of the hazard. Say, for example, again I go back to the neonatal blood. So here the top faulty approach will be when I'm sending, when the HOD of pediatrics is on round, he tells you, you collect the blood sample of this newborn, you yourself go to the central lab and deliver the blood sample. If not, the turnaround time is going to be very high and we will not get the report before 6 hours. So HOD Pediatrics has already done a fault tree analysis, a top-down approach. He has already assumed the high level of risk that is associated with the new blood sample of the newborn. So that is FTA. Okay? And which is said that FTA and FMEA should be conducted together to fully assess all possible ways a laboratory system can fail. Next, FRACAS, which is a failure reporting and corrective action system. FRACAS is basically done by the manufacturing industry. Usually the biomedical instrument industry, after they design any equipment, they subject it to failure reporting and corrective action system. The entire manufacturing team gets down to analyze where all this machine can fail when it starts running. After noting it down, what do? They go into corrective measure. So that is failure reporting and corrective action system. And after they do the corrective action, only then the machine is released in the market for consumption in the medical laboratories. So now we go to the, after we did this, we go to the quantitative, that is we quantify the risk. How we do it? First by risk assessment matrix and risk priority number and SRSs. These are the three most commonly used quantitative methods, literally mathematical methods to assess the magnitude of the risk and the impact it has. It is actually mathematics. When I show you, you'll understand. SRSs is square root of sum of squares. RPN, risk priority number, and risk assessment matrix, these three. And these are the advanced ones, which entails a lot of statistics like probabilistic risk assessment, quality report assessment, Bayesian statistical methods. It is not really done on an everyday basis by the laboratories because this requires a good amount of mathematical expertise. It is not really in our domain. So, the risk matrix. Risk matrix is basically the most commonly used matrix is a 5 into 5 matrix. It looks something like this. 5 into 5. See, it's got 5 on the y-axis, 5 on the x-axis. If you see on the y-axis, I have written frequent, probable, occasional, remote, and improbable. So these are the number of times that particular error or that particular risk can occur. It can be a frequent one, which happens in our labs. Can I tell you which is the most frequent risk or error that happens in our labs? Most frequent. Yes? Missing sample? Hemolyzed sample? We get the requisition slip, but the sample does not come from the indoor. Or we get the sample, but there is no identification on the sample. No ward number, no bed number. Isn't this very frequent? So this is the number of times the risk occurs. And this one you see negligible, minor, serious, critical, catastrophic. This is the amount of damage that risk is capable of causing. And we multiply the two. All these are allotted particular number. I mean, this is allotted a particular number. It's just like a Likert scale. And then we multiply the two and we get a matrix like this. And this matrix is a recommendation of ISO 14971. So it is a 25 cell matrix, and each cell represents a different level of risk. And how do we get the risk level? As I told you, it is simply multiplication of the probability of occurrence, that is frequent and probable and improbable, into the impact. So x-axis into y-axis. So as per 14971, the number assigned to the number of times or probability that that risk can occur. So you see they have given frequent means it is once per week. Probable means once per month. Occasional means once per year. Remote means once every few years. Improbable, once in the life of the measuring system. Like, I don't know how many of you have seen the news yesterday. There was a very sad incident that has occurred in a remote location of Dhulian near Malda. A boat carrying passengers was in the middle of Ganga when it was struck by lightning. It is a very rare event and it killed a lot of people. So something like this is actually improbable. But if I go over the ISO 14971 guidelines, frequent they are saying once per week. Then what would they call the risks or the hazards that we have in our system? Missing samples, immunized samples. What would they call it? So basically, we have to alter this scale as per the prevailing system in our laboratories. Then this is the severity level given as per ISO 14971. Catastrophic means it could result in death of a patient. Like I told you, report of the newborn bilirubin, premature newborn bilirubin reaching 6 hours after the blood sample was sent. That is catastrophic. Okay. Critical could result in permanent impairment or life-threatening injury. Serious could result in injury or impairment requiring professional intervention. Minor could result in temporary injury or impairment not requiring professional medical intervention, like uric acid report reaching 12 hours later. Doesn't it really require any medical intervention? Excuse me. A negligible could result in inconvenience or temporary discomfort. So if I multiply x into y, so if its value is 1 to 4, it is a low risk, acceptable risk level, and no immediate action is needed. It just requires monitoring. If the value is 5 to 9, that is a moderate risk, requires attention and potential action to reduce the risk. If the value is 10 to 16, it is high risk, that is significant attention needed. If the value is 17 to 25, it is a critical risk, immediate action required, and high priority. So this one, which is a two-dimensional matrix, we have just one x-axis and a y-axis, the 2D matrix. Now, the problem with this 2D matrix is it does not fit all. Each lab is different. As I told you, as per 14971, frequent means it happens once a week. But in our cases, once a week is not really, we cannot keep it at the top of the ladder. For us, it happens 10 times a day. That is frequent. And much rather, I'd say 25 times a day. Himalaya sample. So, 2D matrix that is given, it does not fit labs. Potential impact may vary depending on the infrastructure, instrument, process, maintenance, etc. So that is why risk quantification can vary and risk acceptability may vary. Very simple, uric acid report, I go back to it again. In our country, it is acceptable. No problem. We can tell the patient what is wrong. You received it 12 hours late, no issues. You try doing that in Australia and America, you will be sued by CPA. So this is the difference. Acceptability varies from country to country, from population to population. Then risk quantification RPN, which we call the risk priority number. This is a 3-dimensional. Risk matrix was 2-dimensional. This is 3-dimensional. What are the 3 dimensions? Severity of the risk, that is seriousness of the consequences, and it is ranked in a scale of 1 to 5 or 1 to 10. Occurrence, that is how many times it is occurring in a particular time frame, and detection, that is probability that the failure will be identified before it causes a problem. So here we have added another dimension to the matrix, that is probability of detection of the failure, which is of course very important because in labs like medical colleges where the number of samples is so huge and the human resource is so less, many a times, even if we want to, the detection of the risk goes undetected. And many a times it is voluntary. Like missing samples. We do detect it, but we choose not to notify it because we do not have the human resource to pursue that. So what do? We just multiply it. Severity S into occurrence O into detection D. So risk priority number is just multiplying the 3 with SOD. It is also called the multiplication method. So this one is simple, easy to understand, and it is just a simple numerical score that enables us to prioritize a risk, to prioritize whether we will call it a high risk or a low risk, and to allocate resources as per the priority we are assigning it. And usually it is seen for risk analysis and management. RPN, that is the multiplication method, is used along with the FMEA together. Now here the problem is S into O into D. Sometimes if the O and D are different, even then multiplication of all 3 can give rise the same RPN score. So then how do we separate them and how do we set the priority? So here we have 4 pillars. First, we will check how critical it is in compromising patient safety. If it is critical in compromising patient safety, then the RPN gets the priority of the risk, the RPN increases. Secondly, whether the risk has a potential to recur, how often it is occurring. Third, what is the expected financial loss to the laboratory? And fourth, what impact it would cause immediately and in future on the reputation of the laboratory. So when more than the RPNs are same for more than one risk. So this is how we separate the priorities of the risk. And here you see a component of the a financial component of the loss of the laboratory is taken, and also reputation of the laboratory too has been added to it. Okay. See, for a very simple reason, if it is a premarital counseling, like what do we do in premarital counseling? The tests. One is HIV, the other is too common, thalassemia, right? So if the person was HIV negative and you took a little bit of time to run the thalassemia electrophoresis to ascertain the thalassemia status, it is not really detrimental to the health of the subject. But your delay in providing the report, what happens in Indian society it could have a detrimental social effect that the marriage could, or the boy's family or the girl's family, they can step in and say the premarital report is being delayed. So we believe something is definitely wrong. So we are calling off this marriage. It can happen. It's quite a common thing. So you see what happens here. It was not critical in compromising patient safety. And it was the risk has a potential to recur? No. So here what was stepping in? The impact it would cause on the
future of the reputation of the laboratory. Here, reputation of the laboratory was at stake, not the patient's life. So that was the determining point. So next quantification is SRSS technique, that is square root of sum of squares. So we take the S, O and D, that is the here, the likelihood of occurring, that is the how many times the frequency of is occurring, severity and the detectability. We square them, we add them, sum of squares, and we then get a square root of the entire thing. There we were multiplying it. S, O and D were multiplied in RPN. But here in SRSS, what we are doing? First we are taking the square of S, O and D, we are adding them, and then we are doing a square root. So what happens in this? What is the, how it has got a potential advantage is basically by squaring of the individual components, we are actually amplifying the influence of the elevated L, S and D on the final risk score. So it is potentially mitigating the masking effect observed in multiplication. In multiplication, when all three were multiplied, even if one component was low and the other component was high, two risks could have the same RPN number. But here, because we are individually squaring up, so individual weightages comes into the consideration. And secondly, because it is squaring of three parameters, it looks something like a calculation of vector, X, Y, and Z axis of the vectors. So what they say, it gives a magnitude in three-dimensional space, and its analogy is representing the risk as a vector with components corresponding to L, S, and D. Why like vector? Just as a vector has directions X, Y, and Z, here we have a clear-cut direction. Which one is high? Is L high? That is likelihood of the event occurring. Is S high? Severity of the event. Or D, detectability of the event. All three are defined. So that is why it is giving a vector-like assessment. But what are the limitations? First of all, as we are all extremely good in mathematics computation, we all are very good. So what happens? So the square root of the square root operation makes it slightly more difficult for us. S multiplying three things, S into O into D is quite simple. We can do it in our laboratory without any high-end computational device. But when it comes to square root, squaring and square root, we need a calculator for doing it. We cannot do it orally. Okay? That is one thing. Secondly, the interpretation is difficult by our laboratory personnel. Because as I told you, all of us are extremely good in mathematics. So it becomes very difficult for them to interpret the three dimensions. Okay? So that is one shortcoming or limitation of the SRSS method. What are the advanced quantitative risk assessment approaches? We don't really use them on day-to-day basis in our laboratories. What are they? Probabilistic risk assessment, which we call the PRA, probability distribution. Second is QRA and statistical process control. Bayesian statistical methods, Monte Carlo simulations. Out of this Bayesian statistical method and Monte Carlo simulation, these two are utilized by high-end laboratories for machine learning. The data that is being generated by our laboratories, that data is utilized by the Monte Carlo simulation and Bayesian statistical methods and fed into the machine for making predictive analysis of risk scenario. So now out of these three quantitative methods, that is risk matrix, RPN and SRSS, whom or which one shall we choose? So for choosing this, we should know what should be the basis, what should we consider. First is complexity versus practicality.
SRSS, PRA, QRA, Bayesian, they are in-depth risk quantification, but they are too complex on a daily basis for us to understand. So for us, we would choose something more simple, that is risk matrix or RPN. Next is data availability. So whatever data is available to us, it should align with the calculation that we want to make. The RPN and risk matrix, the data, we don't need much data for it, but for these like SRSS, PRA, QRA, we require advanced quantitative, a lot of data for it, and that is why these are not really doable in our laboratories. Purpose of the assessment. If you are doing just for understanding what is the number of risk or the occurrence of a particular risk in our laboratories, just for daily monitoring and for making risk mitigation strategies, then RPN and risk matrix is fine. But if we are doing it for higher decision making, like fund allocation, like making protocols, and for making SOPs in the laboratory, then we go for the higher end one for the like process level risk, etc. Then we choose the SRSS method or the Bayesian analysis or the Monte Carlo simulation methods. Then expertise and resources. Of course, I believe this is the most important point defining the method that we are going to choose. Expertise. For all this quantification, we need high-end mathematical knowledge, which of course is sadly lacking in all of us. How much ever AI we use, we are not really comfortable with high-end mathematics. 1. 2, expertise is lacking and resources. Most of us, we cannot really open our laptops in our laboratory. The central laboratory, if you visited, do we have a space where we can sit and open our laptop and do this data feeding? We can't. So, expertise and resources. I think it is the most important parameter which decides which method we are going to take up. Coming to AI-driven risk assessment. AI is utilized in a big way, as you've seen from the morning, for quality management and for error detection. Even for risk assessment, AI is used for what? When we are doing manually, it is a time to time. But if we integrate it into an AI algorithm, there will be a continuous monitoring and alerts. Again, AI, as I told you, can be utilized for data integration and for calculations of the risk quantification numbers. Secondly, scenario modeling, as I told you, probabilistic techniques like Monte Carlo simulations are now utilized to model risk scenarios so that we can plan risk mitigation, risk management protocols. Now, related concepts, AIRA, that is, you should know this terminology, is IRA. IRA is for AI-based risk assessment tools. AIIA, AI-based impact assessment. AIRM, AI-based risk management. So IRA is basically utilized in a big way in European countries, in UK and also in USA for the design, development and deployment of AI technologies. Now the AI standards, as I told you, as you all have been hearing, it is still under development. What are the documents that are being developed? One is ISO IEC 23894 for AI and risk management. ISO IEC 42001 for AI management systems. ISO IEC 38507, that is one governance implications of the use of AI in organizations. And IEEE documents, that is recommended practice for organizational governance of AI. Remember, none of these documents have been implemented. They are still in the process of drafting. None of these have been implemented as. So I just remembered these 4 lines, which was given by the ex-head of the Department of Clinical Laboratory of CMC Vellore, Dr. Selva Kumar, he had told me what moves needs to be trained, that is the staff. What does not move needs to be calibrated, the instruments. What happens needs to be documented, that is the process. And what is not documented never happens. Thank you.
Thank you, ma'am. Any question?
Yes.
Any question? This one you want?
I'll share the slide, you take it. I mean, I'll give it to Dr. Dipajyoti, he will share it in the...
These sessions will be recorded. They are recorded and they will be uploaded. So you can revisit anytime.
Now, Dr. Now I would like to invite Dr. Durvashri Das to felicitate Dr. Bulbul Purkait ma'am. Now heading to next session, I am inviting Professor Dr. Soma Gupta to deliver her talks on next topic, competency-based GCLP training, NMC curriculum, digital learning and simulation-based education.
Oh, good afternoon. I am also in a hurry. I have to go to home also. So I'll finish it very early. I won't show all the slides because this thing is yet to be implemented. So this is competency-based GCLP training. This thing will come in future, though it is in the process of pilot, as a pilot project this is running. Why? Because it is seen that 75,000 MBBS graduate per year, but 68% gap have been identified in current lab training. So NMC has mandated that by 2030, there should be GCLP training across all MBBS phases, and this has been mandated by WHO also. So what is the plan? Plan is by 2026, there will be pilot project running in 10 national medical college. By 28, it will cover 50% NMC approved medical college, and by 30, it will be covering all the NMC approved medical college. Oh, sorry. So again, this we all know that there are three domains: cognitive domain, psychomotor domain, and affective domain, where all the subjects has been the core architecture of the NMC competency-based medical curriculum has been theorized, and along all the domains will be covered for the GCLP training. And then Miller's pyramid will be used for competency assessment. So you see that the nose level will be assessed by MCQ and short answer question. Nose how will be assessed by scenario-based assessment and case studies, which we are already doing. Shows how will be assessed by simulation and OSCE, and DAOs will be by words settings, and it will be by workplace-based assessment, DOPS, all these things. So just like the RBCW training, what you have gone through, this is compliant with this GCLP. So curriculum mapping is like this. Total mapped GCLP training hours across the MBBS program is given as 330 hours. Everything has been mapped and has been put across the whole 5.5 years of training of MBBS, that is including the internship. Now, along with the MBBS curriculum, the digital learning platform has already also been implemented, and the course curriculum has already been started uploading. It is in the learning management system platform, in the virtual lab platform, then in mobile learning, video resources, AI powered tools, everything is there in digital learning system. And the learning model is 70%, 20%, 10%. 70% is learning by doing, that is hands-on training. 20% is by social learning, and only 10% has been allotted for the lectures, like not like we are doing today. So these are different national digital platforms, Shayon, Diksha, and institutional LMS model. So these things are supposed to help the students for the learning system. I am skipping all these things. And then simulation spectrum in GCLP training is also important. There are different. What is simulation spectrum? The degree to which the simulated experience replicates the real clinical reality. So here there are different types of fidelity: low fidelity, medium fidelity, high fidelity. Now it is not that the always high fidelity is good. If I want to train a student for repetitive skills training, so that they can learn how to draw blood, then we have to take IV arm, not a high fidelity instrument like full patient simulator. So what is your learning objective? The simulation should align with that. So I am not using all these things. We know the competency-based assessment tool, and these are OSCE designed for GCLP, which has been done. Total circuit time has been defined 46 minutes across 6 stations. These will be implemented soon. We are not training MBBS student with blood specimen collection, but it is coming very recently. So portfolio should be prepared. These are the stakeholders for GCLP implementation, and there are many challenges and strategic solutions to be worked out accordingly. Different institutions are having their own problems, and they have to take out their own solution. So the future of medical excellence begins with the quality of training today. Thank you.
Thank you, ma'am. Now we are due to shortage of time. We are concluding our session, today's session, announcing now a vote of thanks is all about closing to the event on a high, grateful and organized note. So I am inviting Dr. R.N. Mahanti sir to conclude the session.
Good afternoon, everybody. So, at the end of 2 days, great academic feast, it is customary to give vote of thanks to everybody for your active participation in today's long this academic feast. And this program has already been announced that it has been organized by the Department of Pharmacology, MIdnapore Medical College, and with the active initiation and active inspiration from our Honorable Principal Madam, Professor Soma Gupta Madam, and our faculties and students, staffs, all have actively participated and contributed to this, to contribute to make it successful. So I give thanks to everybody for their active participation. I welcome, and again I wish that they will come in the next session also, and we expect that more participation will be there in the next sessions. Thank you all for your active participation, and after that we will give the certificate and then we will close our program of this session.
Please submit your post-test and feedback, link provided in the group.
The link has been given to your WhatsApp. Otherwise, you just scan it.
For online candidates, there are about 250 number of candidates still present. I am asking them to submit the post-test and feedback form. These are mandatory for certification. Your certificates will be provided in the group after 25th of June. Thank you. I am calling your names for offline candidates. Please come forward one by one, sign it, and take your certificate of credit hours. First name, serial number 1, Orgodip Saw. Dr. Sima Dash, Dr. Sima Dash, Dr. Nilanjan Chando, Dr. Biplab Kumar Gayen, Dr. Sudipto Chatterjee, Dr. Utpal Majumdar, Dr. Prapti Sarkar, serial number 8.
Serial number 8, Prapti Sarkar. Serial number 8, Prapti Sarkar.
Serial number 10, Dr. Devashish Bhar, Dr. Kollan Mondal,
Ten.
serial number 11, Dr. Kollan Mondal,
Serial number 11, Kollan Mondal.
Serial number 12, Soumodip Mahapatra.
Soumodip Mahapatra.
13, Shopnodip Botobel. Serial number 13. Serial number 14, Shubhajit Datta. Serial number 14, Shubhajit Datta. Serial number 4, Biplab Kumar Gayan. Serial number 17, Jayashree Sarkar. Serial number 18, Chayan Ghorai. Serial number 19, Abhishek Mukherjee. Serial number 20, Dr. Durga Pada Dolai. Serial number 21, Orpita Mondal. Dr. Orpita Mondal. 22, Sumon Mondal. 23, Dr. Sukarna Mondal. 24, Dr. Ayan Ghosh. 25, Yaken Bati. 26. 26, Anirban De. 27, Rupok Maiti. 29, Dr. Rajashri Mondal. 30, Bodupolli Venkata Vijaya Babu. 31, Jhinuk Das. 34, Orkapo Pal. 33 নিয়ে গেছে। 33 নিয়ে চলে গেছে।
34.
35.
35, Sneha Nandi.
Sneha Mandi.
Sneha Mandi. 36, Sampiti Pandit. 37, Himadri Shekhar. Kundu. 38 Anup Sharma, 39 Sanjula Singh, 39 Sanjula Singh, 40 Jaswant Jaisankar, 47 Bulmana Deja, Kya Mukherjee, Pumar Dasari, Ajay Veer, Soma Sarkar, Nandala Shobhi, Devanjoti, Durvas, Sayantan Jana Hajra, सब फैकल्टी बस बड़ा बस समाप्त हो चट्टोपाध्याय और क्या बाकी क्या है बलराम दास
65 Balaram Das, 66 Kaushik Das, 67 Kaustav Mondal.
67 Kaustav Mondal.
Those